सबको मेरा नमस्कार, गुड मॉर्निंग। मैं हिंदी में बात करूंगा। आई थिंक कि जो फॉरेन के डेलीगेट्स हैं मेरी बात समझने की कोशिश करेंगे। सबसे पहले ऑर्गेनाइजर्स को धन्यवाद, थैंक्स कि उन्होंने इस मीटिंग का, इस सेमिनार का आयोजन किया यहाँ पर। मैं विशेषकर डॉक्टर अशोक गुप्ता व उनकी टीम का आभार व्यक्त करूँगा कि आपने इंटरनेशनल कॉन्फ्रेंस ऑफ बर्थ डिफेक्ट का जो ये 6th चैप्टर है उसको यहाँ पर ऑर्गेनाइज किया। मैं मर्ड इंडिया बेसिक रूप से जो मेटाबॉलिक एरर एंड रेयर डिजीज ऑर्गेनाइजेशन के लिए स्टैंड करता है उसका फाउंडर हूँ। यह एक पेरेंट सपोर्ट ग्रुप है। दिस इज द पेरेंट सपोर्ट ग्रुप। द मेन वर्क इज कैंपेन फॉर न्यूबॉर्न स्क्रीनिंग इन इंडिया विच इज द ट्रीटेबल डिसऑर्डर्स, अवेयरनेस फॉर इनबॉर्न एरर ऑफ मेटाबॉलिज्म एंड प्रोवाइड इंफॉर्मेटिव एंड मोरल सपोर्ट टू पेरेंट्स। जो आज की सीएमए में मुझे जो विषय दिया गया है वो है रेयर डिजीज एडवोकेसी, रोल ऑफ पेरेंट सपोर्ट ग्रुप एंड हाउ वी कैन एम्पावर द पेरेंट्स एंड पेशेंट्स। इट इज़ क्वाइट पॉसिबल कि आप मेरे तर्कों या विचारों से सहमत न हो, लेकिन उसे ध्यानपूर्वक जरूर सुनना चाहेंगे। 2 दिन से जो कॉन्फ्रेंस का सब्जेक्ट चला आ रहा है रेयर डिजीज। इफ पेरेंट पॉइंट ऑफ व्यू से देखा जाए व्हाट इज द रेयर डिजीज, तो अगर हम उसे सिंप्लीफाई करें रेयर डिजीज को, तो वो जो मोस्टली जीन, क्रोमोसोम या डीएनए में पैदा हुई असमानता के कारण होती है, जिसमें मोस्ट ऑफ द डिजीज इनहेरिटेड होती हैं। अगर हम इसको और इजी वे में बोलें, एज ए पेरेंट को हम किस तरह से समझाएंगे, पेशेंट को हम किस तरह से डिस्क्राइब करेंगे, तो आबादी में पॉपुलेशन में कभी कभार पाए जाने वाली डिजीज़, रोगों से पीड़ित लोगों की संख्या, कितना इस लोगों की संख्या है। WHO क्या कहता है? WHO कहता है कि अगर 6.5 to 10 आउट ऑफ 10,000 अगर पॉपुलेशन में लोग हैं तो वो रेयर डिजीज से सफर्ड हैं। इंडिया के अंदर 1 आउट ऑफ द 5,000 डिजीज से अगर लोग हैं तो उसे रेयर डिजीज में गिना जाता है। इसमें मैं एक बात जोड़ना चाहूँगा कि विच डिजीज इज 1,000, lakhs or many thousand for one in doctors or medical fraternity, which parent face or patient face, it's उसके लिए भी ये लाखों में एक है, उसका बच्चा भी वो लाखों में एक है उसके लिए। जैसा कि पूरी कॉन्फ्रेंस में कल भी बताया गया कि 7,000 से अधिक डिजीज़ हैं, 72% जेनेटिक कॉज इसका होता है। जो मोस्ट इम्पॉर्टेंट बात है, इट्स अफेक्ट 50% ऑफ चिल्ड्रन and most of 30% of neonatal age, means 30 days से कम पाए जाने वाले बच्चों में ये रेयर डिजीज अफेक्ट करती है। और ये इन इंडिया, इन आवर नेशन, 7 to 8 years कीप डायग्नोज टू रेयर डिजीज, इट्स रेयर डिजीज। अगर हम अपने देश की, इन इंडिया की बात करें तो 24 मिलियन बर्थ डिफेक्ट इन एवरी ईयर। एंड बर्थ डिफेक्ट की बात करें विच इज़ 6 आउट ऑफ 100, हर 100 में से 6 बच्चा बर्थ डिफेक्ट लेकर पैदा होता है। उसमें मोस्टली 4 डिजीज रेयर डिजीज होती हैं। इसी अवेयरनेस हेतु हम लोग 28 फरवरी का जो लास्ट डे है, 29 फरवरी आता है और कई बार 28 फरवरी आता है, हम रेयर डिजीज डे अवेयरनेस के लिए मार्क करते हैं। What is the question in all this meeting, all this seminar? What is the first question? If you summarize this, क्या हम इन सफरर को करेक्ट डायग्नोस प्रोवाइड करा सकते हैं? क्या हम इन्हें करेक्ट ट्रीटमेंट दे सकते हैं? क्या हम इन्हें प्रिवेंशन दे सकते हैं? क्या हम इन्हें नॉर्मल लाइफ दे सकते हैं? कैन वी गिव करेक्ट डायग्नोस, करेक्ट ट्रीटमेंट, नॉर्मल लाइफ, एंड व्हाट इज द प्रिवेंशन? I think if we summarize all of this, this is the main question. What is the prevention? What is the correct diagnosis? What is the normal life? That come our role, parent support और NGO roles come out, कि हम इन families और sufferer को किस तरह से सहयोग दे सकते हैं, किस तरह से हम इन्हें empower कर सकते हैं। तो in Indian democracy we have 4 pillars. Also in rare disease we have 4 pillars. First, awareness. Second is advocacy. Third is provide support. And fourth is next जो stakeholders हैं उनके साथ में collaboration. मैं इसलिए यहाँ पर खड़ा हूँ कि हमारा कोलैबोरेशन है कि जहाँ पर भी इस तरह की मीटिंग्स होंगी हम वहाँ पर जरूर अपनी बात रखना चाहेंगे। इफ़ वी टॉक अबाउट अवेयरनेस, तो फर्स्ट अवेयरनेस कम आउट फ्रॉम चाइल्ड केयर क्लिनिक्स, हॉस्पिटल्स, राउंड टेबल डिस्कशन in Indian scenario, Anganwadis, panchayats, college, schools, we go to media, we go to governments, we go to community centers. What is the rare disease? Second part of the advocacy. So we go to gynecologist. Please listen this very carefully. Gynecology is the first part to convey parents if she come out इफ़ इन एनी फैमिली, किसी भी फैमिली के अंदर कोई रेयर डिजीज़ का बच्चा सफ़र कर रहा है, एक्सपायर कर चुका है या उस कम्युनिटी में कोई डिसऑर्डर, तो गायनेकोलॉजिस्ट को इन्फॉर्म करना चाहिए चाइल्ड केयर डॉक्टर को कि अगर कोई बच्चा नेक्स्ट फैमिली में पैदा होता है, उसका कोई प्रिवेंशन है, उसका कोई एंटीनेटल है, उसका कोई पोस्टनेटल है, न्यूबॉर्न स्क्रीनिंग है। सेकेंड, डॉक्टर कम्युनिटी, बिकॉज मोस्ट ऑफ द रेयर डिजीज़ कम फ्रॉम इन्फेक्शंस, कि बच्चा डेवलपमेंट डिले हो रहा है, बच्चा सेप्टिक करके आ रहा है, बच्चा इन्फेक्शंस लेकर आ रहा है, बच्चा ठीक से बात नहीं कर पा रहा है, इट मे बी रेयर डिजीज़। वी गो टू पॉलिसी मेकर्स, बिकॉज बहुत सारी पॉलिसीज़ इंडिया के अंदर बनी हैं और मैं आप सब लोगों को बताना चाहूँगा कि गवर्नमेंट ऑफ इंडिया ने 2021 के अंदर रेयर डिजीज़ पॉलिसी को इम्प्लांट किया है और 12 सेंटर ऑफ एक्सीलेंस, 12 सेंटर ऑफ एक्सीलेंस ऑल ओवर इंडिया वर्क फॉर रेयर डिजीज सेंटर्स। इन राजस्थान एम्स जोधपुर रेयर डिजीज सेंटर के रूप में काम कर रहा है। वी गो टू कॉर्पोरेट्स, इट्स माई सिंपल सजेशन टू ऑल, गो टू कॉर्पोरेट्स एंड आस्क हिम टू टेक वन डिजीज फॉर CSR। अगर कोई भी कॉर्पोरेट एक डिजीज CSR के लिए ले लेता है तो हम जिन 7000 डिजीज की बात कर रहे हैं, मैं इसमें एक बात और क्लियर करना चाहूँगा कि इन इंडियन सिनेरियो ओनली 350 डिजीज डायग्नोस्ड and we have only 500 drugs in Indian scenario. So we can ask only 350 diseases, not 7,000 diseases. 7,000 diseases in all over nation, all over world. In Indian scenario, only 350 diseases diagnosed, and we have only treatment of 500 drugs. So हमें corporate के पास जाना चाहिए कि CSR के तहत आप इन बच्चों को गोद लीजिए और उनका ट्रीटमेंट कराइए। हमें ब्रांड एम्बेसडर को इस्टेब्लिश करना होगा। जिस तरह से अमिताभ बच्चन पोलियो ड्रॉप के लिए कि हर संडे को पोलियो ड्रॉप पिलाना है, उसी तरह से अगर हम ब्रांड एम्बेसडर बनाएंगे तो अगर मैं इंडिया की आपको बात करूं तो मिस्टर अरुण शौरी का जो बच्चा है वो DMD से ग्रसित है। अभी जो हमारे CAG रह चुके हैं न्यायाधीश चंद्रचूड़, उनकी दोनों बेटियां भी रेयर डिजीज से ग्रसित है। तो अगर हम इस तरह से ब्रांड एम्बेसडर को अगर कैंपेन करेंगे तो हम शायद इन बच्चों के साथ, इन फैमिली के साथ ज़्यादा जस्टिस कर सकते हैं। थर्ड पॉइंट इज द अन्य स्टेक होल्डर के साथ जोड़ना। जैसा मैं आपको बता चुका हूँ कि इस कॉन्फ्रेंस में हमारा आने का उद्देश्य इतना सा है कि हम आपकी बात को सुन सकें, अपने मिशन को आपसे शेयर कर सकें, आपके मिशन की बात सुन सकें। तो मैं इसमें आपको बताना चाहूँगा कि पूरे इंडिया के अंदर 49 सपोर्ट ग्रुप जो हैं वो रेयर डिजीज़ के लिए काम कर रहे हैं, NGOs, और 250 सपोर्ट ग्रुप या NGO पूरे वर्ल्ड के अंदर रेयर डिजीज़ के लिए काम कर रहे हैं। अगर मैं इंडिया की बात करूं तो ORD इंडिया, रेड सिंड्रोम, बाहर की बात करूं तो सेव बेबी सेव, मार्च ऑफ डाइम्स, UMDF, ये ऐसी नामी संस्थाएं हैं जो रेयर डिजीज़ के लिए लगातार काम कर रही हैं। हमें भी उनकी कार्यशैली, उनका वर्क स्टाइल, उनका मिशन में उनका सपोर्ट करना है और सपोर्ट लेना है। मैं अगर महात्मा गांधी की बात करूं तो यहाँ पर डॉक्टर प्रिया मारवा यहाँ पर हैं, डॉक्टर रचना रायण के साथ मिलकर वो थैलीसीमिया के लिए बहुत ही अच्छा काम कर रही हैं। और मैंने अभी उनसे पूछा तो उन्होंने बताया कि 200 से ज़्यादा वो BMT कर चुकी हैं। तो अगर 200 से ज़्यादा BMT कर चुकी हैं तो रेयर डिजीज़ के बच्चे भी लीवर ट्रांसप्लांट कर सकते हैं, हम उनका जीन थेरेपी कर सकते हैं, हम उनकी जीन एडिटिंग कर सकते हैं। तो प्लीज़ कम फॉरवर्ड। और यहाँ पर एक कविता केयर सेंटर है जो भी सेंटर ललित मोहन शर्मा जी के साथ मिलकर काफ़ी अच्छा काम कर रहा है। एंड नाउ द कम टू द आवर स्ट्रॉन्ग पॉइंट, हाउ वी प्रोवाइड टू सपोर्ट टू पेरेंट्स, कैसे हम उन्हें एम्पावर करते हैं, सपोर्ट देते हैं। तो सबसे फर्स्ट ऑफ द वी हम लोग जो उनको सपोर्ट करते हैं, सपोर्टिव केयर में उनकी मदद करते हैं. वी हेल्प टू टेक सपोर्टिव केयर. वी कनेक्ट टू राइट डॉक्टर. द इम्पॉर्टेंट पॉइंट इज अ राइट डॉक्टर, बिकॉज मैनी ऑफ रेयर डिजीज इज मिसडायग्नोज, और कई बार फैमिलीज या बच्चे सही डॉक्टर्स तक नहीं पहुंच पाते हैं. मैं बता चुका हूं कि इंडिया के अंदर 24 मिलियन बर्थ जन्म लेती हैं हर साल, और उसमें हम लोग रेयर डिजीज मानते हैं कि अराउंड 15 to 20 lakhs बेबी बॉर्न विद रेयर डिजीज इन इंडियन सिनारियो. सो सही डॉक्टर मिलना बहुत ज़्यादा ज़रूरी है, और हमारा रोल वहीं से चालू होता है कि सही डॉक्टर से हम उन्हें कैसे कनेक्ट करा सकें. प्रोवाइड अपडेट्स, किस तरह की रिसर्च हो रही है, कोई कहीं पर कोई क्लिनिकल ट्रायल हो रहा है, कहीं पर कोई जीन थेरेपी हो रही है, जीन एडिटिंग हो रही है, कहीं पर कहीं कोई ड्रग का नया मिल रही है, तो हम इस तरह की अपडेट उनको प्रोवाइड कराते हैं. गवर्नमेंट इनिशिएटिव के बारे में बताना, मैं आपको बता चुका हूं कि गवर्नमेंट ऑफ इंडिया ने रेयर डिजीज पॉलिसी को लॉन्च किया है. 12 सेंटर ऑफ एक्सीलेंस पूरे इंडिया के अंदर काम कर रहे हैं, और हम पेरेंट्स को इन्फॉर्म करते हैं, हम डॉक्टर्स को इन्फॉर्म करते हैं, हम तरह तरह के कैंपेन चलाते हैं कि अब रेयर डिजीज का इलाज भी चालू हो चुका है. मूवीज़ की बात करें तो इंडिया में कई मूवीज़ बनी हैं, जिसमें प्रोजेरिया रेयर डिजीज, जिसमें हमारे अमिताभ बच्चन ने काम किया था. हिचकी पिक्चर, टॉयराइड सिंड्रोम, जिसके अंदर रानी मुखर्जी ने काम किया था. तारे जमी पर आप सब लोग जानते हैं डायस्किक्सिया रेयर डिजीज़ थी. बर्फी के अंदर प्रियंका चोपड़ा ने जो ऑटिज्म को लेकर डिजीज़ थी. द स्काई इज़ पिंक स्किट को लेकर थी. और अभी एक जो मूवी आई है, मैं चाहूँगा आप सब लोग देखें उसे, श्रीकांत, जो विजुअली एम्पायर को लेकर आई है, और उसमें राजकुमार राव ने कमाल का रोल किया है. मैं आप सब लोगों से अपील करूँगा कि उस पिक्चर को आप ज़रूर देखें. अब हमें नीड क्या है, अब अगर हम इस पूरी कॉन्फ्रेंस की एक नीड बताएं कि व्हाट इज़ द नीड ऑफ रेयर डिजीज पेशेंट और रेयर डिजीज फैमिली. फर्स्ट ऑफ थिंग, ऑन इंडियन सिनेरियो वी वांट जेनेटिक इंश्योरेंस. जो बच्चे आ चुके हैं, जो फैमिली सफ़र कर रही हैं, हम उनकी बात नहीं करेंगे, उन्हें जिस तरह का ट्रीटमेंट, लेकिन एट द टाइम ऑफ प्रेगनेंसी अगर आप उन्हें जेनेटिक इंश्योरेंस प्रोवाइड करते हैं, तो हम लोग इन रेयर डिजीज बच्चों के साथ में न्याय कर सकते हैं. हमें टीम वर्क की ज़रूरत है. इफ़ वी वांट टू tackle rare disease family and patient, we want to treat rare disease family and patient in the right way, please come out with teamwork. Start from gynecologist and the genetic expert is the actual teamwork. माराडोना और विराट कोहली कभी भी एक शतक लगाकर पूरी टीम को नहीं जिता सकता है जब तक उसे 10 आदमियों का साथ नहीं मिले. माराडोना ने भी कभी भी वो हैंड्स ऑफ गॉड गोल नहीं किया था जब तक उसे उस 10 आदमियों का साथ नहीं मिला था. तो प्लीज स्टार्ट विथ टीम वर्क, प्लीज स्टार्ट विथ कम्युनिकेशन और ईच अदर. दैट्स देन वी कैन justify the rare disease family and patient. Drug development, another thing, third point is the drug development. Please start with drug. Indian drugs, मैं एक सिंपल आपको एक एग्जांपल दूंगा. जिस तरह से हम एक कॉमन कोल्ड के लिए हम लोग एक एलिग्रा लेते हैं, लेकिन एविल भी उतना ही अच्छा काम करती है. एलिग्रा को हम 3 रुपए की लेते हैं, लेकिन एविल भी 25 पैसे के अंदर उतना ही अच्छा काम करती है. तो अगर हम इंडियन ड्रग को डेवलपमेंट करेंगे, बाहर के लोगों से कोलैबोरेट करके हम ड्रग को यहाँ मंगवाएंगे, तो हम रेयर डिजीज़ फैमिली को जस्टिस दे सकते हैं. हमें रेयर डिजीज़ क्लिनिक स्टार्ट है. मैं एमजी हॉस्पिटल से अपील करना चाहूँगा कि यहाँ पर रेयर डिजीज़ क्लिनिक स्टार्ट किया जाए, और मुझे पूरा विश्वास है कि डॉक्टर अशोक गुप्ता के आप नेतृत्व के अंदर रेयर डिजीज़ क्लिनिक यहाँ पर स्टार्ट करेंगे. सीओ सेंटर ऑफ एक्सीलेंस को व्यवहारिक प्रैक्टिकल करने की. मोस्ट ऑफ द डॉक्टर्स, मोस्ट ऑफ द रेजिडेंट्स, मोस्ट ऑफ द क्लिनिशियन डोंट नो अबाउट द सेंटर ऑफ एक्सीलेंस. तो उन्हें भी इसके बारे में आईएपी को, एनएनएफ को जानकारी होनी चाहिए कि इस तरह से सेंटर ऑफ एक्सीलेंस काम कर रहे हैं. एंड द एक्चुअल पार्ट व्हाट आई वांट टू से एंड अपील, प्लीज इन एवरी चाइल्ड केयर सेंटर इम्प्लांट यूनिवर्सल न्यूबॉर्न स्क्रीनिंग. बिकॉज मैं कुछ आपको डेटा देना चाहूँगा. इन 24 मिलियन बर्थ, इन 18 lakhs बर्थ, इन इंडियन सिनेरियो 4 to 6 lakhs neonatal death in 30 days age. 5 to 8 lakhs baby can't see their first birthday, and 13 to 15 lakh children cannot see their 5th birthday. The most of the cause is the rare diseases. So please start universal pneumo screening, which is a treatable. Please start high risk family if baby is sick in NICU, if baby is high-risk family, is family suffering from some another rare disease, please start newborn screening in place. एंड मेरा एक और सजेशन आप सब लोगों को है, प्लीज़ आप इससे गवर्नमेंट ऑफ इंडिया और गवर्नमेंट ऑफ स्टेट तक पहुँचाइए कि रेयर डिजीज सेस को लागू करिए. एवरी 1000 रुपीज़ बिल टेक 1 रुपीज़ फॉर रेयर डिजीज सेस. हमें किसी भी फंड की जरूरत नहीं है, इतना फंड इंडिया के अंदर आ जाएगा कि हम इन बच्चों का बहुत अच्छे से इलाज कर सकते हैं. एट लास्ट मैं वापस से इस स्मॉल गैदरिंग को धन्यवाद देना चाहूँगा, और कि आपने मुझे नॉन मेडिकल होते हुए भी मुझे मेरी बात कहने का अवसर दिया. और मैं एक छोटी सी कविता के रूप में अपनी बात को ख़त्म करूँगा कि आओ दुर्लभ लोगों के लिए हम एक हो जाएं, सब मिलकर ये शपथ उठाएं, इन रोगों की जागरूकता फैलाएं, सही निदान और उपचार दिलाएं, रहती इनकी कश्ती हमेशा भंवर में, आओ हम सब मिलकर इनको किनारे पहुंचाएं. बहुत बहुत धन्यवाद.
Thank you so much, sir, for sharing your valuable knowledge and data and how to proceed with a case of birth defects in such a simplified manner. Without further ado, it's my honor to welcome our respected chairpersons on the dais for today's first session. I welcome Professor Dhavendra Kumar, sir, Genomic Medicine Foundation, UK, Honorary Professor William Harvey Heart Research Institute, QMUL London, UK, Apollo Hospital, Bangalore. Dr. Monish Suri, sir, Consultant Clinical Geneticist, Nottingham University Hospitals, UK, and Professor Pradeep Vasudevan, Consultant and Honorable Professor, Department of Clinical Genetics, University of Leicester, UK. Before calling the first speaker, I would like to invite Dr. Dhavendra sir to felicitate Dr. Vikas sir. Please, I invite Dr. Vikas sir to come on the stage. Yes. I now invite our first speaker, Dr. Priya Ranganath, Consultant Medical Genetist, Apollo Hospital, Bangalore, for her insight on topic multidisciplinary care for epigenetic diseases.
Good morning, everyone. We have a very small niche audience, so please feel free to kind of ask me anything, stop me in middle, anything required. I'd like to thank the ICBD organization for calling me here to present a talk on multidisciplinary care. There's, I hope, much we can do in terms of multidisciplinary care, but I think we're severely lacking in many of the things. Rare diseases as such require a lot of support systems. I think it's upon us to kind of create those systems for many of our patients. So without further ado, I think the audience is not new to the topic of genomic imprinting. So it's a genetic phenomena where gene is expressed based on the parent it is inherited from. That's why we call it the parent of origin effect. Now, it's an epigenetic phenomena. So the regulation is always mediated by something called DNA methylation, histone modification, chromosomal organization, and so on. Now, there are very specific imprinted genes that we know of as such. There are probably more that we don't know about. And these are controlled by imprint control region or differentially methylated regions. And imprinted gene exists generally, so far that we know in knowledge of, as clusters, and each cluster has its own ICR. And approximately 100 to 150 genes are known. And this is like an overview of how the genes would look like. So many imprinting clusters which are located across the chromosomes. And these clusters are controlled by the imprint control regions. So as we were referring to, the DNA methylation is one of the initial modifications that lead to imprinting. So it is a process by which methylation groups are transferred onto that 5' position of a cytosine molecule, and this commonly found around the CPG islands. This is one way to modify or to imprint a gene. The other ways are, of course, histone modifications. This would be a post-translational modification, where the N-terminal tails of the histone, they undergo either acetylation, methylation, and so on, phosphorylation, and so on, so causing changes in chromatin structures. And they can also include changes within the nucleosome position, which causes nucleosomal sliding, and that can then lead to the process of imprinting. So global epigenetic reprogramming occurs twice. I think we've understood this of late and how this happens. So generally at birth you have the sperm and egg cells with their specific imprinting marks of the male and the female that just gets laid out. And then that goes through a period of somatic maintenance where zygote, embryo, and adult maintain these epigenetic marks. Something happens during the reproductive phase where you get a germline erasure of all these imprinting marks, and then you have the primordial germ cells where these all get imprinted again. Let me show more in detail. So you have the oogenesis period, and then you have the period where it goes into a 8-cell stage to a blastocyst stage. So you have the initial demethylation that happens in the first, let me see if I can get that working. Didn't think they're powerful enough, but so you have the 8-cell stage and then the blastocyst stage. So you have the initial erasure that is happening. Then you get the paternal imprinting and the maternal imprinting. By the zygote stage, you have the one set of imprinting that happens, and then you have the maintenance and the secondary imprinting. So this is how it goes about. So you have the primordial germ cells, male germline, female, initial de-imprintation, and then the imprinting, and then a de novo methylation. Now, imprinting disorders are many times alike and many times different. So in many ways they are alike and many ways they're different. So let's kind of group them and see how best we can help them in management when we look at them as a group. So many of them have growth disturbances. Many of them have metabolic or endocrine disturbances. Some of them have neurocognitive development, psychosocial problems, behavioral problems. Some have dysmorphisms, others have very specific abdominal wall defects, and so on. Most of the times we see that the maternally expressed genes are that kind of controlling the growth and preventing an overgrowth, and the maternal ones, and the paternal ones are those that are kind of promoting growth, the IGFs and others. A fine balance between the two is absolutely necessary to hit the right growth mark, so that's where we see it. And most of them follow a pedigree like this. So only paternally imprinted, that is paternally imprinted disorder, you have only active expressed genes from that of the mother. So if you have the father transmitting the gene, that's probably not causing any disease, but you have a mother who has the similarly imprinted genes, then it causes a baby to have the imprinting disorder. So the mechanism, molecular mechanisms generally divided into these 4 groups. You have imprint region that can undergo deletion. There could be a point mutation within the imprinting region. There could be something called uniparental disomy, where both both the alleles represent that from the father or that from the mother, and then the epigenetic modifications. So we have a list of known imprinting disorders, very difficult to cover all of them within 20 minutes, but the few classical ones are something that I can speak about. Everybody knows about Prader-Willi. So Prader-Willi is involving the chromosome region 15q11.11 to 15q13. So these are generally 1 in 10,000, 1 in 30,000 birth. The three mechanisms that we spoke about that's seen in Prader-Willi is generally about 75% of them can have deletion, 20 to 30% can have uniparental disomy, and 1 to 3% can have genomic imprinting. Now, I'm not going to cover why this is important, because the testing of it matters to come to a diagnosis. I'll have a talk. The talk next to me is the one that's covering the testing. So I leave the complex issue to Dr. Ashwin. So there you have non-imprinting genes. You have a deletion, maternal UPD, and imprinting disorders. So in Prader-Willi region, the SNRP, the SNOT16, and the others, these are the ones that are kind of producing something called long non-coding RNA. The long non-coding RNA then goes about producing the effects of regular day-to-day functioning. When that is absent, especially the SNORD116, then you get the features that show about imprinting of Prader-Willi region. So this is how it is. So you have the long non-coding RNAs. So long non-coding RNAs affect by way of splice. So a splice dysregulation happens at that point, which results in abnormal presentation. So generally, the typical features are divided into stage 1, stage 2. Stage 1, during infancy, what do you see? A lot of hypotonia, sleepiness, low birth weight, failure to thrive, suckle problems, you have respiratory difficulties, subtle dysmorphism, underdeveloped sexual organs. And in stage 2, you see hyperphagia, preoccupation with food, appetite, increased appetite, very slow metabolic rate, low energy levels, delayed milestones, and emotional lability. So the management, again, could be divided into fourfold. So the initial stage, you need oxygenation, nutrition, endocrine, and behavioral or scholastic aid. So in the initial stage, you'd probably require oxygenation because there's high risk of aspiration, there's neonatal hypotonia, there's risk of respiratory distress because there's not only that there's hypotonia and respiratory muscles are not functioning, but there is also now evidence to say that there is poor regulation of respiratory effort from the hypothalamus, so there's a lot of CO2 retention, and you could have sleep apneas and others. So the second one is, of course, nutrition and growth. You would look at NG tube. Not all of them require, but many of them do. Improvement of tone, that generally goes away with time and it improves as such. And issues with hyperphagia, where you could work with a nutritionist to kind of help you through it. And the endocrine, so synthetic growth hormone in these individuals have shown a lot of improvement. There is a lot of controversy on when to kind of start this as a daily injection, but there are literature that says starting early could really help in avoiding or increasing or bettering the muscle tone and helping in the management of these children, and hormone therapy for hypogonadism. Of course, we have the behavior and scholastic aid that is required with early occupational physical speech therapy. Not all of them require it, but some of them require it. So this is the multimodal management that we see, multiple people coming together, working on one patient to help better care. Now, this is another child, 3 years old, birth history of delays, and then very happy child as such. You see microcephaly, a very prominent dysmorphology that helps us to kind of identify this disease. And of course, they have very stereotypic movements and other things. Hypotonia, non-specific hyperintensities. We had a clinical diagnosis of Angelman. We went through literature and understood how to, or which criteria, whether the criteria for Angelman diagnosis is met or not. Then order the respective test where you look at the same. So here UB3A, which is expressed from the mother, is the gene of interest. It's expressed more towards the brain, and I mean more in the brain, that particular, would probably result in ataxia and other features, and that's why it's very important to understand the mechanisms. Now here, unlike Prader-Willi, you have 65 to 70 with maternal deletion, still a large deletion, but you have only 3 to 7 which contributes to uniparental disomy. You have something called familial cases which have mutations within UBE3A gene, and this could have a higher recurrence rate, and something called 3% abnormality in ICR regions, translocations, and epigenetic disruptions. Now, we did the management in Prader-Willi. The management basis remains pretty much same except the growth hormone therapy. But here, the most important feature that most people come up with the seizure. So there are specific guidelines like valproate and benzodiazepines are most commonly very beneficial in these children. Lamotrigine could be very effective in them, so topiramate could be better effective. So understanding the seizure type and management would help in understanding this. And of course, in Angelman syndrome, now you have a lot of research being happening, a lot of ASO therapies where you're activating the paternal UBE3A to kind of help you through the process because it's just lying there. So these are the avenues that we're looking towards management of such children. Then you have Beckwith-Wiedemann syndrome. It's an imprinting disorder that generally leads to overgrowth. The aberrations is in the imprinting cluster between 11p 15.5 to 15.4, and you have 2 imprint regions here, imprint control centers. You have IC1 and IC2. They work in tandem to kind of cause this disease. So when the 4 mechanisms goes like this, whenever you have imprint control region 1, gain of methylation in IC1, you could have where there's an increased growth that's coming from the mother. So the signal from the mother is saying grow more. So because it's absent as such, so that's why there is overgrowth. Then IC2, loss of function methylation. So here there is no signal from the mother, so that causes growth more. And then you have uniparental disomy where both the alleles are from the father. And of course, you have the CDKN1C gene mutations, the subpoint mutations with high risk of recurrence. So all these contribute to that. 40% is only in the familial cases. There are certain cardinal features and clinical score. There are certain pathognomonic features which could say Beckwith-Wiedemann, like omphaloceal, you'd have placentomegaly, overgrowth at birth, there's rhinomegaly many times, and there's adrenal hyperplasias. All these could kind of point towards Beckwith-Wiedemann syndrome. Now, again, testing is a little complicated. You'd have MS-MLPA as the testing mechanism. Again, that will be covered further. Mine is more on the management. So in the management, in the neonatal period, they would require, because there's chance of hypoglycemia, hyperinsulinemia, hypothyroidism, management or anticipating this is all the treatment they require. Sometimes macroglossia may require reduction. Abdominal wall defects like omphaloceal could be repaired. Growth hormone is again very beneficial, but you also have insulin-like growth factors, IGFR2, IGFR1R, the receptor inhibitors, which are under review and maybe will have some treatment on the basis of that. Of course, here the most important issue is the pediatric onset tumors, for which you would have very good constant monitoring, and if they are kind of found, these are, if acted on early by surgical interventions and chemotherapy, they are very effective in management, and of course, behavioral and scholastic changes. Now, Russell-Silver syndrome, all of us know, but it's more complex because we know a little about the molecular mechanisms of Russell-Silver. So these involve characteristically postnatal growth failure, relative macrocephaly, protruding forehead, triangular faces, which used to be called it previously, body asymmetry, and feeding difficulties. So the molecular mechanisms here, again, you can see we know only about 60–70% of it. So loss of methylation, maternal uniparental disomy, different regions of the chromosomes, chromosomal rearrangement, and there are some unknown, Diagnosis clinically can be based on a criteria, but management again is very variable. So you have early feeding, nutritional support, which can help with gut motility, postnatal catch-up, GI issues, which most children go through during early stages, and hypoglycemia prevention, which is very important. Knowing ketone test at home, looking for hypoglycemia, immediately seeking attention in the hospital, which would be really good. And no glucagon therapy is very important here. And then surgical treatment, growth hormone-based therapy could also help. There are ones which are lesser known, like Berg-Barrel mental retardation syndrome. This is in the imprinting domain 8q24. Like other imprinting disorders, these also have developmental issues, some joint contractures, feeding difficulty, dysmorphism, molecular alteration in the KC and K9, the image syndrome where you have IUGR, metaphyseal dysplasia, adrenal hypoplasia, genitourinary abnormalities. This again involves the CDKN1C region. Then 14q region, you have the temple and Kagami-Ogata syndrome. So I just want to introduce, I think many people do know about it, but to the pediatric crowd, it would be the multilocus imprinting disorder. We've understood that imprinting is probably more complex than what we see. You could have multiple regions. So this is actually a group of patients where methylation disruptions have happened in multiple loci, like it could be one gene, the other gene, and 3 genes and 4 genes. Altogether could lead to a multilocus imprinting disorder. So now the technical challenge is how to diagnose this and then how to manage this. So this is very tricky. We have known genes with MLIDs, and this is like an upcoming topic to understand how to find an answer to. And then you have the Mendelian disorders of epigenetic machinery. It's called MDEMs. So these are not really the epigenetic marks, but they are involved in the epigenetics process. So these could also be epigenetic disorder, but they are inherited in a Mendelian fashion. So that's why they're called MDEMs. And you have a list of disorder, right, from what we initially knew as Rubinstein-Thiebaud. You had so many Kabuki syndromes. All of them have a basis to imprinting. So without much further ado, this is what a parent wants to hear from me, that we have an early diagnosis, so we'll be able to address the issues much better. So we know more about this disease now, and that's why we are in hands where we can do some treatment basis. We also can provide a framework on how to monitor them, guide them through therapies, and I can give you an important understanding of the disease, reassure that support is available. We have multiple support groups. That's why rare disease associations and forums like this really help, and tell me that there are parents who can mentor me, guide me, that support system and groups that they can find. And the baby is not just the disease, but a baby as a whole. So there's a lot of things that are still working and still wonderful about the child. So that individuality of expression is very important to understand. So thank you. Thank you for the time. I'm well within my time. So thank you. And any questions, I'm happy to take.
माइक्स का कर लीजिएगा प्लीज.
Thank you, Dr. Priya. Very clear presentation on very complex subject. These case examples are really meant for teaching purposes, and with a lot of, I think, clinical and genetic aspects. So, are there any questions for Dr. Priya on this complex subject?
Hello, sir.
I have one question. Thank you for the wonderful presentation.
Yes, sir.
I wondered, at your center, what sort of multidisciplinary setup do you have for epigenetic conditions?
So we do have support systems in the form of physiotherapy, behavioral therapy. We have a therapist in-house with Apollo who works there. And then we also have neonatal management in many cases, because all these are fed from our kind of neonatology group. So at birth, what do they manage? We have all of that, the oxygenation management. what we do lack is nutritional assistance, because many of the nutritional therapists do not know how to kind of handle these situations. So at least in my center, that's a little bit lacking. But I think we hope to do this, and patient support groups, that's something that, again, is a lot of work that's needed in India. So maybe we have for Angelman, we have for Prader-Willi, but some of the rarer ones we don't have. So that's a challenge. So these two are the challenges, and there are some frameworks that we already have in place.
Thank you.
That was a nice presentation, Priya.
Thank you, sir.
Can you tell us, do you have the ability to actually diagnose multilocus imprinting defects?
So there are now diagnostic modalities being suggested. There is a global epigenetic studies where you do, what we used to do priorly, you look at imprinting at a broad spectrum and check which locus could be imprinted, and you see the methylation reduction in these regions. These are available, but many people are working towards a kit that can identify MLIDs and say these occur together. So let's put that in a kit. Right now what we have is, if we have Beckwith-Wiedemann, we can order MSMLPA specific to Beckwith-Wiedemann. But if I want to say that's not working, that the diagnosis is unmade at that point, we'd want to check up whether other genes which occur concurrently or act concurrently with this disease can be tested. Right now it's not there, and there are people working on it to kind of get to that. This is a paper from 2023, so this was a relatively new discovery, so we will probably have more in that field with times to come.
Thank you. If there are no more questions, we can go on to the next speaker. Thanks, Priya.
Thank you so much.
Thank you, ma'am, for enlightening us on multifaceted approach on care for epigenetic diseases. We have gained so much from you. I now invite our next speaker, Dr. Kerstin Kutsche, Human Genetics Specialist, the Medical Center, Hamburg, Eppendorf, UK, Hamburg, Germany, for her presentation on functional genomics in birth defects.
Okay, slides are not visible at the moment. So I will start, of course, with I would like to thank Davendra and Monish for their kind invitation, and they brought me to India again. Thanks a lot. So today I would like to present you some data on functional genomics and how we are doing that, at least in Hamburg, in my lab. And so first, that is an introductory slide to show you what is the main interest in my lab. And the main interest is to discover novel disease genes, and that we are doing by next generation sequencing, and mainly by actually till now whole exome sequencing, while we will switch to whole genome sequencing in the near future. And of course, it's our duty to find the single pathogenic variant in a novel disease gene out of more than 20,000 sequence variants, what you identify in the exome data. And so mainly we do this by a family-based approach. So we do exome sequencing not only in the affected child, but also in the healthy parents. And then we filter the sequence variants according to the different Mendelian inheritance pattern, what you can nicely see here for de novo variants, X-chromosomal variants, or autosomal recessive variants. And then when you come up with a novel disease gene or variants in the novel disease gene, so that's not anymore working here. I cannot. Okay. So then, of course, when you have novel disease gene discovery, or at least a candidate gene, then you have to do functional studies to confirm pathogenicity of the variants in the candidate gene, and also to provide some insight into the pathomechanism. And in my group, we have plenty of biochemistry methods which we can apply to prove pathogenicity. Of course, it's not only important to find a novel candidate gene in a single patient. You have to find unrelated patients with pathogenic variants in this candidate. And we usually do this through gene matcher, because there you have the possibility to connect to worldwide scientists and medical clinical geneticists which have an interest in the same gene. So today I would like to show you two different projects. One on the left, which we already have published. It's the neurofacial skeletal syndrome with or without renal agenesis caused by biallelic variants in HS2-ST1. And I will also present you a novel case which has not been published with variants in this gene. And on the right side, you see that we have discovered a novel gene for hydrops. So I start with the HS2-ST1 gene. And here you see the phenotype of the affected patients. And you see there seems to be a facial gestalt, which is really a dysmorphism with upslanted palpebral fissures, a broad nasal tip, a wide mouth, and sometimes there are also some ear abnormalities present. And what you also see from the photos is skeletal abnormalities with kind of brachydactyly with broad fingertips and toe tips. And then they have developmental delay or intellectual disability. And what they can also have is uni or bilateral renal agenesis. So what HS2-ST1 encodes is heparan sulfate 2-O-sulfotransferase 1. So that is a protein, which is an enzyme, and this enzyme catalyzes the transfer of sulfate groups to heparan sulfate. Heparan sulfate is a glycosaminoglycan, and you see here that this glycosaminoglycan, shown in yellow, is bound to a protein, and then this is called the heparan sulfate proteoglycan. So these heparan sulfates are heavily modified. These are sugars that are modified, and the HS2-ST1 catalyzes the 2-O sulfation, which is very important for the function of the heparan sulfate. And here you can appreciate what is the function of a heparan sulfate, at least for FGF-mediated signaling. And you see that the 2-SO sulfation of heparan sulfate is especially important for binding the growth factor FGF2. And then there is a complex formed between FGF2, heparan sulfate, and the FGF receptor. And then the FGF receptor, when FGF2 is bound, dimerizes and is then important for intracellular signaling and the activation of the kinase ERK1 and 2, which is then phosphorylated. The signaling downstream of FGF2 and especially the phosphorylation of ERK. And here are immunoblots showing the phosphorylation of ERK in the upper row and the total ERK in the lower row. And when you compare the upper row, the immunoblots in the upper row of the individuals, of the patients with the controls, you immediately see that the phosphorylation of ERK is strongly reduced in the patients compared to controls. And this, of course, we have quantified. And in the quantification, you see on the left the patient phosphorylation of ERK in blue, And you see that this is reduced after 10 minutes of FGF2 treatment compared to controls in gray. And also after 20 minutes, we see a reduction in the FGF2 stimulatory activity in the patient-derived fibroblasts. So next, we thought, what will happen if we not only treat patient cells with FGF2, but we try to rescue the phenotype by adding or treatment of heparin. Heparin is another glucosaminoglycan, and we thought we could maybe rescue the phenotype by the addition of this glycosaminoglycan. And we did this, and we added heparin together with FGF2, and now you look at the response of the patient cells for phosphorylated ERK, and what you can see is that the phosphorylated ERK amount is increased in the patient cells compared to patient cells which have only treated by FGF2 and not by heparin. And so also we did here the quantification, and you can nicely see that when you add heparin and FGF2, the response is much higher compared to only FGF2 in the patient-derived cells, and they have similar amount of phosphorylated ERK compared to controls. So that is a nice possibility to show that this can rescue the phenotype. So that is a family I would like to only briefly mention to you, which came up through Dr. Shalini Nayak, she is at the Department of Medical Genetics in Manipal, and we have close connections to Manipal over 12 years. And she came up with a homozygous variant in HS2SD1, a missense variant, which was interpreted as a VUS. And you see here that are the clinical findings or the findings after autopsy in the fetus, and I've highlighted here in blue what are the overlaps to the known clinical features which we have found in another fetus in our first publication, and you already see that there's a really strong clinical overlap what have also been found before. Shalini asked me to do some functional studies to prove pathogenicity of this variant, of this particular missense variant here. And Luisa, one of my team members, was so kind to provide the first Western blot for the level of HS2SD1 in the fibroblast of the fetus, of the affected fetus on the left. And then you see for the control fibroblast on the right. And I think you can immediately see that the level of HS2SD1 is drastically reduced in the fibroblasts of the affected fetus. And by this, we can already claim that this is a pathogenic variant and causative for the severe fetal phenotype, what I show here. So the other project I would like to briefly show you is on hydrops fetalis and biallelic variants in PDCD2. And here I show you our family, which is from Hamburg. This family had 2 abortions and 2 affected fetuses with non-immune hydrops. And the routine genetic workup did not reveal any causative variant in this family. So we offered trio-exome sequencing on a research basis, and we identified compound heterozygous missense variants in PDCD2. And you see that is a proline 28 serine exchange, and the other one is an arginine 3,4 proline exchange. So we were quite unsure whether this is a cause, because this is a candidate gene and not a known disease gene. And then we, of course, used GeneMatcher, and we were quite lucky to meet Saqib Lakhani, who is caring for this family 2, and they found the same, exactly the same variant in their family, the proline 28 serine, in a homozygous state in 3 affected fetuses with hydrops. And when we saw this, we were quite sure that this gene and at least these 2 variants cause hydrops fetalis. So what is the function of PDCD2? It is an important protein involved in ribosome biogenesis. And you see on the left PDCD2 in red and US2 in US5 in blue. And these are two proteins which are in a complex and are really important for the generation of the 40S ribosomal subunit, which you can see on the right in the nucleolus. And what we could show by biochemical assays is that the two variants which we have identified, both variants interfere with the ability of PDCD2 to bind to US5, and by this we can already see and claim that these variants are very likely to be pathogenic. And then finally, we were in the lucky situation that Saqib Lakhani in his lab had the possibility to do some frog model, and they reduced the expression of PDCD2 by a morpholino-mediated knockdown, and then you can analyze the phenotype, and especially you will see now the different stages of the frog embryos, and especially the tadpole stage is very important to see a phenotype which is mimicking the human phenotype. And on the next, on my final slide, I will show you that the knockdown of PDCD2, so the reduction in the expression of PDCD2, leads to severe embryonic developmental defects in the tadpole. The gastrulation is impaired and the neurulation is impaired, and you see there is almost no, so the tadpole looks very deformed. And in addition, what you can nicely appreciate on the stage 38 tadpoles is that they develop edema. And most of these tadpoles develop edema, what is quantified on the right, and you see that over 80% of tadpoles which have a reduction in PDCD2 expression develop edema, and so this really shows, at least to us, that this mimics the human phenotype and shows that PDCD2 is really important for embryonic development and for, not only in the frog, but also in humans. So here I show you the road to success. So not, of course, for all cases and families what we are investigating, but for many. And you see how we approach this candidate gene identification through gene matcher, in silico studies, functional studies, and then hopefully to come up with a nice paper on new disease genes. And last but not least, of course, this is not my work, that's the work of my team. And I really appreciate all what they are doing. They are talented and highly motivated young scientists. And of course, I would also like to thank the collaborators on PDCD2, which was an excellent collaboration. On the left, Anne-Marie, Sapi, and François, that are the experts on ribosome biogenesis, and Emily, Weizen, Lauren, and Saqib, that are the colleagues from the Yale University School of Medicine who are caring for the second family with the PDCD2 variants. Last but not least, I would like to thank you for your attention. Thank you.
Thank you, Kirsten. That was brilliant. Any questions?
Yes, a lovely presentation. So it's always lovely to see two novel genes, one a little bit less novel than the other one. Wonderful work. So I was thinking, so your lab is so kind to offer functional testing. So now, that's wonderful. So, but I'm thinking, so at the end of the day, we need functional testing on long term. So it's more general question. So not after the paper, but of not stopping at the paper, but after that.
Yep.
So how do you envision, and that's also more a general question, how do you envision this for the future? Because we are dealing with so many genes, so many variants of unknown significance that need functional testings one way or the other. So, sort of gene matcher for functional testing, but the thing is, it's all about funding, isn't it? So I want to know what your ideas are here? Because you had lovely tests there at
Yeah,
start of the
sure.
slide.
But of course, I mean, that is actually, Bert, I think, an excellent idea that we need gene matcher for functional studies. And sometimes you meet on gene matcher, indeed, scientists who do basic science and who are the experts for the functional tests and not me. And I'm getting a lot of requests to do functional studies for a lot of variants in novel disease genes which we have published and we cannot manage, honestly. So that is really a lot of work, and you need patient material. And as you have seen, we use mostly what you know, primary fibroblasts from the patients. And of course, in some cases, it's not possible to get the skin because parents are not agreeing to a skin biopsy or the gene is not expressed in the skin. So that is really a problem. And yeah, so for the future, I think it is really a big challenge how to treat with all the WUS which we identify in the disease genes. And I have really no good idea how we can find a solution. So I'm sorry. So sometimes I really say, okay, we are doing the functional test as for Dr. Shalini in Manipal for the family, because I was really convinced that this is a variant. And I mean, if there are only a few cases published, I think it's really important to prove the pathogenicity, to publish the new cases, to see what kind of broad phenotypic spectrum we may have associated with a disease gene.
That's a lovely remark again. They're both open for adoption, both genes still. So.
Yeah, I know,
Okay.
Bert. I have to adopt so many genes.
Any other questions for Kirsten? Mina?
Thanks, Christine. Great talk. I follow on from Bert's questions. We know that functional assays appear to be more promising for single gene disorders. Great. So what are your thoughts on the key challenges on identifying and validating functional variants associated with complex diseases?
Oh, that is a very difficult question, Mina. Thank you for that, but I have to say, honestly, that I'm only the expert for monogenic disorders. Yeah. And I think for complex diseases, you can use some of the functional studies which are already established in your lab or in any other lab. But I think, I mean, in complex diseases, we sometimes came up with variants in the non-coding region. Yes. And for that, it is even more difficult to find the right functional assay, you know, to study whether a variant in a non-coding region could be causative, so, or could be at least related to the disease. So that is it more demanding, I would say.
Okay, thanks.
Kirsten, I've got a question for you. It's very basic, and that is that what exactly is the mechanism of hydrops in PDCD2? Does it interfere with lymphangiogenesis, vasculogenesis, cardiogenesis? What is it actually doing?
Yeah, we don't know. Actually, we don't know, honestly. So it is, I mean, ribosomal disorders, as you know better than me, there is, for example, the diamond blackfan anemia, which belongs to the ribosomal disorders. It's an anemia. But we have no idea whether it's a problem of the lymphatic system or of the homeostatic. I mean, we really don't know.
And there's no data from those terminated pregnancies, histology or pathology?
We have the first fetus from our family from Hamburg was investigated, so there was an autopsy, and actually there's a normal development. So the fetus looked absolutely normal, and there was only hydrops found, but no developmental abnormalities.
Thank you. Any other questions? If not, thanks, Kirsten, for an excellent talk. Oh, there's another talk, another question.
Most of your functional studies were done through Western blots or Don't you think RNA transcriptomics, like the question sir asked also, would throw more light even for the pathway analysis as to which pathway this gene is working to bring out the hydrops? Like, isn't RNA transcriptomics more efficient in probably doing functional genomics at the moment?
Yes, it could be. Because we know already that PDCD2 is involved in ribosomal biogenesis, we started with that because that was obvious, at least from our point of view. But of course, to gain more insight in which genes could be downregulated in addition to PDCD2, of course, your idea would be excellent to follow up. Thank you.
Thank you very much, Kirsten.
I must mention my deep sense of appreciation for Dr. Kirsten for explaining her topic beautifully. And ma'am, you look so pretty in this Indian dress. Thank you, ma'am. Now let us all welcome our next speaker, who would be joining online, Dr. Ashwin Dalal, Head Diagnostic Division, Center for DNA Fingerprinting and Diagnostics, Hyderabad, to present his topic on lab diagnosis of epigenetic disorders. Can we please connect to Dr. Ashwin Dalal?
Is this live or recorded?
No, sir, it's live.
So it's live.
Yes, sir.
It needs to be a bit louder.
Hello?
Yeah, that's better.
Okay. Yeah, thank you, Professor Davendra, the organizers. Unfortunately, I could not join at Jaipur. So I'll begin my talk today on the laboratory diagnosis of epigenetic disorders. So epigenetic disorders, when we speak about, the first thing you need to know are what is epigenetic or what are these diseases. So the epigenetic modifications are the modifications which happen on the DNA above the basis. So you have either the DNA methylation, the histone modification, or the non-coding RNA, which all are involved in the gene regulation, but they do not form the part of the DNA sequence. So they all are involved in gene activation and gene silencing. And these tags, either the methylation or the histone modification, they are written and erased by different enzymes and are controlled by different regulatory factors. And epigenetic diseases are caused due to any problem with any of these regulators. A number of epigenetic disorders are known now, and they are now grouped
Ashwin, we've lost sound.
In the normal individual, one allele is methylated, other is unmethylated. In Prader-Willi, both are methylated. In Angelman, both are unmethylated. So using a simple PCR-based analysis, you can see that in the normal, you design a primer in such a way that only the methylated or the unmethylated will amplify. So in normal individual, you get two bands, whereas in Prader-Willi syndrome, you get only the methylated bands. In Angelman syndrome, you get only the unmethylated. So it is very easy to detect Prader-Willi or Angelman syndrome, presence or absence. However, as we have seen earlier, if you want to know the mechanism of Prader-Willi or Angelman syndrome, then you will have to do the other tests. Now this mechanism is important because doing methylation in the chorionic venous sample is sometimes difficult and not recommended because there can be methylation differences between the chorionic villi and the fetus. And hence, for prenatal diagnosis, it's better to use the mechanism-related test like a FISH or LLPA, which is a deletion instead of doing a methylation analysis. So let's see few cases how diagnostic testing is used for epigenetic disorders and what are the limitations of some of these tests for which you have to use other methods. So this was a 8-month-old female child. The mother had complained of decreased limb movements since birth and a weak cry, but the baby was recognizing the mother and smiling. The CPK was around 200, so overall the phenotype really fits into a spinal muscular atrophy or a hypotonic baby phenotype. So the first test that we did is the MLPA for the SNM1 gene, and you can see that that was normal. So when MLPA is normal for SMA, you would think it could be some other gene causing this hypotonic baby. So we went ahead and did a exome sequencing that was not able to find anything. However, on analysis of the CNVs or the copy number variations, it was found that there is a 30 kb deletion in this region of Prader-Willi syndrome. So this is matching with the phenotype. A hypotonic infant is known to be there in Prader-Willi syndrome. However, it's a very small deletion, 30 kb. So when we do fluorescent in situ hybridization, you can see here what happens. It is showing like a normal fish. That is because when your deletion is much smaller than the probe that is used in fish, then the surrounding region probe will bind and you will get a false result on fish analysis. And so when we did the MLPA, then we could identify, because MLPA probes were there within this region of deletion, we could identify the presence of deletion. So in this way, you have to remember the disadvantages or the limitations of certain tests, how to detect, and then we are able to reach a diagnosis. So this was Prader-Willi syndrome, which was presenting as a hypotonic baby. This is another child, a 5-year-old girl who came to us with delayed milestones, almond-shaped eyes, obesity, and behavioral abnormalities. With this kind of a phenotype, our first diagnosis is again Prader-Willi syndrome. So when we did the methylation analysis for Prader-Willi syndrome, it was positive, so we were sure that this is Prader-Willi syndrome. However, the MLPA was negative. The SNP microarray did not show any microdeletion, as well as it did not show any uniparental isodichotomy. And the exome sequencing showed no variant in the IC1 gene or any other gene. So the only mechanism remaining for Prader-Willi syndrome was the maternal heterodychotomy.
Thank you, Ashwin, on the excellent overview of laboratory diagnosis of epigenetic disorders. Any questions for Ashwin? There's a question from Meena Upadhyay.
Thank you, Ashwin. Excellent presentation. I have a couple of questions for you. First of all, epigenetic changes tend to fluctuate over time, which really complicates the reproducibility of the test. And my second question is that how do you know whether a epigenetic, or how can you distinguish whether an epigenetic change is due to the cause of the disease or the result of the disease?
Yes, both these things are important, but they are important from the point of view when we talk of epigenetic changes in genes related to maybe multifactorial disorders. But the epigenetic changes that happen in single gene diseases like Prader-Willi or Angelman, they don't fluctuate, they remain throughout the life as such. And hence, they are not going to change whatever time you do the test, you are going to find them. So, what we are talking about, the fluctuating epigenetic changes, those are the changes basically happening because of the environmental factors, and they would be more important probably in the multifactorial disorders when we start using them as predictors in these cases, or maybe in cancers or something. But the epigenetic changes of the single gene disorders don't really change. They are fixed or permanent.
Thank you.
Okay, thank you.
Any other questions? I think in the interest of time, we can discuss, at a later time. So I think that brings us to the end of the session. Thank you very much, Ashwin. Thank you.
Thank you, Dr. Ashwin, for sharing your knowledge on various diagnostic tools of epigenetic disorders. I once again invite on stage Dr. Priya Ranganath ma'am and Dr. Kirstine Kuche for their felicitation. I request Dr. Monish Suri sir to felicitate Dr. Priya ma'am. I request Professor Pradeep Vasudevan sir to felicitate Dr. Kirstine ma'am. We extend our sincere gratitude to all our speakers and esteemed chairpersons and audience, although limited, for making this session successful. Heading to our next session, I am pleased to welcome honorable chairpersons and request them to take their place on the dais. Dr. Naresh N. Rai, Professor and Head Department of Pathology, Jaipur National University, Institute of Medical Sciences, Jaipur. Dr. Rekha Gupta, Associate Professor, Department of Fetal Medicine and Genetics, Mahatma Gandhi Hospital, Jaipur. Dr. Ajay Goenka, Pediatric Neurologist, Assistant Professor, Department of Pediatrics, Mahatma Gandhi Hospital, Jaipur. And Dr. Gunjan Agrawal, Senior Consultant, Department of Pediatrics, Mahatma Gandhi Hospital, Jaipur. I welcome our first speaker for this session, Dr. Helen Stewart, Department of Clinical Genetics, Oxford University Hospital, UK, for her insight on the topic Diagnostic Tools for Birth Defects, Clinical Imaging and Laboratory.
Thank you, and thank you to the organisers of this meeting for inviting me. I'm Helen Stewart, I'm a clinical geneticist in Oxford. I'm a clinician, I'm not a scientist, and I'm mainly interested in paediatric disorders. The title that I've been given for my talk today is, sorry, I've just seen that says 15 minutes. I'm expecting to talk for 20, so I hope that's all right. I've been given the title of Diagnostic Tools for Birth Defects, thinking about clinical imaging and laboratory. So I'm going to go quickly through clinical and imaging, because I'm assuming that many of you will know about that already. And I'm going to focus on specialised genetic testing, thinking particularly about prenatal, and then in the postnatal setting, thinking about acute and non-acute problems. I'm going to try and emphasise some different aspects, so not just clinical, but to think about training and education and service development. So from the clinical point of view, as you know, we start off with a history, particularly starting with a family history, thinking about modes of inheritance that might explain a child's condition, and sometimes thinking whether a child is out of keeping for the rest of the family. With regard to pregnancy, we want to know about teratogens, infections, maternal and paternal age, what testing has already been done, whether there may have been screening tests, any specific tests in the pregnancy, and we need to know about scans and growth. When asking about birth, we need to know whether there were any complications, what gestation a baby was born, what their birth weight was, and also their length and head circumference. And I always need to know whether a baby's received any resuscitation or special care. Obviously, it's important to inquire about a child's development. I always ask parents about what they know about what physical features might be present, and often that's a subtle question that you need to ask when you're asking, do they recognise that there's anything about the baby's face? You need to know whether the baby's growth is different, and in England we have a red book that documents a child's growth, so I always like to see that. I ask about the child's past history, so focusing whether the child's had any seizures, any operations, whether they're prone to infections. I do a systems review, and sometimes when you do that you need to ask very specific questions. So for example, if you think a child might have 22q11 deletion, you might be asking about vomiting. Does the child vomit through their nose? So questions that might seem somewhat random, but they're often useful for testing your diagnostic hypothesis. It's important to know what investigations have already been done, and I like to know what services are involved, so whether speech therapy, physiotherapy, occupational therapy, etc. are already involved. Examination sometimes starts before you even see a patient. Sometimes you can hear them in the waiting room. You might hear them running up and down in the corridor while you're seeing your previous patient, and it all starts to build up the picture. When I call people in from the waiting room, I'll observe a child's gait if they're ambulant. I'll observe their behaviour. It's important to have a look and see what equipment they've got. Are they in a wheelchair? Have they got a nasogastric tube, etc.? And I generally suss out the parents a bit as well, that you want to know what their learning and education levels might be like, how supportive they are of each other. And it's important as well to sort of have a quick think about whether they've got any physical differences. When examining a child, I generally start with their hands, move around to their face and their body. I always want to know height, weight and head circumference, and we'll always plot it on a centile chart. And as we probably all know, when you examine a child, sometimes you can do it very formally and in a structured way, and sometimes you have to be quite opportunistic if a child's not able to cooperate. Sometimes you have a diagnosis in mind, and in that case you might be searching for signs to confirm your hypothesis. So if you think a child might have Rubinstein-Taybi, you might be looking to see if they've got broad thumbs or big toes. And sometimes you have no idea what's the matter with the child, and obviously then you're doing a full examination, trying to gather all the clues together. We can examine children from the outside. Sometimes we need to see what's going on in the inside, so you might need to do MRI scans, echoes, renal investigations and x-rays. And sometimes there's a limit to the abilities that we have to examine children, so you might need specialist examinations, for example, ophthalmology, craniofacial team, ENT analysis, or assessment by the cleft palate team. when I'm talking to families about genetics, I start off very basically and explain to them that our bodies are made up of cells. Within the cells are the chromosomes. The chromosomes are made up of the genes, and the genes are made up of the DNA. And when I explain to them about chromosome testing, I'll say that it's a bit like going into your library and seeing if you've got all your books. And when we're doing molecular testing, it's a bit like reading your books to see if there's a mistake in the actual writing. So when thinking about the range of tests that are available for babies with birth defects, some of them are prenatal and some of them are postnatal, and I've tried to just list lots of them here. So in the UK, all babies are offered serum screening, which gives you an idea of the well-being of the baby. They're all offered scans, which gives you an idea about the physical features of the baby and the growth. Non-invasive prenatal testing, so looking for common aneuploidy, so numerical chromosome abnormalities, might be done in cases of increased maternal age, when there's abnormalities on serum screening or on scans, or if they've had a previous baby with a chromosome abnormality. In contrast, non-invasive prenatal diagnosis is a specific diagnostic test when a known genetic abnormality is present in the family. In that situation, an invasive follow-up test is not required. Fetal sexing can also be done on free fetal DNA to see whether the baby's male or female. That might be particularly important in an X-linked condition. Invasive tests include chorionic villus sampling and amniocentesis, and those might be done for a known genetic condition in the family, or it might be when there's an unknown problem that's been picked up on scan. And that might take the form of array testing, or we might be looking for single gene abnormalities. Postnatally in the UK, screening involves examination, so all babies are examined before discharge. They have a hearing test in the newborn period, and the heel prick test in the UK looks for 9 conditions. In the UK, we've just started introducing whole genome sequencing for newborn babies. So in that situation, we're looking at about 500 genes that cause about 200 conditions. And all of those conditions will have an onset under the age of 5. They're all severe conditions, and they have to have some kind of treatment available that would influence the outcome of the baby. So that project is going live in Oxford, hopefully in the next few days. In the case of a baby being born with a birth defect, or if they're unwell and a genetic cause is suspected, then they go through standard of care testing. So for an unwell baby, they'll have QF-PCR, so a rapid aneuploidy test. They might be offered an array, and they can go on to have rapid whole genome sequencing, which the lab code for that is called R14. In a non-urgent situation, again, a baby might have an array. They might have specific panels of genes tested, or they might undergo whole genome sequencing. So how do we know what tests are available in the UK? Well, we have a national test directory. This is the link to the test directory, and it's basically a big catalogue of what tests are available and under what circumstances you can do them and who is eligible to undertake that testing. The other really useful source of information is a site called Panel App, and this allows us to see if you've got a gene in mind, you can see which panels contain that gene, or if you're interested in a particular panel, you can see which genes are on that panel. So thinking about prenatal diagnosis, this is the list from the National Test Directory of all the tests that are available prenatally, but I'm going to concentrate here on R21, which is the fetal whole exome sequencing. So if you look at Panel App and say, well, what genes are offered prenatally in R21, you can see that there's over 1,400 genes on that panel. So when do we do R21? So it can be done if a fetus presents with multiple abnormalities in multiple systems, and or if you think that there's a specific monogenic disorder. And you have to be clear that it would influence either the management of the pregnancy or the baby in the newborn period. So examples of when we do R21 might be if you suspect a skeletal dysplasia when you've ruled out IUGR. It might be if there's large echogenic kidneys with a normal bladder, meaning that you've ruled out posterior urethral valves. In the case of a CNS abnormality, when you've ruled out a neural tube defect. If there's multiple contractures but not bilateral talipes on its own. If there's increased nuchal translucency, an array is normal. Or if there's hydrops, meaning there's fluid in more than one compartment, and again with a normal array. So what is R21? Well, it's done on a prenatal sample, so either CVS or amnio, and it's a nationally agreed panel of genes that we know can cause prenatal onset of problems, and just the exons are looked at. So in terms of service provision, we'll have discussions obviously with the family, but between clinical genetics, the fetal medicine team and the laboratory, so all have to be in agreement that we're going to proceed with the test. We do a rapid aneuploidy test, and if that's normal, then we move on to doing exome sequencing and an array in parallel. We try to do it as a trio with mum, dad and child to enable rapid interpretation. And we try to get all the samples, all the growth charts, all the imaging, the family tree, the test request form and the consent forms, and all of that needs to be sent off to the laboratory. And in the UK, we have 2 laboratory hubs that are doing this testing. In terms of information, we've got national information available about how to do the testing. And when we do this test, it's aimed that the preliminary results will be ready within 14 days and the final result will be ready within 21 days. In terms of interpreting the results, the laboratory have to comply with the Association of Clinical Genetic Sciences, and they will report a pathogenic variant that they think is causal. They will report a variant in a recessive gene, even if they only find one allele. They'll report a variant of uncertain significance if they think it might be upgradable. They won't report an unupgradable VUS or a benign variant. So just to recover that, we might find something that's definitely abnormal, difficult to interpret, or normal as far as we can tell. And when the laboratory are interpreting the data, they'll look to see, has it been seen, a variant has been seen before, has it been seen in the population in general, what's the type of mutation and the effect on the protein, does it fit with the phenotype, is the gene tolerant to that type of variant. They might do some computer analysis, and they might look to see whether the variant co-segregates within a family. In terms of incidental findings, we try not to find them. We're not actively looking for things apart from what might be the cause of a baby's features, but sometimes we can't help finding it from the data. And if something is found, we'll be discussing it on a case-by-case basis before reporting back to the family. We may well detect non-paternity or non-maternity, and we've even found cases where there's been both. So the aim is to try and find out what's the matter with the baby, to try and inform decisions about how to manage the pregnancy or the baby in the newborn period, and in the longer term we might have information about recurrence. In the case where nothing abnormal is found, can you reassure a family? Well, I think the answer to that is no, because the findings on the scan remain, but they just remain unexplained. And it may be that we go on to do whole genome sequencing after delivery, whatever the outcome of the pregnancy may be. We're constantly studying ourselves during this process, so this is a paper that was published in 2024, which was asking clinicians' opinions about this kind of work, and in general the clinicians were very supportive of it and finding it very useful, but are aware that we need lots of ongoing education and infrastructure development. And this is really just to highlight that there's ongoing education for different groups, so this is a paper aimed more at the obstetricians. So that's all I'm going to say about prenatal. So moving on to postnatal. Pradeep talked to us yesterday about the rapid whole genome sequencing service for critically ill children, so I'm not going to go into that in much detail. This is a screenshot from the National Test Directory. And just to say that when we do this testing, it can be for a baby that has multiple congenital abnormalities or might be very unwell in the newborn period. And for children that are older, we might do it if there's a developmental regression or if they have severe epilepsy. We can also do it in pregnancy if there's a child already born who has got undiagnosed genetic problems, where the outcome of any testing might influence the outcome of the pregnancy. And there are situations when we might do this testing for an adult. So in terms of the process, the first word I've written here is phenotype. It's really, really important to do the phenotyping correctly and accurately so that we can inform the laboratories about what tests to do. In the UK, 90% of testing is done as a trio. We have to fill in a test order form to request the test, and we have to go through the record of discussion or consent forms. We advise people that they have the opportunity to take part in research, and the aimed turnaround time is 10 days. 1,200 of these are funded a year in the UK. Up until 2022, we were doing it by whole exome sequencing, and now we've moved to doing it by whole genome sequencing. And the outcomes of this testing, the R14, might be that we find a diagnosis. That diagnosis might affect the child's management. It might give information about future family planning. Currently, the diagnostic yield is in the order of 43%, and 3 or 4% are diagnosed by whole genome sequencing that wouldn't have been picked up on exome sequencing. And as before, we might get a variant of uncertain significance, or the result might come back normal, and incidental findings are only found in about 1% of cases. So this is just a little vignette to sort of indicate what does this mean for people. It's not just an academic process. So this tells a story of a person who was thought to have a urea cycle defect, but the laboratory couldn't confirm it biochemically. Doing whole genome sequencing allowed the molecular cause to be found, and that's then been able to influence the child's management. So finally, moving on to whole genome sequencing, that allows us to read the exons as well as the introns. And I've just put a little summary here. This is what I say to patients when I'm talking to them about it. So I'll explain that when we're doing it, we're comparing samples from mum, dad, and child, that we read every letter of every gene and the letters in between, and then analyse the relevant ones. We're aiming to make a diagnosis. We're not looking for additional features, so I reassure them that we're not looking for cancer and dementia and things like that that aren't relevant to the child. Again, we might find things incidentally, including non-maternity, non-paternity. I explained to them that we may find something that's very rare or something that's more common. We may find something that's very serious, so I'm warning them that we may find something that they don't yet know about. And then in other cases, we may find an answer that just simply explains what they do know about their child. We might find out how a condition arose, what the implications might be for family members and family planning, and that they'll be offered access to research. And then the final paragraph here is really just going through the process that we need the blood, the test order form, and the consent forms. So why is phenotyping important? When we do whole genome sequencing, we get about 3 billion bits of data, and we have to tell the lab what's relevant to analyse. And in order to do that, phenotyping is crucial. And so we use this website here, which has HPO terms. So if I examine a child and I say they've got a curved little finger, if you examine the child and say they've got a curved little finger, we're informing the lab in exactly the same way what that child's physical features are. So they've got accurate data going in, so they have accurate data coming out. So how are we doing this in the UK? This is an NHS service. The labs operate in a hub and spoke structure. We've been offering whole genome sequencing since 2019, and in more recent years we've been mainstreaming. So by that I mean that we've been teaching our colleagues in non-genetic services how to do this testing. So a lot of the work has been with community paediatrics and paediatric neurology, adult neurology, renal, metabolic, immunology, and ophthalmology. We've been teaching them how to fill the forms in, what the pathways are, and how to give results. And we've been doing this by raising awareness and engagement, a lot of teaching, training, and education, a lot of service development. What we found was that it was taking too long for the clinicians to fill in the record of discussion, the consent forms, so we have a team of genomic practitioners who do this. So this has been a new layer of the genetic clinical service that we've developed. Sometimes we do one-to-one support. Sometimes we've held drop-in sessions, so if people have a query, they know that we're available. We've done seminars, workshops, webinars, lectures. We're developing a virtual learning environment for the junior doctors through the deanery. We've made videos which are on YouTube. There's information on the website, and we're doing a lot of MDT, so multidisciplinary team working. There's national resources available through the Genomics Education Programme and Health Education England. One of the things that we're focusing on at the moment really is what to do with results. We try to encourage people to give the results face-to-face. I like to have an update on the child's progress, and then I go through the result and explain what it means. One of the things that's really important is to emphasise to families that there's no blame when there's a genetic diagnosis. Very often when you go through that aspect of result giving, that's when parents are often very tearful. Go through the family implications, family planning, what support is available, and if there's appropriate, offer them access to research. If there's a variant of uncertain significance, we need to go through what the next steps are, which might be family testing, functional work, splicing studies, research. Already we've heard about gene matcher, etc. So often international collaboration, and sometimes it's a matter of time before we're able to interpret a VUS. When nothing abnormal is found, the data continues to be analysed. This is just a quick slide to go through different types of results. I'll skip through that. It's just sort of terminology that we make sure that the people that are returning results understand the result that they're giving. And when they give a result, they have to understand the genomic concepts, the context of giving the result. They have to be able to describe inheritance patterns, what the diagnosis means for the ongoing management of the child, and the scope and limitations of the result that they're giving. It might be that some of the aspects of the result are not appropriate for the mainstream clinical teams to give, so it might be that the families come to us to discuss family implications and ongoing family planning. And this is just to show at the bottom in blue here that there are links to information that are available about how to give results. Why is a result important? Well, we know on the left-hand side here that a result can curtail a diagnostic odyssey, provide an explanation for a child's features, allow access to information and support, might relieve parental guilt. Families might be able to find other people with a similar experience, and it might inform family planning. But from a parent point of view, what do they want? They want the result to be given accurately, in a timely manner. They want us to be supportive. They want us to work together collaboratively, and they want to feel respected and acknowledged. On the left-hand side here, we've got the numbers which we've talked about on a number of occasions during this meeting. On the right-hand side, again, what is the impact of a rare disease for families? Often they find there's a lack of prognostic information, lack of care pathways. They might struggle for their condition to be recognised. They might struggle to get support. They might find that other clinicians are ignorant about their child's condition. There might not be evidence-based treatment. There might be a lack of research. And as a consequence, they might feel isolated and helpless. And they might feel even more so if you found a variant of uncertain significance. So having said all of that, well, why do we do whole genome sequencing? It's because we've got a very good diagnostic rate. And by doing whole genome sequencing, we're able to pick up abnormalities in regions of the genome that weren't previously available for us to test. Again, there's lots of writing here, but this is to say, what is the difference that it makes to families? Sometimes people go through a very long period of not having a diagnosis. They might have lots of tests that might be unpleasant, they might be very expensive, and without a diagnosis, you don't necessarily have access to the correct treatment and the correct testing for other family members. And then just finally, to sort of think about how we're working with MDTs. I do lots of MDT working these days where we discuss cases, processes, pathways, and allow an opportunity for teaching. If there's a variant of uncertain significance, we might discuss what to do next, which might involve RNA work, looking at episignatures, as we've heard about. And if nothing's found, it might be that we need to reanalyze the data. In terms of where we're going, we're trying to think about doing home blood tests so that people aren't waiting to have their blood tests taken, hoping to improve efficiency. As I've alluded to, we're doing lots of training and education of our colleagues. One of the things we're really striving for is to make sure that we have equity of access and that all different groups of the population have access to testing. We're aiming towards improved variant detection. I have to say that I've been doing genetics since 1995. When I started, we could look at some chromosomes, we could look at chromosomes under the microscope and do a few gene tests. And now we're doing whole genome sequencing as a standard of care test. A lot of the conditions that we're diagnosing, we're not yet able to treat. And I think my hope for the next generation of geneticists and clinicians coming through is that, say, in the next 5, 10, 15, 20 years, that a lot of the conditions that we're able now to diagnose with relative ease will be treatable. So thank you very much for your time and attention.
Thank you, ma'am. That was a wonderful talk. My question was for the screening, whole genome sequencing used for the purpose of screening. So I wanted to understand two things. Was this offered as a whole genome trio or whole genome for the proband only? And second is I wanted to know your experience in offering this test. I understand this is a genome first based approach. So how effectively were you able to tackle VUSs? What did you do after? How did you go about it?
So this has just started in the UK within the last few months. We've been working in Oxford to set this up probably for the last 18 months. So we've been working with Genomics England. We've been working with our research midwives, our delivery midwives, our paediatricians, our existing screening coordinators. So it's been a big project. The expression I'm using is putting all our ducks in a row, so getting everything all lined up. We're pretty much ready to go. Some centres have started already. There's probably 5, 6, something like that, that have started. So the process is that women will be consented in pregnancy. When the baby's born, a cord blood sample is taken. If for some reason the cord blood sample can't be taken, they can have a heel prick. It's going to be very separate from the existing heel prick process, so we don't want to disrupt that. It's going to be done as a singleton, and then the aim is that it will go off to the laboratory and the results will come back within a couple of weeks, and we know that it might take time before we get it to that short turnaround time. We're only expecting to find abnormalities in about 1% of babies. We know that some might fail for some reason. So people who've got nothing abnormal found will just get a letter that goes to their parents and to the GP to say nothing was found. And they have to understand that that doesn't mean that there's never going to be anything the matter with the baby. It just means nothing was found on that test. And if something is found, then we're going to have a regional results coordinator who tells the paediatrician, and the paediatrician has to be an expert in that condition. So if, for example, it's a retinoblastoma gene, the regional results coordinator will tell the retinoblastoma expert, who will tell the family. Because what we don't want is for people to say, we found something and, oh, I don't know what it means. We need to say, this is what's been found and this is what the next steps are. So a lot of the conditions, so if it's an immune condition or a metabolic condition, there will be a next layer of testing. So immunology testing or biochemical testing or a retinoblastoma eye check. So there will be confirmatory testing. The aim is not to report variants of uncertain significance.
So you do report only pathogenic?
We won't be reporting variants of uncertain significance. And we're very aware, as you said, this is genotype first. So when that baby's born, they're a blank canvas. And the regional results coordinator will have a job to find out, has the baby already died? Has the baby been ill? Is the baby already on intensive care? Is the baby on the neonatal unit? And so they will be checking that before they give the result to the family. So it's a very detailed and complicated pathway. And maybe on Monday, when I get home, we might be starting in Oxford. So we'll see how we go.
Thank you. Thank you so much.
Thank you. Oh, I can't hear you. Hold on.
Ma'am, in your approach when you're doing the WGS, you are probably looking for specific genes. You have specific set of genes which you are looking at, or you're looking at all the 22,000?
So when we do whole genome sequencing for a child who's already born and has got abnormalities, this is what I was referring to.
No, this I'm saying for the ones you are doing as a screening.
For the screening?
Yeah.
So for that, we're looking at about 500 genes that cause about 500 conditions. So it's a very specific panel.
So that is what I was trying to emphasize, that you are not actually looking at everything. You are just screening for the actionable ones which are there. Yeah,
exactly. But what's
that's
interesting
the impression I got. Yeah.
is we have our panel of genes in England. The panel of genes that they're doing in Belgium is a bit different.
Yeah, it's
the,
specific to your population and your place. Yes.
So it may well be in time that you come down with a core group of conditions that are the right ones to test. I don't know. Thank you very much.
Still time, or I'm looking at the... So, yeah, stand up. Thank you for a lovely presentation. So, high yield, 43%, so congratulations on that. So that's impressive. I was wondering, so you're checking a little bit more than 1,400 genes in this R21 panel?
No, the 43% was for R14, so the postnatal rapid
that was postnatal,
yes.
Okay, but now so that's R14, so yes. I'm now moving to the R21.
I don't know what the pickup, do you know, Pradeep, what's the detection rate for R21?
Oh, no, okay, but it's not that high. Okay, fair enough. Okay. So I was wondering, so what's keeping up your R14 and your R21? I mean, so that is that a continuous, because you already mentioned that's different for in Belgium or in the Netherlands or
so yes, R21 is a panel of genes that's specific to fetal abnormalities. So I think it had, as I said, 1,400 plus genes. When we do R14, we're looking at more than 23,000 genes. Mm-hmm. So the postnatal rapid whole genome is much bigger.
Okay, so that's not a selected panel. So how many?
It's gene agnostic.
Okay.
Just a continuing question. Very nice talk, but also about the R21. So you just do actually a panel, and regardless of the fetal anomaly, It's just the
yes,
same
it's a
panel
panel.
forever?
Yes, I think it's the same panel if it's a skeletal dysplasia or if it's hydrops. It's just
Okay.
a panel of genes, yeah.
And you don't use the HPO terms in this prenatal setting? You do that? Okay, yeah, thanks.
Sorry, I didn't specify that. Are we finished?
Any further questions? Thanks a lot for the lovely presentation. Thank you.
Thank you.
My sincere thanks to Dr. Helen for giving an excellent coverage for her topic. I now have the privilege to invite Dr. Deepanjana Datta, Genetic Counselor State Coordinator for Organization of Rare Disease India, to speak on navigating the genetic testing in rare diseases.
May I start? Okay. Thank you. A very good morning to all of you. The topics are very similar, so might be a bit repetitive of what we are trying to say or listening since morning. So my topic is navigating the genetic landscape in the rare diseases and like sort of, on the genetic diagnosis. If we are looking at the burden in India, there was a very recent paper which shares the 22 years of experience from tertiary centers. And what we found was, from us, though there are 7,000 disorders, 305 disorders were recorded, and among them, most of them were in the segment of 1 to 12 years. There obviously are adult onset and fetal onset and neonatal onsets, but most of us, what the diagnosis was happening was between 1 to 12 years. And if you look at it, if we look at what disorders that have come up, most of them will be related to birth defects, either anatomically or related to the biochemistry. So if as a part of Organization of Rare Disease India, we do a project in East India where we had asked the urban healthcare centers and also the urban ASHA workers, or these are Anganwadi workers, who actually go to different families and ask these questions. And we asked that, how many of you have seen children with dysmorphic babies or babies who had neurodevelopmental challenges? Here everybody is tagged as cerebral palsy. So we use that term cerebral palsy and dysmorphic features and different or abnormal, though these words have their own problems, but we use that. And we found that among these, about 46.2% said no, but 53.8% said yes, which actually reflects that, of course, this birth defects is something that we are not picking up as we should pick up. And when we asked that, okay, if they look all right, is there any problems in development or learning? There also we got a good 60% saying they have seen such patients and they have met such patients. There are these families. And when the question was asked to the medical officers that what do you do after you see such child and when they visit, would you refer them to a higher center? And most of them actually said yes, we will refer them because we know that there might be a recurrence. So that's the status of awareness. This is a paper that came out in 2023, which actually denotes what were the common birth defects that we found in the tertiary care center. And you can see the congenital heart defects and the cleft lip, cleft palate, congenital diaphragmatic hernia, hypospadias, and the POVs coming up as the most common birth defects. And as we know, the genetic yield for each of this is also higher. So initially, we probably would see the person as very nicely explained in the first session. that the child needs to be evaluated. Later we moved on to the biochemistry, but as technology advanced, we could see the chromosomes as well as probe different genes that are there, right? So right now we understand a bit more, or maybe understand a bit less, or understand more complicated. But just to understand what diagnostic tests are available at the moment, which we do, most of these birth defects may be due to chromosomal reasons, and if we can break the chromosomes into numerical, structural, epigenetic modifications, our test choice would also be in that certain way. So when we look at numericals, obviously we are looking at an extra chromosome somewhere, or a chromosome which is less, and there is karyotype FISH, chromosomal microarray, low pass whole genome, which can detect these, though for numericals we really don't need fancy tests. We can actually go for the basics, especially in a cost restrictive setup like India. For structural, we see that whether there is a change in the structure of the chromosome causing imbalances, and again the same set of tests can be used. And we know that there are certain disorders where we don't need fancy tests, especially where we understand the dysmorphisms. We can go for specific tests like FISH, MLPA, or where we can detect it at a much lower cost. So what we want will depend on what test we order will depend on what resolution we want to see, whether we want to see it as a totality, or we want to pick up one aspect of it, or we want a specific location in that particular aspect. So yes, our magic number is 46. We would like a 46 number of chromosomes. So looking at from the bird's eye point of view, or we need to know a certain segment of this particular place, like it was told, we walk into a library, we see the whole library, that would be my karyotype. We see a small section of the library, that can be my MLPA or FISH. We can also have the chromosome looked at in a molecular way, where we probe each of the STRs which are there on the chromosomes, and have probes which would be like flipping through the books, and we can actually look at these probes and see whether there is a gain or a loss. But we understand that in an endogamous population like India, there are these, like in every population there are these segmental regions, homologous regions, but in India, because we marry in the same communities, the chances of breakage and these disorders are somewhat more. And because they are more right now, there are other tests like the low pass whole genome sequencing, which sometimes gives us a bit more information than the array, because arrays are designed in specific locations, while low pass whole genomes allows us to look for novel transcription CNVs as well. We have our epigenetic modifications, which was very nicely spoken by Dr. Dalal sir in the morning, and depending on again what we are looking at, these are very specific tests, and these specific tests can be ordered. So there's a platter of tests as far as chromosome goes, and similarly when we are looking at genes, there are these single gene disorders which we can probe by reading through the sequence. In India, we do have panels, small gene panels, we have exome sequencing, we also have whole genome sequencing, but because of cost, we hardly do any whole genome sequencing. Now, Sanger sequencing allows us to look at specific regions, and like in a child like achondroplasia, we can just go ahead and do specific tests. We don't need to do any fancy tests that way. While if we are looking at it again, in the last talk, this was covered very well, where they are saying that the whole genome sequencing will look at introns and exons, while exome sequencing will look at only the exonic regions, while the panels we have will look at the specific pathways or the specific genes that you are looking at. So the challenge over here is that the human genome itself is a dynamic structure, and there are a lot of variations. To understand that variation, though we have the Indian genome variation database, but still it is very complicated, because for a clinician it is a set of ATGCs and we don't know how to interpret this. The ACMG and right now the AMP have given criteria where we can classify this as pathogenic, likely pathogenic, VOUS, and benign, which was again very well dealt in the last talk. But we do this based on certain markers like population, computation, functional analysis, allelic databases, disease associations, segregation studies. But the most challenge in India is that right now we don't have our own population database. We don't have our own population population normal, though there is a project Indigen which is coming up, but we still don't have the data for it. So our normal, we don't know. We have to depend on the Western population. So there are these criterias which we give when we do the calling of the variant. Just few examples, because in India when we get a report, 80% of our report would be VOUSs, and we have to reclassify, or we have to, if needed, if they are matching the phenotype, we have to give an answer. So some from my own experiences. So this is a child with lamellar ichthyosis, and this was the pedigree. There was no history, but this particular, and they were not in a consanguineous marriage. They had a first MTP, and then they had this boy. And then they had a child, female child, who was very severe and expired. When they came to me, they were pregnant and they were looking for answers. When we tested the child, we found he was homozygous for TGM1, and obviously the parents were obligate heterozygotes, and this was also proven by Sanger sequencing, but this was a VOUS. So we actually did protein modeling studies. We are not lucky to have functional labs which are very available to us, but we do depend on in silico modeling in most of the cases. As you can see, on one side of your panel, on your left side of your panel, you will see the wild type, and on your right side is the mutant. And you can see how the helix structures, that 8 and this particular loops, the alpha helix, have changed. And because they have changed, it was causing a functional variation. We do a Ramachandran plot, and we actually see that the stability of the protein has changed, and functionally, as per in silico model, we could reclassify this variant. But later we found that this was like about 1 year later, this was reported in other individuals. But because we found this, we actually offered them with all the limitations and of the counselings that this may not be the variant, but we did offer a prenatal, because in silico it was matching. But 1 year later, this was reported in 2 other individuals, so that could be reclassified. Now here is another child with global developmental delay, distinct facial features, and had a positive MRI, had a number of problems with the child, and child couldn't stand also. And this was a child who primarily presented with autism, but had a difficult gait, and also had a MRI which was positive, which had mild problems. So I'm just rushing through because time is less. Both of them had a ARD1B mutation. The first child, who was very severe, basically had a termination variant which was likely pathogenic and reported, but this child had a VOUS. So we went ahead and again did our in silico studies, and here we find that the Gibbs free energy of this protein was also very unstable, and as a result, the mutant protein, the functioning of the protein was not there. We could do this because there was a crystal structure of the protein that was present, hence we could do it functionally. And there were reports where ARD1B gene has various presentations from autism to Coffin-Siris syndrome, and we were part of this study as well, where we could contribute these 2 patients to them. And then we also have the fetal ones, where, see here, the fetus presented with increased NT, and ductus venosus was not visualized. So first a CMA was done to rule out, but then at 19 weeks, the fetus presented with clubbing of feet and hands and long bones short. And then we offered them an exome sequencing. But here the problem is, most of the time we feel what to test and what panels to test. So in this case, there are very simple algorithms, maybe very simple phenotypes, the HPO terms, which we can actually take to understand what kind of genes we are probably looking at. So if we are looking at long bones short, we can look at where it is short, whether it's bowed, whether it is straight. Based on that, we can have a gene list, and based on that, we can have a diagnosis. In this case, we could diagnose this as called 1A2. And when we looked at the family, it was a de novo mutation. And if these are papers which actually cite that when we are looking at a fetal phenotype, skeletal dysplasia, most of the time the yield is very high, and then it is followed by cardiac and hydrops and NT, which is more than 4. So these informations are very important when we are counseling, because India is a cost-restrictive setup and we would like to minimalize our tests rather than maximize it. So deep phenotyping, family history, any prior tests are very important before we order for a genetic testing. If we give less data, if we give less phenotypic data, it's very difficult for lab interpretations because the lab will look at the gene list based on that interpretation, and the gene lists are prepared in that certain way. And when we sequence, ultimately we will prioritize certain genes based on the HPO terms, and once that is done, then the selected genes are there. So sometimes if there's a new phenotype, it's very important to go back and look at the data, and maybe some other genes might be reported with it. So it's basically existing knowledge, genotype-phenotype association, and the gene list that helps us move forward when we are doing an exome sequencing. So counseling should be done in such a way that we make the patient understand that this is not the end of all tests. There are other tests that are available, there are variants that can be missed, there are regions that cannot be picked up. Because I think the sentiment of the patients, because they are paying out of the pocket, is that if I'm doing a test, I should get an answer. And if we don't counsel at this point, there is a bit of hostility, and we tend to lose the patient, and we also maybe not give them a diagnosis which can come up later. So in this case also, this is a fetal case where we see a nasofrontal angle of 145 degree, and there are 2 echogenic foci with premature coccygeal and calcaneal ossification. We got a SMC3 heterozygous variant which was classified as a VOUS. Now, the problem over here was the fetus had come very late, and to do parental studies was difficult because in our India, 24 weeks is the guideline for willful termination. And the fetus looked like this. The fetal medicine did not think of this particular disorder, which was Cornelia de Lange, but when we got the mutation, we went back and we actually we created these 3D structures, you can see, which is below the ultrasound panel, and we actually could say that this was matching the phenotype. And when the baby was born, the baby did look like Cornelia de Lange. We have sent it for some RNA studies to UK itself. I have a friend over there, but we will wait for it. But in the meantime, this was not reported in any other individuals, but this is what we have at the moment. Also, sometimes one test might not be enough because it might not pick up. Here was a very straight and simple case of clinical diagnosis of Bardet-Biedl syndrome. They did exome studies, nothing was found. But when we did a microarray, there was quite a big deletion which was actually found, which the exome sequencing could not pick up. So counseling over here, cascade testing was important because we did not offer a whole genome sequencing in this case, but phenotypically it was matching, so we had to look for more. Also, in another case study, this was a case study which is very interesting because here the clinician was excited because we knew this was diagnostically Alport, like clinically this was Alport. There was bilateral hearing loss, there was optic atrophy and ESKD, and the clinician knew it was Alport, and Alport was reported. But for me, the phenotype optic atrophy was not actually matching because with Alport we don't get optic atrophy, and that was where I was questioning whether it was just Alport or not. And we mentioned this to the lab that we were not just looking for Alport, and we actually got another gene which was a homozygous gene which was related to the bilateral optic atrophy, and you can see it's a consanguineous family, and this was a pathogenic variant as well. So, sometimes genetics also misleads us because we are getting Alport, we are looking at Alport, but the finer phenotypes also need to be spoken about, which might lead us to dual diagnosis, and in the age of genomics, we do get a lot of such dual diagnosis present. Now, this is another child, I'll not read through everything, but this child had nephrotic syndrome, and which was steroid-resistant nephrotic syndrome. The genetics which we got was, one was a particular variant which was a known variant in the exon 6 of the NPHS2, and another one was the R229Q variant. Now, this is basically a polymorphism if you look into the population data. But if it is known that if this is present with another pathogenic variant on exon 7 or 8, then it changes. So when you look at VOUSs, it is also important to look whether there are these databases which tell us that whether these polymorphisms can be modifiers or not. And especially in the scenario of kidney and cardiac genes, these kind of polymorphisms do have other implications. So a VOUS should not always be treated as a VOUS, and sometimes maybe if it's matching the phenotype, we need to look more. Trio analyses are not common in India, but when we get an opportunity, like in this case, we actually did a trio analysis, and the presentation was that of ARPKD, and that is what was we were looking at. We didn't have time, so we were looking at a trio. The family could pay. So in this case, we got a homozygous mutation in the Bardet-Biedl syndrome, but when we tested, the mother's report came as heterozygous, but the father did not carry the mutation. So we did test the paternity because that was our first question, but what we actually concluded, and then later actually we also proved through methylation studies, was that this was an UPD. Now this was a maternal UPD which was causing Bardet-Biedl syndrome. So see, my recurrence risk for this patient changes, and hence trio analysis over here is important. If I just had done the fetus and it was a pathogenic variant and everything was fine, but my interpretation of recurrence risk changes, and also a lot of things changes if I know if I'm doing a trio. So hence probably scientifically a trio is important. Also, when you see a homozygous mutation, we most of the time feel it's a, let us just not do the parents because they will be obligate carriers, but that is also wrong in some way. So there are surprises at every turn. So as emphasized, how do we choose a genetic test? My choice would be start with the basics, do everything basic that is possible, and then when indicated, do your family studies, do your case-specific evaluation. That gives you what test to choose. And if you have an index case, we need to be sure that the index case has been diagnosed properly before going into the prenatal diagnosis, because we shouldn't jump into the prenatal diagnosis or shouldn't just go ahead and do a sequencing in the fetus, which many fetal meds do. And let us not forget the gene expansions as well. So here you can see this is a child with autism, behavior concerns, and the mother has a maternal uncle The mother has a maternal uncle who had mental who had intellectual disability, and the grandmother has dementia. So, sorry about that. So, when we are looking at this, it does give us a picture of Fragile X, and when we tested for the Fragile X, what we found was there was size mosaicism. So, when you're looking at Fragile X, again, we need to look at these smaller things because the phenotype also changes, and because the phenotype changes, there's a lot of variation in presentation, and we shouldn't miss these repeats also. So genetic diagnosis, as per se, is all not single gene disorders. When we are looking at neural tube defects, there are much more to it than just the genetic basis. There is gene-environmental interaction, and there are multifactorial interactions, and hence that gives us difficulty sometimes in understanding the recurrence risks. So the other part which we end with is congenital heart diseases. Sometimes we do carry these particular genes which can cause congenital heart diseases, but they are dose specific, because in higher dose they can cause manifestation pretty early in a fetus form. Otherwise in a heterozygous form they are late onset, or sometimes they have variations in penetrations as well. So transcriptomics in these cases are very important. while I was just preparing for this lecture, came across this paper where they say that the drugs you are using during pregnancy, right now there are system biology which can actually predict whether these drugs are interfering with anything or not, any of these major pathways that can cause these malformations or not. So this is something that is coming up in the field of toxicology involving genomics. So obviously the entire point is academics is fine, but involve the patient's decision, something which we know might not be optimal for the patient, something which the patient wants might not be optimal but should be best for him. So patient first, and as a genetic counselor we need to definitely put the patient's decision as the decision. And with that, thank you. Thank you so much.
Thanks a lot, Dr. Datta. It was an amazing presentation. So in view of the time, we will take the questions during the lunch session. Thank you. Speaker? Next speaker.
We are truly grateful to you, ma'am, for sharing your expertise and perspective, provided valuable insights that was well received by all the attendees. Moving on to the next speaker, I feel honored to invite Dr. Abhijit Dikshit, Consultant, Department of Genetics, Nottingham University Hospitals, UK.
Thank you very much to the organizers for an invitation to this wonderful city and to this wonderful conference. And the topic that I'm going to talk about, in fact, it's become really topical after all the discussions that we have had about how to make a diagnosis today and all the tools and technologies that are now available in Europe and in India. Is to go through what might be missed and how can it be minimized by using the tools that we have. All of us have them. It should work. So that's the missing diagnosis. Right, so what we'll do is I will not cover the genomic testing, how it has evolved in the UK, because that's been covered. Quite a lot of it has been covered, so it makes my life quite relatively easy. And then I'll share a system that we have recently developed for classifying why agnostic tests, so exomes or genomes, might be negative when you are not expecting them to be, with examples from our experience in Nottingham. And then for pediatricians or geneticists to maximize the genomic diagnosis, what can you do to increase the diagnostic yield? That's what Dr. Stewart had sort of already alluded to as the sequence of years through which the NHS started to offer more and more tests. And the directory has also been mentioned by several people. So, and also, many of the previous speakers have said that the most important thing, and I would just reiterate that in terms of getting the diagnosis, is not the technology you have, but to do good old-fashioned stuff really well. Take your history, family history, physical examination, sometimes really basic investigations like X-rays can give a very strong clue. And you will see examples of that as I go along. So, yesterday Bert mentioned phenomics. So you get a clinical diagnosis. If you have a good clinical diagnosis or a good clinical phenotype, even if it is not a diagnosis, then the vast majority of the pitfalls in a misdiagnosis can be avoided. And that diagnosis can be made by a pediatrician or by a clinical geneticist. So the agnostic test has been missed. And now let's work backwards from that. an agnostic test has been done by someone, not any of the excellent people in this audience, but a hypothetical doctor elsewhere, and it has come back negative. And this is the system for thinking about it, a framework to think about it. The first is that there was no genomic variant at all. So, that's not unexpected that no variant has been found, because there are conditions which do not have a genomic basis at all. We could discuss whether VACTERL is one of them or not. It could be a novel disorder, like we heard from Kristen earlier about hit from a gene matcher, that you have a variant which is candidate, but then you get an answer. Or that it is actually a non-genomic disorder. Sometimes it is a non-genomic disorder which actually looks like a genomic disorder. And those are the three categories in which I would classify conditions where no genomic variant will be found. And the second group is much bigger, where a genomic variant has actually been missed for some reason. And they can be classified into two categories. One is that it is an unusual variant, and the pipeline that was used was actually not suitable and would not be expected to find it. And the other is that it is a usual variant, but there was some shortcoming of the pipeline or of the bioinformatics or some other phenotypic clinician input that led to it being missed. So those are the two types of missed variants. And then I have kind of just populated the page as we have gone along. And we will not go through them one by one, but you will see examples of many of these come up as I go along. These are all examples of conditions that we have seen in Nottingham through our experience, sometimes made the diagnosis ourselves, or sometimes it has been through the help of research groups here or there and working collaboratively with the doctors and scientists around the country and around the world. And to facilitate this, to do this in a more systematic manner, we have just recently set up a new program in our service, given the catchy title and Discover, to try and minimize or try and go back through our caseload of sort of negatives, where we could come up with an answer by applying the system that is being developed. Right, so not just X-rays, and I love my MRI scans as well. So this is a good example for not a genomic disorder, and where you should see the pons, there is nothing, and instead of that, on the back of the brainstem, there is a lump, and that is the characteristic appearance of a condition called pontine tegmental cap dysplasia. This is not a genomic disorder. It is a very highly clinically recognizable disorder, though. So if you know what you are looking at from an MRI perspective, even the history in this condition, as you can see on the right side of your screen, is highly characteristic. Yesterday, Dr. Suri mentioned fetal fentanyl syndrome and its similarities with the Smith-Lemli-Opitz. So fetal fentanyl is obviously not a genomic disorder, and Smith-Lemli-Opitz is. And there are other examples on the screen there of a diagnosis of an acquired condition or a non-genomic disorder, which looks like a genetic condition. And then there are, in the bottom half of the screen, are conditions where I have seen patients who were referred as a possible genetic condition, but I made the diagnosis of a non-genetic disorder and wrote back to the referring physician. One more MRI, I'm sorry, I promise there will be no more. It's a fetal MRI, but it's very distinctive. You can see that one cerebral hemisphere is enlarged, and it is not just enlarged. You can see that the ventricle is also enlarged, the white matter is also enlarged, and the cortex is lumpy and bumpy. On the other side, it is nice and smooth and normal in size. And when it is enlarged on one side, and all of the elements, the CSF, the white matter and the gray matter is increased, that's called megalencephaly. And if it's only on one side, it's called hemimegalencephaly. Hemimegalencephaly is a genomic disorder, but it is mosaic in distribution. So if you take a blood sample from this fetus and try to look for a variant, or you try to do a whole genome sequence, you will not find anything, because the pathogenic variant is localized only to the affected tissues. And you can see that it was found in this patient of mine by sequencing DNA obtained from the affected right cerebral hemisphere. I said that I am going to thank all the previous speakers from today. This was not a plan, but it has turned out really well because people have mentioned through the day. That's one of the advantages of having your talk sort of towards the middle of the day or towards the second half of a conference. And this is a patient of mine who, you can see the asymmetry of his face. You can see that the right side of his face appears more prominent. The right leg appears to be longer. And when that happens in a clinic, then you try to think along the lines of Beckwith-Wiedemann or Russell-Silver. But there were no clues as to which way the child might lie because his growth parameters were actually average. He was not a large child like Beckwith or a small child like Russell-Silver. And it turns out that he actually turned out to have multilocus imprinting defect. And we have a few other multilocus imprinting defect patients as well now. Again, bear in mind, in fact, I had made the mistake of saying, because his birth weight was towards the higher end, that it might be Beckwith. But it now turns out that it is his smaller side, which is the abnormal side and not the larger one, because he's a multilocus imprinting defect with Russell-Silver phenotype is his correct diagnosis. Imprinting has been mentioned by two of our speakers today. So that's an imprinted disorder. Just to highlight the abnormal chest X-ray, I put a normal chest X-ray next to it. And as a pediatrician, as a doctor working in a neonatal unit, this should be a spot diagnosis. You don't need history, you don't need physical examination, you don't need anything else. It's PAT-UPD 14, Kagami-Ogata syndrome. So those ribs are so characteristic that there is nothing else that looks like that, absolutely nothing else. And although there are many different molecular mechanisms that cause paternal UPD of chromosome 14, the chest X-ray looks identical. And we have in Nottingham now quite a large collection of Kagami-Ogata syndrome babies. Most of them, in fact, apart from one pregnancy termination, are alive and into their teens now. Those are the clinical features. And again, a very simple, straightforward, cheap, already performed X-ray on a neonatal unit, which shows the ribs to be. So those of you who haven't seen it before, that is a dysmorphology diagnosis, not on the face. It is absolutely characteristic. The way the ribs are not short, they are just curved like coat hangers. So once you see it, you will not forget it. It happened to me. Somebody showed me the X-ray, and then maybe a year later, I told someone that's PAT-UPD 14. So everybody can do it. And again, because it could be a segmental UPD, so it will not show up on your exome, genome, or karyotype or any other test unless, as Dr. Dalal pointed out, you suspect that this could be an imprinting disorder. Also, it has been said that the questions were asked about this as to whether when we do whole genome sequencing in the NHS, it is just a technology platform, except for the R14 patients. It is not a test. And the genome is sequenced, but only the genes that you request or the panels that you request are analyzed. So, and also within the panels that are analyzed, it's not even for the genes, the intronic variants are not looked at outside of the bounds of what is on the screen. So that again highlights the importance of phenotype in knowing whether the right gene is on the panel or not. More examples. These are disorders that are related to non-coding variants. Now, non-coding variants are usually not covered on exome platforms. And even on genome platforms, unless you know that this is a non-coding variant which might actually be relevant, it will not be flagged up easily. So this is an example of a brand new condition which has the catchy name now of Renew syndrome. It has just been published as in Nature maybe 3 months ago. And I am showing this here because this is an extremely common cause of intellectual disability. Within the 100,000 Genomes Project data of the UK, there are more than 100 patients with this condition that had been, the data had been there for over 10 years. And it took a long time and some very clever scientific work to describe the condition. They estimate, these authors, that it will account for 0.4% of all intellectual disabilities. So it has gone right up to that sort of, big hitters as a cause of syndromic intellectual disability, despite being described in 2024. And they are actually dysmorphic children as well. So I've shown an example from the paper that was published earlier this year. And so you see the coarse facial features, the distinctive nose, the downturned corners of the mouth. So if you have patients like that in your practice, then this is something that they could potentially have, because it is a common condition in all populations. There is some sort of imprinting going on as well, because there's quite a high proportion of those kids had the de novo variant on the maternal allele, all of them. So those who were tested all had the variant on the maternal allele. This, we do not understand yet why. There is a second disorder in this similar non-coding RNA gene, which has been published literally about 2 months ago, and it causes syndromic epilepsy. Again, in several dozens of patients within the UK cohort. Right. More X-rays. Micrognathia, Pierre-Robin sequence. And what do you see on the X-ray in a neonate there? Rib gaps. Rib gaps. So they are not broken because you don't see any callus there. But gaps in ribs are highly distinctive. It doesn't happen very often. It is a rare condition. Most geneticists will recognize it, but sometimes pediatricians will not. But even so, if you Google it, it will come up. But there is a trick, and there is a reason why this is here. It is a condition called cerebrocostomandibular syndrome. This is one of our patients from Nottingham. And you can see lots of gaps on both ribs. And it's quite a severe condition because it will give a flail chest. Now, a clinical exome was performed in a UK laboratory after they were told that this is the diagnosis, and it relates to only one gene, and it relates to very specific variants in that gene, and they returned a negative result. And so if it looks like a duck, if it walks like a duck, surely the duck DNA test must be positive, but it wasn't. The molecular basis, we don't have time to go into the molecular basis of cerebrocostomandibular syndrome, but it is due to pathogenic single nucleotide variants in an alternative exon, which is not usually annotated on the genome. So unless you tell the laboratory that this is what we are looking at, they will not find this. So the negative became a positive after we told them what to do. And as I said, this is a rare condition, but only maybe a year later, a baby was born with antenatal micrognathia, but the X-ray of this stillborn baby shows clear-cut rib gaps. So they do come along more than once, sometimes within a year. This is an OTC deficiency family, and the molecular mechanism is very interesting and very unusual. That would have been missed on most diagnostic tests, because what was shown was that it was an inversion of about 5 megabases that had disrupted the interaction between the promoter and the enhancer of OTC. And it took a long time until we got to that answer. It would not have been seen on karyotype. It was too small for that. But it was sort of clever bioinformatics work on WGS data. Last couple of examples now. Large family. This is, I have a very passionate interest now in renal genetics. And I see lots of kidney disease families. And when I first set up the clinic about 10 years ago, all the big, the big hitters got referred. And you can see this is one of those where there are lots of people who have had kidney failure in adulthood with nothing, no pointers towards a diagnosis. Any shout outs to say what it might be? The clue is that there were no pointers. You heard about Alport syndrome from the Panjana. So it's not, because Alport syndrome are deaf, they have proteinuria, they have hematuria. These people have nothing. They just have kidney failure. No, there's no cysts in them either. No. Oh, you are looking at the aneurysms. Well done, but no. This is a condition called MUC1-related tubulointerstitial kidney disease. Mucin 1 is a fascinating gene because there are very unusual variants, which are insertion of a single nucleotide within a variable number tandem repeat region in a certain part of the gene, which is resistant to Sanger sequencing, to exome sequencing, to genome sequencing, and any other technology that you can think of. So the clue to the diagnosis, now we now have 7 families, including about 50 patients with MUC1 kidney disease in the East Midlands. So it's not a rare disease. I'm absolutely certain there are patients in India with MUC1 kidney disease who have not been diagnosed. That's the phenotype on your left, and the main clue here is that if there is familial CKD, parent and child, then, and no clues, no hematuria, no proteinuria, ultrasound normal, even the biopsy is non-specific, sometimes wrong, sometimes it gives misleading answers, then it's this condition. And there's quite a lot out there to read about the scientific basis. Mitochondrial, so lots of people suspected this gentleman to have a mitochondrial disease. For good reason, because hearing loss, neuropathy are features of mitochondrial disorders. But you can see, just like Dipanjana's case, something doesn't fit. So there is interstitial lung disease, interstitial lung fibrosis. That is not a feature of mitochondrial diseases. And then he had some hyperpigmented patches on his chest wall. He had whole genome sequencing that was negative. I hope you can see his chest, the top right, the depigmented patches around his chest. You can see the nails also. The nails appear dystrophic. So if you are seeing a neurologist, if you are seeing an organ-specific doctor, they might sometimes overlook the clues that are present in other systems. But if you put it all together, then it turns out that this patient actually has dyskeratosis congenita. And the clues towards his diagnosis were minor, and so they were underlooked, sort of not appreciated as well. And eventually, the diagnosis was made by one of my colleagues in the genetics department who made the clinical diagnosis of dyskeratosis congenita, went back to the data and asked for dyskeratosis congenita genes, and there it was. Last one. This was a diagnosis on email. So I got an email last year to say, can you see this patient tomorrow? And generally, we like to prepare properly, and I wasn't very happy about it. But when I looked at the history, thought that there is a pretty good chance that there must be a diagnosis, and I wonder why it has not been made. And it didn't take long. You can see the timeline, maybe less than an hour, to find the answer, sitting in my office. So this is the story. 19-year-old boy and his sister. They arrived in the UK as refugees from Syria in 2015, and they had a retinal dystrophy. And back then, in 2015-16, they had a clinical assessment with us, and they had a gene panel test which was negative, and they went into the 100,000 Genomes project, and that was also negative. The reason why he was coming to the endocrine genetics clinic to see me is because he had not gone through puberty as expected, and it was hypogonadotropic hypogonadism. And as part of his workup for hypogonadotropic hypogonadism, he had an MRI scan that you can see that he had. Now, this is not something that he had any symptoms from, at least from the family's perspective. But you can see that there is some atrophy of his cerebellar superior vermis, some of the hemispheres as well. So when you put together the retinal dystrophy, cerebellar atrophy, and hypogonadotropic hypogonadism, then everybody in the audience will agree that there must be a genetic condition in a consanguineous family. So then I had to go into Google, and it gave one answer and one gene, and then I queried the data on the interpretation portal of the WGS on 100,000 Genomes project. And he was homozygous for a variant in a gene called PNPLA6 that gives a condition called Buschet-Neuhauser syndrome. And so until yesterday, he was an undiagnosed patient, and when I saw him the next day, I could share the diagnosis with the family. So back then, the gene had not been part of the retinal dystrophy panel, and by 2020, when the 100,000 genome last analysis had been done, it was a new gene at that time, but the phenotypes were not known yet at the time, that he was only entered as a retinal dystrophy patient, but not the other conditions. To have hypogonadotropic hypogonadism, you have to reach puberty age. Here is a long list of all the conditions that we have diagnosed in the last, so it's 2 pages long, and we have tried to classify them, and I've tried really hard to make them fit into some kind of a systematic pattern. What is in red are clues for which there is a phenotypic, phenomic diagnosis. It is relatively easy, but it is highly distinct, and everybody should be able to make those phenotypic diagnoses. If you can make those phenotypic diagnoses, then all of your WGS and exome and negative agnostic test results can be solved. We didn't have time to go into all the others, but again in red are the patients in whom the phenotype led to the diagnosis. So this is my last summary slide. The message for pediatricians and geneticists, how to increase your diagnostic yield is, the biggest portion of it is what's the clinical diagnosis. If you know the molecular mechanism, are all the molecular mechanisms covered? Is there an overlapping phenotype? Has the phenotype changed? Has the patient got a new problem? Did you see them 5 years ago? Do they have minor clues on their skin or their nails or their hair that have been overlooked? I want to say in India, I'm conscious that to say trio, but if you do trio analysis, then also bear in mind the possibility that a parent may be mildly affected, and that will change the interpretation. Know what are the panels that have been analyzed and the limitations of your pipeline. There is a software called Exomizer that is often coupled with the WGS analysis now, but it was not in the past, and that has led to some diagnoses being missed. I don't have time to go into the epigenetic signatures, but there you are. There are 2 or 3 things on that slide for which there is no time to mention, but that's the summary of what might be the reason why your genomic testing is negative. Thank you very much.
Hello. Thank you for your elaborative presentation. Any questions?
Thank you, Abhijit, for an excellent presentation. Could you tell us a little bit more about NDiscover project?
Yeah. So this is a question for the UK colleagues of mine, but what we are proposing to do is that go through the list of patients who were in DDD or in 100,000 genomes project, because we have we know we can identify them through our internal databases, and those who were negative, we will ask the recruiting clinician to suggest whether they should enter the program or not. So the plan is that we will do this remotely first, without without inviting the family back, just by reviewing the phenotype, reviewing and making sure that everything was done, that there isn't actually an easy exomizer hit that was missed. And then if all that is done and it is all normal and nothing is found, then we will invite the family back for a clinical review. So it has not happened yet, but that's the provisional plan, to do the patient seen in the past. And then once the pipeline sort of gets refined a little bit, then to use it prospectively for the patients going forward, where as soon as we receive a negative result, or to start, first of all, do the things correctly first time round, and then if it is negative, then go back and apply this iteratively.
Thank you for the excellent talk. I think it's a very good point, and we all set up such methods to discuss with each other the patients that you don't find the diagnosis. The problem is the time, and that's why it's good that you make a project of it, I think. Yeah.
So are you asking me about where do we find the time for this?
Yes.
Okay.
And yeah. Okay.
Yeah. Thank you. So I'm hoping that this also relates to the way the time is calculated in the NHS. And we have to sell this to our hospital management as a worthwhile project, because at the end of the day, those patients are not going anywhere. The patients living in our region are still our patients. End of the day, they will get referred back to us, and we will have to restart it all over again. So that is up to the management to accept that this is an effective way, probably much quicker than doing the whole thing all over again and getting them to do WGS once more. And we have a number of trainees now who are all sort of relatively skilled, newly learning bioinformatics. So we have tried to encourage them all to come up. So one of the logo has been created by one of our trainees. So I'm sure they have the enthusiasm to at least do the first step of the basic analysis, and then hopefully some of the senior clinicians will provide supervisory input. But it's a very new thing. So if we completely fail, then I'll let you know.
Thank you, sir.
Thank you very much.
Thank you, sir, for sharing your knowledge. I request the chairpersons, Dr. Rekha Gupta ma'am and Dr. Gunjan Agrawal ma'am, to felicitate our speakers. Dr. Abhijit Dikshit sir, Dr. Helen Stewart, and Dr. Dipanjana Datta. I feel honored to invite Dr. Priya Marwa, Professor and Unit Head, Department of Pediatrics, Mahatma Gandhi Hospital, Jaipur, to felicitate our esteemed chairpersons. I extend my deepest gratitude to all the respected chairpersons and expert speakers for their presence and participation. It's time for a short tea break now. I request all the dignitaries and participants to enjoy the tea and be back in a very short time, 10 to 15 minutes, to continue with our upcoming sessions. Thank you.
Good afternoon, everyone. Gregor Mendel, called as the father of genetics, transformed our understanding of inheritance through his simple pea plant experiments. His remarkable discoveries showed how traits pass from one generation to next, laying the foundation of modern genetics. As we honor his legacy, Dr. Gregor Mendel oration lecture at this conference highlights the important role of genetics in advancing healthcare, offering insights that connect his timeless principles of today's innovations in diagnosis and personalized medicine. Truly, small seeds can grow into mighty trees, and Mendel's seeds of knowledge continue to flourish. It is my honor to introduce Dr. Reena Das, ma'am, but to do the honors, I would call and request none other than the organizing chairperson of this conference, Dr. Dahavendra Kumar, to please come on the stage and introduce Dr. Reena Das.
Thank you, Aditi, and our host here, MGU, MST, Dr. Shiv Gupta, and all of my colleagues. So before I start, I want to introduce the background of this oration. I can't see the slides here. Start cut. So, so this conference is a series of biennial series of conferences started in 2010 under the banner of the Genomic Medicine Foundation UK. The sole objective of this foundation has been, as you can see from the slide, the genomics and omics in all aspects of human genetic diseases and its applications in healthcare. So this was really the brainchild of Professor Sir David Weatherall, known to many people across the world globally. He put hemoglobinopathy, thalassemia on the global map. He was the first person in the world who was invited by the WHO to chair the first committee to look at genomics in the global health context. As the chair of that committee, he wrote a seminal report that has been the basis of the genomic medicine and healthcare that we are talking about. He is no more, but he was a founding patron, and I was very fortunate to be the first chair of this foundation. So this foundation has got many projects. We started in India as a project called Indo-UK Genetic Education Forum. That became very popular. And we moved on to UK-India Genomic Medicine Alliance. Many universities and institutions signed us with MOU. Now, in the post-COVID time, we decided to expand that on a sub-regional continental basis. So no wonder we agreed on South Asia Genomic Healthcare Alliance. So all those countries you see in the pink are part of this. But these boundaries are very arbitrary. There is no limit. These were created purely for economic purposes, for the geographic distributions, nothing else. There was no population basis. So no wonder why South Asia has got overlap with Southeast Asia, Middle East, and also Central Asia. There are many projects of SAGA, South Asia Genomic Healthcare Alliance, and the forum, education forum remains number one. The Birth Defects Conference is part of the South Asia Birth Defects Consortium, and then many other groups, as you can see from this slide. And all are very active, some are very fresh, like the pharmacogenomics group and the genome ethics group. We have been to many places, as you can see from this map of India. Jaipur is the fresh one, the new one to be included on this map. And we are grateful for all these institutions. The response has been tremendous. There is a huge requirement in this country with 1.45 billion people. and about 35 different states and regions. Now, coming back to the basis of this oration today, so we have been thinking about how to acknowledge eminent people in different regions and as well as globally. So the idea was, no wonder we all talk about Gregor Mendel. His vision, he was just an ordinary priest in a remote part of Czech Republic. At that time, it was called Czechoslovakia. And we call him father of medical genetics or modern genetics. So two things very important in his, which we talk about. Number one is the phenotype. He decided to have a soft-looking, smooth-looking garden piece, or long and short, and all those things he put together. The second thing is that he put all those things in a very randomized manner, and that has become the concept for trials. We call it Mendelian randomization. So you heard about the double-blind randomized control trials. In essence, that was his idea. That's what he did in a small garden. So we decided to have the oration in his honor. So as you know, there are many alien diseases we have discussed in this conference, many autosomal recessive, autosomal dominant, and X-linked recessive, and some are also X-linked dominant. In fact, some of the complex traits also behave in the Mendelian manner, those who are in a cluster of variants or a cluster of the family history. So that's the starting point. So Mendelian diseases has been the main focus behind choosing the name of Gregor Mendel oration. Now, coming to the most common genetic condition in different parts of the world, I practice in Europe, where cystic fibrosis is very common. But coming to this part of the world, hemoglobinopathies, mainly sickle cell anemia and beta thalassemia. Sickle cell anemia is less common because it's more in Western Africa. But beta thalassemia, starting from Turkey, Greece, Cyprus, coming all the way to Iran, to West India, and a lot of Parsis in Maharashtra, and you name it. I think it's really endemic in proportion of cases of beta thalassemia in India. So we were looking for someone who has done work in this field. So Professor Reena Das, who is a head of the Department of Hematology in Postgraduate Institute of Medical Education and Research in Chandigarh, and I have known her for the last many years. She has been to Oxford. Her mentor was also Professor Sir David Weatherall, and she has got perhaps the largest thalassemia mutation database in India, mostly derived from North India, and tremendous teaching experience, and not only hemoglobinopathies, but other blood genetic diseases. And she has been the recipient of a number of awards from a huge number of research publication articles. So it is my great pleasure to invite Professor Reena Das to deliver the inaugural Gregor Mendel oration at this conference in recognition of her lifetime contributions and achievements to thalassemias and other inherited Mendelian diseases of the blood in India and South Asia. Professor Reena Das.
Thank you so much, Professor Davendra. It's an absolute honor to be here, and I think I've really been enjoying lots of talks since morning. They have been excellent talks, and really has been a wonderful experience to come to Jaipur for this conference. So can I have the first slide? So the topic that Professor Davendra chose for me is the challenges of hereditary hemoglobin disorders in India, outcomes from North India. And Basically, I'll be talking about a molecule which is the hemoglobin molecule. All of us are aware about the hemoglobin levels. I think I see a lot of students here, they will understand that anemia is a huge problem in India. And I'll be talking about a genetic disorder which is fairly common in India. So you have heard about Professor Dr. Gregor Mendel, and sir has given a very nice outline. I would like to dedicate this talk to Professor I.C. Verma, who is the father of genetics in India. In 1968, he set up the first genetics center in India at AIIMS, New Delhi. And he has been a recipient of multiple awards in the country and abroad as well. He is no more with us, but his legacy continues as genetic work in India. So my mentor in India, in my department, was my head of department, Professor Gurjeevan Garewal, and she introduced me to this red cell disorders, which is a fascinating RBC, that we see as a biconcave disc. It doesn't have a nucleus, but it comprises as the most abundant cell in the human body. And adults have actually more than 25 trillion RBCs in circulation, which is really giving oxygen to the blood. To all the tissues and organs. And this is how the structure of hemoglobin looks like. There are 2 alpha chains and there are 2 beta chains which are there. And the output of this protein is really very, very well coordinated by 2 chromosomes, the chromosome 11 from where we get the beta globin gene locus, and the alpha genes are there at the telomeric end of chromosome 16, and the alpha globin genes happen to be duplicated as alpha 1 and alpha 2 genes. So this is a very, very interesting molecule, and it never ceases to amaze me. Why? Because most of the hemoglobin protein has been really, really well described since the long. We know the genetic basis of many Mendelian disorders through this molecule, simply because it's very easy to get the blood. And there is no, it can be replenished, and taking a liver biopsy and studying that would be very difficult, but taking blood is not difficult. But this is a structure of the hemoglobin, the globin chain, and you can see the twists and turns which are there. And there are certain locations which are very, very important where the mutations are not going to be tolerated, and there are some places where you can have asymptomatic hemoglobin disorders. So if we look at the thalassemia syndromes or the hemoglobinopathies, we would classify them as quantitative defects of the globin chain, which are known as the thalassemias, and the defects could be either in the alpha chain, beta chain, delta beta, etc. Now the classification is based on whichever is the defective gene. So if the beta globin gene is defective, we call it beta thalassemia. When there are alpha gene deletions, we call it alpha thalassemia. But hemoglobinopathies are like qualitative defects. So sickle cell anemia that we all know, or hemoglobin A disorders comprise this disorder. The high fetal hemoglobin is one condition. So we know that the fetus requires oxygenation from the mother, and this is the fetal hemoglobin which is able to deliver the oxygen to the fetus. But when it happens in adults, then we call it a high fetal hemoglobin. Now this is not an abnormal hemoglobin, but the location or the time at which this hemoglobin still persists in the adults is kind of abnormal. So it's an inappropriate expression. These disorders, the unstable hemoglobin disorders where the protein is abnormal, or polycythemic variants where there is a gain of function mutation, or an acquisition of an unusual property like methemoglobinemia, these are inherited as sporadic cases or autosomal dominant inheritance, and the common ones are autosomal recessive. So where you will find that the parents are asymptomatic or they are carriers, and they will give the disease as autosomal recessive kind of inheritance. Now, why are we so concerned about the thalassemias? Because this is a very easy disorder where screening test is available. There are numerous thousands of genetic disorders where easy screening is not really available. But thalassemia is one condition where a test costs less than a pizza that you would probably buy from the market. So this is a public health service wherein lab tests are systematically applied to identify individuals who appear normal. So anybody sitting in this hall could be a beta thalassemia carrier, and if one happens to marry another beta thalassemia carrier, in every pregnancy there is a 25% chance that the baby might have thalassemia major. Now the family members of an affected index case, if we are really screening them, we call this cascade screening, or extended screening. So in simple words, the bua, masi, mama, chacha, all the young people in the family, they should be screened for this test. The other category where screening should be done is compulsorily is antenatal women, because antenatal women is the time where every mother wants their child to be normal. So basically the concern for having a normal child is very high. It's very easy to counsel for the gynecologist to get the husband to come and get the screening done as well. So based on red cell indices, there are various ways, and these are the red cell counts which are coming from the automated blood cell counters. We call this as mean corpuscular hemoglobin, mean corpuscular volume, mean corpuscular hemoglobin concentration, and RDWs. And we can identify a beta thalassemia trait or carrier by these red cell indices fairly well. However, when during pregnancy or if there is iron deficiency anemia with beta thalassemia traits, which is not uncommon to encounter in the population, there can be difficulties. Also, we cannot pick up hemoglobinopathies. For doing the testing for beta thalassemia, we just need a blood test from where we can do a HPLC by a BioRad system, and it can tell us the values of hemoglobin A2 or fetal hemoglobin. Now, we collaborated with a statistician, and he has come up with an app which is on the telephones, but this is available only on Android phones, where if you fill in the data of the automated blood cell counts, it will give us possible outputs as whether this is not suspected to be beta thalassemia trait or HPLC is recommended for this. So this has been found to be quite good, and it has been used by many countries, at least it has been downloaded, so we hope that it is being utilized as well as a screening method. So it's obviously not a definitive test, but it gives you a fair idea about. So we have kept the kind of the specificity not very good, but the sensitivity to be very high, so that at least we don't miss cases of thalassemias and various hemoglobinopathies. So long back in 1996, when I had joined as an assistant professor in the Department of Hematology, we had a DBT sponsored training program on a thalassemia, which was a 3 weeks long program, and there I was a faculty, a young person at that time, but we had Dr. Urvashi Bharadwaj, who actually introduced me to molecular biology, and this is Professor K.C. Das, who used to be our former head of the department, and Professor Gurjeevan Garewal, who was my head of the department at that time. So I also picked up some of the molecular skills from CMC Vellore, and I would like to acknowledge Dr. Shaji, whom I think as my friend, and Dr. Yunus, and also they had excellent technical staff who were very keen to teach. That is something which is very important, that when you learn something, you have to give back to the society and the country and other labs as well. Then we had the first Asian workshop. This happened in China, and that was the first time that I met Dr. Dhavendra, and also some of the Usha Dave was there, and we had Dr. Ratna Puri, who is now head of Sir Gangaram, where Professor I.C. Verma worked for so long. So this is a group photograph we had at that time. I think Dr. Dhavendra had left by then, or he came in earlier or later. Then there was this Asian Thalassemia Network which happened in Singapore, and you can see Professor Vederol, who was there. Professor Sutat was another big name in thalassemia from China, and from Thailand, sorry. And we had Dr. Prema from Sri Lanka, who worked very closely with Sir David Vederol. And this was in a meeting that we had in Chandigarh. And this is the Vederol Institute of Molecular Medicine, where I had actually taken some of the DNA samples where I learned a lot of techniques over there as well. And this is Dr. Dhavendra hosting me at Cardiff, and I always thank him for that, because he introduced me to Dr. Derek, and there I got the technique for doing the inversion 22, which is a very common test for hemophilia A, and there was a simple test which was kind of, I was introduced to, and that's the test which is done all over India now, because the traditional method of doing inversion 22 is really cumbersome to do, and now people do the inverse shifting PCR for this. This is a general OPD blood collection center that we have at PGI, and life is a great leveler because this is the type of rush we get, and this is the general kind of a patient who would come to our clinics. So you can see that it's very difficult to ask them for money for getting all these complicated tests. So we are grateful to a lot of funding support that we get from the government, wherein most of the tests that we do are actually free of cost. At the moment, all the thalassemia screenings, all the prenatal diagnosis that we are doing, it is completely supported by the government, and the patient does not have to pay any money for getting all these tests done. So the prenatal diagnosis was started by Professor Garibal in 1998, and we do a universal antenatal screening program of population data for beta thalassemia and other hemoglobin disorder, which we started from 2009. And 4.2% of antenatal women were found to be beta thalassemia trait. Now when I analyzed the husbands of the beta thalassemia traits whom we were able to screen, we found that there is the frequency of beta thalassemia trait is quite high to 16.75%, and this is because many of the marriages in India happen within the same community. So we do not have consanguinity in many populations, but the marriages may happen within the same community structure. So among the abnormal hemoglobins that we got, 62.9% were beta thalassemia trait, but we also got many other types of variants within them. So this is the screening data that more than 40,000 individuals we have screened, and this is all hospital based data, and 92% were antenatal women, and this is the kind of percentage we got of the beta thalassemia traits, etc. So we also got a series of uncommon hemoglobins, like these are just hemoglobins which we have picked up from the general population, you can say, by the screening method, and they would not actually come to a doctor because they are completely asymptomatic, but they are interesting to a hematologist. So the conclusions from this data is that it provides contemporary prevalence of beta thalassemia trait and an estimate of the number of pregnancies at risk of having a child with beta thalassemia major. And this data also uncovers uncommon asymptomatic hemoglobin disorders in the country. So despite advances in preventive measures, the large population that we have in our country and inadequate trained manpower, even now I think probably 15 or 20 prenatal diagnostic centers are really available in the country, which is not really the need. We need many more number of trained people, trained labs, trained obstetricians who can do chorionic villus biopsies so that we can prevent these disorders which are preventable, so that we can have resources to look after the children who have thalassemia major or other genetic disorders. So this was one case which was there, a 30 years female Punjabi lady who was screened as a universal screening program in Singapore, where compulsory screening has been there for many years. She tested normal, and since she was normal, her husband was not screened. But when the child was about 3 years, there was significant anemia, and he was diagnosed to have thalassemia intermedia. And we see that there are 2 mutations which are there, the IVS15 mutation G2C and the CAP+ mutation, which is the A2C. And along with it, the mother actually had a heterozygous alpha deletion, and that was the reason why there was a relative normalization of the red cell indices, and it was missed in screening. So I usually give this example because just to remember that you can get, if we just do automated red cell counts, it's possible to miss cases of beta thalassemia trait, and there is no way of identifying these kind of individuals who are beta thalassemia traits with a completely silent red cell indices and also hemoglobin A2 levels. Now this is the prenatal data that we have got. We have done about 1,531 cases till date of antenatal diagnosis. Roughly in the last couple of years, we are doing somewhere between 80 to 90 prenatal diagnosis. This is data compiled till 21, and so I'll just give a short few case histories to show how we have difficulties in cases also, not just everything is hunky-dory and we are able to get the diagnosis. Now this was a 13 years female referred in 2009, so long back, and the child looked like a typical thalassemia major. The fetal hemoglobin was high and was receiving transfusions also, like it looked like a thalassemia intermedia, because the child did not receive regular blood transfusions. There was no consanguinity, and the parents were looking like regular beta thalassemia traits with raised hemoglobin A2. So if the A2 is anything more than 4%, we think that this is a beta thalassemia trait. So basically we did the Sankar sequencing for them. The exon 1 and 2 could not be amplified. In the meanwhile, actually for this family we ended up doing 2 prenatal diagnoses. At that time we just did haplotypic analysis because we did not know the breakpoints of the mutation. So a few years ago the child's MLPA was done and we found that there was a gene deletion which was there. It looked like a homozygous deletion because everything, so this black dots seem to be like normal, but these red dots over here shows a large area of beta globin gene deletion. So including other genes which are there included. So when we did the MLPA of the father and the mother, we found that both of them were heterozygous, and this is the targeted NGS that we did. So we do all our targeted NGS in-house in PGI in our department since 2014. So we could develop some primers just by knowing, expecting that maybe this is the region which is got, and we found that the hemoglobin HBD region, the delta chain basically, from delta chain to the exon 3, so basically exon 1 and 2 were deleted, and we could develop a gap PCR based on this data. So it took us many years to really get onto that, but we kind of just managed to do that. This is another child which was very interesting. He presented with, at the age of 4 years with hepatosplenomegaly. The hemoglobin was quite less at 76 grams %. The RDW was very high because you can see that the red cells were looking quite far apart and there were some spherocytes which were there. And the reticulocyte count is really high with the Heinz body-like picture which is there in the reticulocyte preparation. Now I had already reported this HPLC long back and I had called it a double heterozygous for HBQ India with beta thalassemia trait, and the child had gone back and again got readmitted with a second episode of hemolysis like this. So at this particular time we looked at the parents and both the parents were normal. So I had expected one parent to be HBQ India, the other one to be beta thalassemia trait, but that was not happening. And at the alkaline pH we found the hemoglobin electrophoresis showing a band which is not at the position of HBQ India where it should have been in between in this location. So it definitely looked like that I had made some big mistake. So when we did other tests, the urine for hemosiderin was positive, test for unstable hemoglobin was positive quite grossly in this particular child compared to the control. And then when I looked at compared the HPLC of the patient with a case of double heterozygous, I could see that the A2 here was like sharp, but here it looked like broad based, and this looked like an inverted funnel, not like the HBQ India how it should look like a very sharp kind of a peak which was there. So definitely I had made a mistake. Then we did the beta globin gene sequencing and we found that there was a heterozygous mutation which we kind of reported it as for the first time as hemoglobin sabine, which there's no other case reported from India, and we could publish this case as a case report, as a diagnostic difficulty which is there. Another patient here, actually this patient was about 26 years old, presented with a high hemoglobin and splenomegaly, but he also had jaundice. So I had this resident calling me from the clinic and saying that, can you look at I think this patient is having hemolysis. Can you look at the reticulocyte count? I said, who looks at reticulocyte counts when the hemoglobin is 18 grams? But since he insisted, I had a look at it and I found that the RBC count is very high, the hemoglobin is high, but the red cell indices were like a beta thalassemia trait. And the peripheral smear, you can see that the RBCs are overlapping so much because of the polycythemia, but the reticulocyte count is really high in this. So it appears that something was going on, and the HPLC of the mother showed that she was a beta thalassemia trait. The father's HPLC showed another peak at P3 of 37.4%. Now this is definitely not like hemoglobin J merit where we get a peak which is roughly about 20-25%. And when we looked at the index case, there was no adult hemoglobin, the A2 was increased and there was this single peak which was there. So definitely something was going on in this child. There was a fast moving band which was there in the father as well. He has the adult hemoglobin as well as the fast moving band, and the unstable hemoglobin was faintly positive in this particular case. Now this looked like a hemolytic erythrocytosis because there was a point mutation over here in comparison with the normal kind of which was missing in the parents, but we also had an additional mutation over here when we compared with the normal. So basically this was a case of hemoglobin andromenia polys where we also get polycythemia as well as we get an unstable hemoglobin. So when we send it for publication, they said no, you have got another mutation, so give it another name. So the patient belonged to Bijnor, so we called it hemoglobin andromenia polys, Bijnor hemoglobin. And it was Dr. Niranjan Khare whom I kept on pestering that you have to publish this case because you were the one who picked up. I don't think I would have looked at the reticulocyte count unless you insisted from the clinic. This is the story of another patient, 36 years male, presented with shortness of breath for 3 weeks, and there was history of nasal obstruction, nasal discharge and sneezing, and he was on salbutamol SOS. Now during the referral, the oxygen saturation was 75%. There were some polyps in the nasal examination, but the clinicians were obviously worried. Now I had this junior resident in internal medicine. He was the first year junior resident and he rings me up and he says that, ma'am, I think it's an abnormal hemoglobin. So I said, how do you think that this is an abnormal hemoglobin? Because you know all the other tests are looking normal and there is something wrong in this patient. So I was in Calcutta at that time. So I get this HPLC message on my WhatsApp and I said, oh, this is looking normal. But then when I spoke to my technician, he said that, ma'am, this doesn't look normal. There is something wrong with it. So when I came back and I compared and I found that this peak which appears kind of normal, but this is quite broad based and compared to our normal over here. So when we compare it with the normal, we find that there is a small 0.4% peak at the C window in addition to this broad peak which was there. So when we did the sequencing of this case, again we found that this was hemoglobin Chevrolet. And by chance, when we looked at the family screening, we found that the brother and the sister also had hemoglobin Chevrolet. And so the only important thing is that they should just be aware of the fact and go with this report so that they don't confuse doctors when they go to any of the hospitals that something may be really grossly wrong among them. So it was actually Muhammad Bilal Azam and who was the junior resident, and again I pestered him that you have to write this case because you were the one who kind of picked up this particular case. So very briefly I'll just talk about another child with severe hemolytic anemia. And most of the other tests were kind of negative, and there was nothing really very wrong in the peripheral smear except for occasional nucleated RBCs which were in circulation and the anemia which was there. But we found these cells which are known as nesocytes, which means that the RBCs have a kind of a omega kind of shape which is there of the RBCs. And when we looked at the HPLC, we found that only the hemoglobin A2 is increased, nothing else was there. So the incubated osmotic fragility test was showing resistance which we would expect. Those targeted resequencing showed that there was no probably pathogenic variant in this particular case, and this case was taken up for whole exome sequencing. So this is again showing that NGS always doesn't give us the answer. Sometimes we need to retest even by NGS because it's possible to miss some diagnosis by NGS. So when we did the whole exome sequencing, at that time we found that there was a heterozygous kind of mutation which was there, which was confirmed on Sanger sequencing. This was a hyper unstable hemoglobin variant which was known as hemoglobin Yakaguchi. And what happens is that normally you have the leucine at this particular position of 110, but when it gets substituted, the structure kind of changes and this open structure becomes like a ring structure, and that is the kind of abnormality which is there. So this is there in the database as a hemolytic anemia, and the electrophoresis shows no separation because it is hyper unstable and it will get completely not to be seen. The last case, this is a 1-year child presented with anemia, and the smear showed macrocytes, spherocytes and polychromasia, some nucleated RBCs, again reticulocytes, and some RBCs which are showing a lot of this reticulocyte RNA kind of. Now all that was wrong in this HPLC was that apart from the retics being very high and the patient being very severely anemic, that the fetal hemoglobin was high, nothing really wrong. When the whole exome sequencing after the targeted resequencing was done, we showed that there was a hyper unstable hemoglobin variant which is called as hemoglobin Alicia. Now why is this very, very interesting? Because of the fact that when we look at this particular case, there is a post-translational modification mechanism which can happen, which can convert the translated methionine in hemoglobin Alicia into an aspartic acid residue, which can result, can be related to hemoglobin Bristol. Now here we are talking about 2 hemoglobins. So there is basically a hemoglobin Alicia, and post-translational modification can convert it into hemoglobin Bristol. So actually this particular, the study of these hemoglobin disorders has been very interesting experience for me, simply because I think that most of us know everything about the molecule, but then after every 2-3 months I come across a case which I have never seen before. So there is a lot of things which are happening, and it's constantly we are reminded of that medicine itself is a vast ocean and we are merely a drop in the ocean. Currently, we are focusing on non-invasive prenatal beta thalassemia testing. This was a collaborative project that we did with UCSF, Benioff Children's Hospital. Currently, I got an ICMR project which is on cell-free DNA, and hopefully this test will be available so that we can do it in India much more cheaper than what is expected in the Western population. This is just the methodology of how it is done. I think we don't have the time to really go through the entire thing, but just to tell that this is what is coming up nowadays. Currently we are just doing the prenatal testing. So basically we have to do a very deep kind of sequencing, something very akin to the deep sequencing that we do for minimal residual disease in cancers or hematological malignancies when we are following up the patient after chemotherapy or after bone marrow transplantation. So all this work that I have shown would not have been possible because of the excellent residents that we have in our department, clinical hematology department and the pediatric hemato-oncology department, and I have got wonderful colleagues and some of the lab staff which are shown in this photograph. Till now it has been a satisfying journey that I have covered for this particular disorder, which is kind of everything known, but I still feel a lot of it is still undiscovered and not known. Thank you very much.
Thank you, ma'am, for this excellent presentation. Everybody was looking forward to it, and the oration is really honored by your name getting attached to it. Normally, after oration, we don't have questions. But in the interest of the interest that you stimulated in the talk, I think there may be some queries. So one of them certainly comes to my mind is that if the kind of hemoglobinopathies and other hemolytic processes that you have been able to identify, does it mean that today the genetic analysis should become one of the very tests which has got to be done early in the course? Because what's happened is in the last 40 years as a clinician that I've been managing thalassemia patients for almost 35 years, nothing changed except some transfusion chelation. In the last 5 years, you started doing transplantation. And what we look forward to is moving towards gene therapy and gene editing other areas. So this is something which is probably going to make a sea difference in the recommendations as far as the teaching goes. So your comment on that, sir.
Yeah, so you're asking me about gene therapy?
Yeah, two things. One is it going to be a routine program to do genetic analysis in all children presenting with hemoglobinopathies? And the second is...
Yeah, so that has been the dream. I think all of you would be knowing that the Prime Minister has said that, by 2047, I think, that we are not going to have sickle cell anemia in India. And now the gamut of thalassemias is also going to be included within them. So it's all right to, say programs, but I think the focus should be for prevention. The prevention is so important for a country like India, where there are so many pregnancies which are happening. I think antenatal screening program is something which has to be all over the country. Now, that is not enough. We have to have more and more prenatal diagnostic centers. Unless we have that, just screening and identifying people with beta thalassemia carriers is not going to be enough. So I feel that it is going to be more. At the moment, there has been a lot of initiative for identifying centers who can do gene therapy, and IGIB has got a huge project for sickle cell anemia. Sickle cell anemia because only a single gene mutation is there, but the hope is that if it happens, it will be much cheaper in India possibly, but we haven't reached there yet. I think gene therapy programs are happening in the West and even in USA and Europe, but it's at a very huge cost. I don't think that even they can afford it as a long time kind of a program. So I think prenatal diagnosis is the way forward, and before that, of course, the screening programs. Universal screening program is something which is absolutely necessary for a preventable genetic disorder.
Thank you. Any other question from the audience? I think then the final word from you.
Yeah, once again, Professor Das, excellent presentation.
Thank you.
And so you have really started a new series of oration at this conference. So it is really a great pleasure. I think we need to felicitate you for this oration.
We would like to thank ma'am for sparing her valuable time and making it to this conference. We are extremely grateful to you, ma'am. If I can request Dr. Ashok Gupta and Dr. Devendra Kumar to please present the memento and the certificate of appreciation to Dr. Reena Das. If I can request everybody to please give her a big round of applause. Also, if I can invite Davendra sir's wife to please come on the stage. If I can invite all the guest speakers to please come on the stage for a group photograph, please. Thank you. Thank you, everyone. Moving on to our next speaker, it is my privilege to introduce Professor Bette de Vries, Consultant Clinical Geneticist at Redbourn University Medical Center, Nijmegen, the Netherlands. He is the chair and co-founder of Human Disease Genes website series. A globally recognized expert in clinical genetics, dysmorphology, and neurodevelopmental disorders, Professor Bette has made significant contributions to the applications of genomic and its diagnostics in genetic inherited diseases. His pioneering work has been published in numerous high-impact journals advancing in field of genomic medicine. We are honored to have you, sir, today with us, and we look forward to hearing invaluable insights on a very interesting topic, artificial intelligence and facial imaging as diagnostic tools for rare diseases. Dr. Bette, welcome Ode Conferencia in Jaipur, meaning I welcome you to this conference in Jaipur. Over to you, Dr. Bette.
Thank you for this nice introduction. Thank you for inviting me over here to India again, and I'm enjoying my time here. So there my first slide is coming up. So it will be about AI, and I see lots of young people here in the audience, and that's great because it's your future. AI is new to me, but it's already common for you, probably, and it will have a major impact in medicine. Facial recognition, I will talk about this as well. Probably that will be a niche, so a small field in dysmorphology, but maybe it will extend broader as well. Okay, let's see. I'll go a little bit back in time, so I'll go to 1984. That's not because of this lovely novel, and I wonder how many people have read this novel, but it's an excellent novel. No, it's because of this paper, and this is a paper by Preuss in Clinical Genetics in 1984. And what he did try to do is to create a checklist for Williams syndrome. And maybe some might be familiar with Williams syndrome, some won't. So this is a neurodevelopmental disorder with lots of problems in different systems. It's caused by a deletion on chromosome 7q11.23, but that wasn't known in 84 because that was disclosed in 95. Facial dysmorphism, intellectual disability, congenital defects of the heart, and periods of hypercalcemia. Okay, so what did he do? He created a 40-item checklist, and you cannot read it, certainly not, so I expected this. So he had looked at the eyes, he looked at the ears, so 40 items. And what he did do is he created two groups. So the scores for Williams, they were on the left end, and for you on the right end, and non-Williams. And when I was a trainee to become a clinical geneticist, I used this score with a senior colleague, and then we start scoring, and most of the time I used this score. Unfortunately, it ended up somewhere. Is there a pointer? Okay. Yeah, somewhere in the middle. You can figure it out where it ended up. So it was inconclusive. But this was a guy who was really thinking about the future. With AI, he would have solved this easily. But it was 84. So now I move a little bit in time, 25, 26 years, and we see that dysmorphology, so looking at the face and other clinical features, is changing. In 2010, actually, the whole exome sequencing was introduced. And from a clinical point of view, it's relatively simple. You have your DNA, you put it in a machine, and on the other end, the sequencing are coming out. Of course, it's highly complicated, but this is how you can look at it. Okay. We were the first one in Nijmegen to introduce whole exome sequencing in a diagnostic setting. And it was a very exciting time because there were lots of questions that we need to answer. One of the questions was, which of the patients are we actually testing? because it was a very expensive test. So you have to make some selection. And on the other hand, you get those variants coming out, and we have to ask ourselves which of those variants are actually clinically relevant. Okay, so that was in 2010, exciting time. So we moved to 2024. To be honest, the machine changed. It's going faster, it's cheaper, so a wonderful time to be in genetics. But the two questions still remain. They haven't changed over those 14 years. And I would like to add a third question. So what do we actually know about comorbidities in patients with neurodevelopmental disorders? And I will address all these three questions during my talk. So then you always start with, let me see. So you always start with question 1, which patients should be tested? And for this, we developed PRED-WES. And PRED stands for Prediction, the Outcome of WES. And here we use Human Phenotype Ontology, HPO. Before that, so I have been working together as a fellow, then we're talking about 2000, 2001. I had the honor and the privilege and the pleasure to work together with Robin Winter at Great Ormond Street Hospital in London for a year. And what did we do? We tried to create a checklist so for selecting, testing for subtelomeric abnormalities. Because that was new at that time, and it was costly, and we didn't know who we could test, so we had to make selections there. And we come up with this relatively simple 5-item checklist, scoring 0 to 10. And the higher the score, the more likely it is that you find a subtelomeric deletion of duplication, so that's at the end of the chromosomes. And we could also use this for copy number variances. So that was pleasant. So we could use this. At that time, it was useful. But of course, nowadays, it's old standard. It's not good anymore. Because we have AI. And the advantage of AI is that you can actually put all your symptoms in and test an algorithm and by testing the algorithm, and eventually you will test it in a way that it will address the question you have. So what did we do? We had this over 1,600 patients with neurodevelopmental disorders in our department in Nijmegen. They were all seen by clinical geneticists. They were well scored, 15 HPO features per patient, so that's a lot. And we had 3 groups. We had a group where we had a positive WES, so it's more than 400 cases. We had a group where the outcome was negative, so around 1,000 cases, nearly 1,000 cases. And we had 232 cases with a variant of unknown significance or uncertain significance. So basically, it could be either way, causative or not causative. And with this data, we started to train an algorithm. So we had the features for all those patients, and all the features were put in, all the patients were put in, and we trained the algorithm, and we asked the algorithm, please predict whether it's a positive WES or a negative WES. And lo and behold, that worked. So the overall diagnostic yield in this cohort was 26%. And we said, okay, please, algorithm, tells us the best one to test and the worst one to test. And it lined up all the cases, so we had the top 10%, and we had the top 10% lowest. And then you already see that the top 10% is doing pretty good, with a diagnostic yield of 56%, whereas the lowest end only had a diagnostic yield of 8%. This means that using this PRED-WES, you can actually increase it by 2-fold if you only test the top 10%. And currently we are testing just top 10% with whole genome sequencing, because I expect that we will find genetic abnormalities there, which couldn't be picked up by the whole exome sequencing. And the good thing is, you can use this. You can go to the Human Disease Gene website series, and you can actually click on PRED-WES, because it's there. You can put it in your clinical data using HPO. It's probably 10 minutes work. And then you will get a likelihood of getting a positive S or a negative S. And that's very important because you can make some selection because your resources are limited. And this has well been picked up by editorial in the American Journal of Medical Genetics, stating that it's lovely, of course, and I was pleased to read this. The other thing is that there was also caution by an American colleague, and he said, okay, lovely test, but we should be aware that it shouldn't be misused by insurance companies. That they only say, okay, we only pay when your patient has a likability in the top 10%. Okay, that's a caution, but anyway, that's how science works. And we are using this, and we are currently working together with a group in South Africa who's making this sort of selections for their research studies. So from my perspective, it's more a research tool, but because, yeah, that's my perspective. Anyway, so this is question 1. So we go to question 2. So which of those clinical variants are actually relevant? We all know, or most of you know, that we have those pathogenicity prediction tools, and they are based on molecular data. So a CAT score, Philo-P score, there are dozens of them. And you can use them, be cautious with them, but you have those prediction scores. So we thought, okay, that's lovely. So we have all those prediction scores based on the molecular data. Couldn't we do something clever on the phenotypic data? And that's called phenomics. We're all talking about multi-omics, and I say phenomics, phenomics, phenomics. Okay. So what did we do? We developed PhenoScore. And that's an AI-based phenomics to quantify rare disease. And we use 2 models. Model 1 is based on 2D photos, so facial recognition tool, and the other one is based on human phenotype ontology. And for the model 1, this facial recognition, we use VGG phase 2, and that has pre-trained weights. That means that it has been trained on 3.1 million faces from all over the world. So the algorithm is trustworthy. For the model 2, we use HPO. And I think HPO is very important because it has a hierarchical structure. That means that when one clinician will say, this child had neurodevelopmental delay, whereas another clinician might say, okay, but I think it's more motor delay. And because of its hierarchical structure, those 2 features are relatively close together, and they are weighed in a similar, almost similar way. So you correct for this sort of naming. So you have specific, aspecific, it's a tree. So how does this work? This is machine learning, so sort of, in my opinion nowadays, basic AI. You have a syndrome of interest, and you have controls, in this case also controls with neurodevelopmental disorders, and they are age, gender, ethnicity matched, and that's important. And that's when you start doing anything with AI, be aware that rubbish in is rubbish out. So you have to have very careful which your controls are. If I would have put there normal controls, normal people, yes, that's easy. But then the outcome is rubbish. Okay, so here I would like to introduce the Curran-de Vries syndrome. It's a relatively novel syndrome caused by mutations in cancer1, or the cancer1 gene itself is deleted. It has facial dysmorphism, as you can see here. There are 3 patients. They are alike, especially for people who are working in dysmorphology. No, that's okay. You want me to be chairperson? I don't need to. Okay, sorry, we have to wait for the computer to restart, I guess. It's on my screen already, but that's not helpful for you. Oh, there we are. Okay, so you can recognize it facially. It has characteristic facial features, intellectual disability, epilepsy, congenital heart defects, and also kidney problems, and it has musculoskeletal problems, especially hypertonia at a young age. Okay, so what did we do? We had 63 well-characterized patients with Coulon-de-Vries syndrome, and we used 63 sex, age, ethnicity matched controls. And then we start training the algorithm that has been pre-trained, as I mentioned. And here we see the results on the facial recognition tool. This is Coulon-de-Vries syndrome. That needs to confirm this, and in this case, I confirm it's a Coulon-de-Vries syndrome also on clinical recognition. But that's very important. The decision is not with PhenoScore, it's a helpful correlation study. So 50,000, there were over 3,000 unique HPO features. So that's tremendous. And 2.5 on average. So I mean, on average, mean per patient. So what can you do with this? You can actually ask Phenomat NDD, and again, this is linked to the Human Disease in a Website series. You can ask, for instance, what is the frequency of abnormal heart morphology? You tick this in, and then you get this, coming up. And it shows the prevalence of the frequency, we say prevalence, in the whole cohort of Phenomat NDD, in the Nijmegen cohort, in the literature cohort. It gives the number of patients that this feature could be scored on, because you write paper. If it's not looking at heart defects, then it doesn't make sense to start scoring, of course. And it shows all the papers where these frequencies are based upon. So it's a very helpful tool. And here I want to introduce Cohen-Shires syndrome caused by ARID1B. Again, a multi-malformation syndrome. You have the intellectual disability, the coarse facies, the hypertrichosis, sparse scalp hair, and abnormal fingernails, especially on the 5th digit. And in the Human Disease in Website series, we had a lovely collection of more than 200 individuals collected by a colleague in Leiden, Gijs Santen and Van der Sluis. And it's a high quality data. And as you can see here, this is what I call a phenotypic fingerprint. All the organ systems are listed here. And in blue is whether you've scored positive, red is that the feature is not present, frequency that is not present, and sometimes it's unknown or not reported. So you can click on, for instance, in this case, neurological abnormalities, and then you get the exact percentages of all the features that have been scored for those 200 patients in this series. So what can you do with this? And I think this is very important. I believe it's important. You can put all the features together and you get this sort of frequency. But is this frequency actually related to ARID1B? And there, Phenomat NDD gives you a helping tool, because you know this is the baseline frequency in the whole cohort of children with neurodevelopmental disorders. So you can establish the enrichment score, and the enrichment score is depicted over here, and of course this is Bonferroni corrected, so these are all significant. So you can actually see what the features are of this relatively novel genetic disorder. Most of you use OMIM. If you go in OMIM, that is a lovely clinical synopsis, but it's not up to, yeah, so it's inadequate. So we looked for ARID1B and we see that some of those features are not in OMIM. Okay, we thought, is this only for ARID1B? So we question how complete is OMIM. So what we did do is we had data on 33 neurodevelopmental disorder syndromes, and in all those 33 genetic disorders, we had more than 1,700 enriched features. So there are really features related to those genetic disorders. And then we went back to OMIM, to the clinical synopsis. I can do a round, of course, but I won't because of the time. My screen is okay already. And then that screen is going up, and then you will get your further information. Okay, there it is. So again, we looked for those 33 genetic disorders, and we come up with 1,700 enriched features, so really related to those genetic disorders. And there, the clue, it's a little bit more than 1,200 in OMIM. So that means that 30%, 29% is actually missing in OMIM. And of course, that hampers clinical diagnosis and further treatment of the patients and dealing with the families. Okay, so this is Phenomat NDD, and you can go to the Human Disease Gene website series, and you can use this. So coming to the conclusions, so I addressed 3 crucial questions. They were already crucial in 2010, and they're still crucial, and likely they are also crucial in 2030 and 2035. So I hope I have convinced you the importance of phenotype for rare genetic disorders. Phenomics, phenomics, phenomics. So which patients should be tested? Here, PredVest might be a very helpful tool to do some prediction. Which are the variants are clinically relevant? You can use PhenoScore there, and on what's the comorbidity, or what are the baseline, what really do we know about NDD patients. Here, Phenomat NDD will be a helpful tool. And by the way, Phenomat NDD will be growing. We will be adding up all new cases for the coming decades, probably, using the same system. Okay, so I've not done this work on my own. I certainly have to acknowledge Lex Dingemans. He's a very talentful PhD student, and he went through all the 9,000 papers, more or less, in a clever way, supervised also by Lysenka Visis. And of course, we are working closely together with the AI department, Max Hine and Marcel van Gerven, because, of course, that's really needed, was really needed. Okay, so this is my final slide. It's moving. So if you want to get more information, go to the Human Disease Gene website series. There are over 1,400 genes currently adopted. If you're ever considering adopting a gene, don't worry, just send me an email, and it's relatively easy. We as a community have to start collecting worldwide all the data on all those novel genes. I cannot do it on my own. I've adopted 20 genes myself, but we need all the specialists that are dedicated to a specific gene to adopt a gene and start collecting. As I mentioned before, it starts with 10 cases, but we also need 11, 12, 13 to really get the clinical spectrum. Thank you.
Thank you so much, Dr. Burt, for your informative talk. Before we move ahead to the next speaker, I would like to invite the chairpersons to chair this session, Dr. Somshekhar Nibalkar, Professor and Head, Department of Neonatology at the Pramukh Swami Medical College, Gujarat, Dr. Rajpreet Soni, Senior Consultant, Department of Pediatrics, Mahatma Gandhi, Jaipur. Dr. Prashant Mithalwal, Consultant Internist, Hope Hospital, Jaipur. We can now take questions for Dr. Bett. Anybody from the audience?
Before, I think it was a very great presentation using the 3 questions. And so how do you enlarge the collaboration across various countries? Because you wouldn't have AI everywhere, and like most places would not have the capability to use this.
So all the tools are, it's open science, so all the tools are available. So on GitHub, you get all the data. You can actually train your own algorithm. So currently for PhenoScore, we did it on 40 cases, 40 genetic syndromes. We are extending it to 100 this year, and we will go on. The important thing is that you need good controls. So this works for our cohort. We have a lovely cohort of thousands of children with neurodevelopmental disorders, also with faces and so on, whose parents gave permission that we could use the photo within this safe environment. So that's one thing. So everyone, and there are young students here, and probably they think, oh, this is simple AI, and probably it is. For the younger generation, they can do it. But you have to provide them with good data. If you provide them with the right data, then they can run it, I think. Well, not all maybe, but some clever ones. So on the PRETWES, you can already use this, because you just put in your clinical features and also give you a probability. I have to say it has been tested on Dutch cases, so that might be you have to be careful, but it's always,
The question is, how do you get a platform for people to collaborate, and how do you build that platform to ensure that you get more people inputting data in this area?
Now, so for the Human Disease in Your Website series, everyone can send me an email, and I respond. And then I can tell you how you adopt a gene, and it's relatively simple. You create some text, and then you have the text, and then you can start collecting novel cases worldwide. In 10 minutes' time, you simply have to have a look at the website, but there's where you can put in novel cases in 10, 15 minutes, and it's all HBO structured. I have no time to show it here because I had to restrict myself. And then by doing this, you get adequate information. I think, especially here in India, you should be starting adopting genes, because you have so many recessive disorders, and you're the ones who should be starting collecting those, not me, because I don't have them in the Netherlands, or not those. We do have other problems in the Netherlands, but anyway, so that's the idea.
Please go ahead.
Thank you, Bert. One of my questions was, you talked about who to test and your algorithm. Are you factoring parental wish or need to know? Because some people want to know more than others.
Can you speak a louder? I couldn't hear.
Sorry. Some people want to know more than others, don't they? What's the matter with their children? Are you factoring that into your algorithm?
Yeah, which algorithm? Because we've tested several. So the PRETWES or the PhenoScore of?
The who to test algorithm.
Oh, the who to test. Now, so it's so we are in the lucky position in the Netherlands that I am allowed to test, because of the insurance way we have insurance things. I'm allowed to test any child with neurodevelopmental disorders using WES, and we are currently moving to whole genome sequencing. So I'm not restricted, so I don't have to select. So in that way, I do, yeah. So I don't know if I address your question in the right way, or, but so we don't have to select on this. And of course, but as with anything you do in a more broader sense, I discuss it with the parents, and things like PhenoScore, we have a permission for, certainly in a clinical setting, but if we move to a research setting, we have permission of all the parents involved that we can use their images and the data to train the algorithm. Of course, that's very essential, but that's basically in all studies you are doing.
Thank you. There are no more questions. We can go ahead. Thank you, sir.
Okay.
Thank you so much. I would also request our guests for today, Dr. Anurag Tomar, who is a senior pediatrician at the NIMS Hospital, Jaipur, to please come as a chairperson to chair the following session. I would also request Dr. Atul Gupta, pediatric endocrinologist who has traveled all the way from Himachal Pradesh to be with us today at the conference, to please come and chair the following sessions. It is my privilege to introduce the next speaker of today, Dr. Munish Suri, a consultant clinical geneticist at Nottingham Clinical Genetics Service, part of the Nottingham University Hospitals NHS Trust, UK. With over 25 years of experience in clinical genetics, Dr. Suri, known for his expertise in pediatric genetics, dysmorphology, skeleton dysplasia, and more. In addition to his clinical role, Dr. Suri holds an honorary professorship at the University of Nottingham's School of Medicine and serves as the clinical rare disease head at the East Genomics Laboratory Hub, Cambridge. Dr. Suri has co-authored 154 peer-reviewed publications and has an impressive H index of 39 on Scopus, a remarkable achievement that speaks volumes about his dedication and impact in the field. Congratulations, Dr. Suri, on this incredible milestone. He is also the Vice President and President-elect of the UK Clinical Genetics Society and also delivered the most prestigious Carter Lecture for the Society in 2024. Dr. Suri's insights, experience, and commitment to advancing genetic medicine make him an invaluable voice in this conference, and we are excited to hear from him today on the topic, Neuroimaging for Genetic Brain Disorders, both phenotypic and genotypic correlation. I invite you here, sir.
On the slide. So thank you very much, Aditi, for that introduction. The title of the talk in your handouts is actually Neuroimaging for Genetic Brain Disorders, Genotype-Phenotype Correlation, but I've actually just changed it to Phenotype-Genotype Correlation because as clinicians, obviously, we see patients first. So we see the patients, we do some imaging, look at the imaging, and then decide which particular genes may be responsible for those particular phenotypes that we've just seen. So over the next probably 15 to 18 minutes, I'll just give you a couple of slides on normal sequence of brain myelination. This is important because of one of the conditions I'm going to be talking about. And then I'll try and link neuroimaging phenotypes to genotypes, and I'll give you an example of two genotypes that can be caused by variants in many different genes. So those are very non-specific phenotypes. Then I'll give you an example of one neuroimaging phenotype that's caused by fewer genes, then another neuroimaging phenotype that's caused by just two genes, then one gene, then just a specific region of one gene, and then just one variant in one gene. And finally, I'll give you an example of a neuroimaging phenotype for which there is no gene. So essentially, that diagnosis has to be made primarily on the phenotype itself. So the first thing I want to go through is the normal sequence of myelination. So obviously, brain white matter gets myelinated in a very sequential manner starting from before birth. So before term gestation, the brainstem and the lateral thalamus get myelinated. Then soon after birth, the cerebellar white matter gets myelinated. And then up to around first 6 months of life, you have the posterior limb of the internal capsule getting myelinated, then the anterior limb, then the genu and splenium of the corpus callosum, and then the optic radiation. And then thereafter, over the next 2 years, you get myelination of the cortical white matter, and that starts from the periventricular region and goes outwards and then extends to the subcortical U fibers. So this is an invariant sequence, and it always progresses in this way. And if it doesn't, something is very, very wrong. So here's what it might look like. So just see if I can use the pointer here. So this panel at the top here, these are T2 weighted images because the CSF appears white. And these are T1 weighted images here in the bottom panel, and that's because the CSF appears dark. So in the first 6 months of life, if you want to look at myelination, you should be looking at T2 weighted imaging. And if you want to look at myelination after 6 months of life up to around 2 years of age, then you should be looking at two weighted images, so here. So let me just show you what happens. So on T2 weighted images, unmyelinated white matter is white, and as myelination proceeds, it becomes black. So you go from white to black. And in T1 weighted, it's the exact opposite. So you go from black to white. So let's start here. So you can see here that the posterior limbs of the internal capsules here, maybe you should reduce the lights over there just to get a better idea of the imaging. So you can see here that the posterior limbs of the internal capsule are white, indicating that they are myelinated. Then the anterior limbs, the genu of the corpus callosum, the splenium of the corpus callosum, and the optic radiations here. So you can see that at 5 months, these are all myelinated on T1 weighted images. And then if you go up to T2 weighted images after the age of 6 months, so at 1 year, you can see now myelinated white matter is actually dark because you're looking at T2 weighted images. So you can see posterior limbs myelinated, anterior limbs myelinated, genu of the corpus callosum myelinated. You can see some myelination extending to the deep cortical white matter, and then this is 5 years. You can see that the myelination is extended all the way to the subcortical U fibers over there. So you just need to remember that. So I'll start now by giving you an example of a neuroimaging phenotype that can be caused by variants in many different genes. In fact, it can be caused by chromosomal microdeletions as well. So that is polymicrogyria. So the way to identify polymicrogyria is to look at the cortex, and you will see the thickened cortex, which you can see over here, and you can also see it in this region here on these T2 weighted images here. So the important thing is that the normal thickness of the cortical white matter is around 2 to 3 millimeters. So it will be thicker than 3 millimeters, might be 4, 5 millimeters in thickness. But the key feature here is look at the gray-white matter junction. So at the interface here, it should be very irregular. It's not smooth, it's very irregular, and that is very, very typical of polymicrogyria. So a thickened gray matter with an irregular gray-white matter interface. You can see the same thing on the T1 weighted images here, very thick and quite irregular on this side as well. And then on this T2 weighted axial image, you can see the polymicrogyria just in this region on the right side, just here. The rest of the cortex is completely normal. Everywhere else, the thickness of the cortex is completely normal. So you can get polymicrogyria if you have a 1p36.3 deletion, a 22q11.2 deletion. If you have a somatic mosaic PIK3CA variant, so PIK3CA related overgrowth spectrum in the tubulinopathies. In Turn-Penny-Fry syndrome, which is a multiple congenital anomaly syndrome that's caused by a specific variant in PCGF2, and then in these entities as well. These are both metabolic disorders, non-ketotic hypoglycemia and Zellweger syndrome. So here, basically, this is a phenotype that doesn't give you a huge amount of clues to what the underlying gene might be. Here's another phenotype, neuroimaging phenotype, that doesn't really give you a very good idea of what the gene might be. So the 3 images you see in the top panel are all from normal patients. So that's a T2 weighted axial image, that's a T2 weighted coronal image, and that's a T1 weighted mid-sagittal image. So if you look here at the pontomesencephalic junction, this region here in the normal, and compare it to what happens in your patient, you can see that they are very different. But how are they different? So the first thing to say is that look at the superior cerebellar peduncles here, and here. They're very thin and they're very short. And if you look here now, you can see the superior cerebellar peduncles are very thick and very long. And this whole appearance here is like a molar tooth. So that's why this is called a molar tooth anomaly. And a molar tooth anomaly is a neuroimaging red flag for a ciliopathy. So that's on axial imaging. What you see on coronal imaging. So on a normal image, you should see the cerebellar vermis here in the middle and the cerebellar hemispheres nicely on both sides. But in your patient with molar tooth anomaly, you can't see the cerebellar vermis at all, and there's perhaps a degree of cerebellar atrophy there as well. And then finally, on the mid-sagittal T1 weighted image. So here, you just look at the brainstem here, and you can see that this is a superior cerebellar peduncle, and it's going from top to bottom like that. But in molar tooth anomaly, and also it's thin, whereas here the superior cerebellar peduncle is thick and is horizontally oriented. It's not going down, it's going just horizontally. So you can see that here. So again, this is a pattern that you can recognize, and it tells you that your patient has a ciliopathy, and your patient could have any of these conditions: Joubert syndrome, Meckel-Gruber, OFD1, oral facial digital syndrome type 6, acrocallosal, and there are a huge number of genes that give you molar tooth anomaly. So it's specific, but not that specific. The next neuroimaging phenotype I want to talk about is pontocerebellar hyperplasia. And this is a neuroimaging phenotype that is caused by variants in fewer genes. And it is possible to actually look at the images closely and perhaps try and differentiate one from the other. But the number of genes that you're looking at are certainly less than the previous two examples I gave you. So again, this is a normal T1 weighted mid-sagittal image, and these are from 2 patients. So what you should see here, look at the brainstem. So that's the midbrain, that's the pons, and that's the medulla, and that's the cerebellar vermis there. So if you draw a line here at the pontomesencephalic junction, and you draw a line here at the junction between the pons and the medulla, you should have a ratio of 1 to 1. So what I mean is that this region here should be 1, this is 2, and then this is 1. Also, what you should see is that the pons is very proud. And if you look at the cerebellum, it should extend from the mid-colliculus here up to the obex, which is here. This is all normal. Now look at this patient here. This is a T1 weighted mid-sagittal image from a patient who has pontocerebellar hyperplasia. The first thing to see is not in the brainstem. If you look at the corpus callosum, that's normal. Here it's thin, but it's still reasonably well present, and all parts of the corpus callosum are present there. The second thing that you can see here is that this patient appears to have a small head. So you haven't seen the patient. How can you tell that the patient has a small head? You haven't measured the head circumference. And what radiologists do is they look at the ratio of the head and compare it to the ratio of the face. And normally this head-to-face ratio should be around 2, 3 to 1. And if it's less than that, then it's microcephalic. And the other thing you can see here is that the jaw is small, so there's some micrognathia. You can see that there's a tube here as well, and that's because this MRI images were actually obtained under a general anesthetic. So that's the tube to give the child the general anesthetic. So here now look at the brainstem. You can see that the proud pons, like here, is not there. It's completely flat. And the cerebellar vermis is really tiny. It extends from below the inferior colliculus to halfway to the obex. So this is pontocerebellar hyperplasia. And because the cerebellar vermis is so small, the cisterna magna appears massive. So this is pontocerebellar hyperplasia with microcephaly and with slightly reduced corpus callosum size, but fully intact corpus callosum. And this is likely to be caused by casque variants. So you can sort of make out that this is probably going to be a casque. If you look at this T2 weighted coronal image, this is, just focus again here on the posterior fossa. So you can see that the cerebellar vermis is present, but it should actually have gone all the way up to here. So it's small. And then you should have seen 2 big cerebellar hemispheres on both sides. Instead, you can see that they are very, very hyperplastic. And this appearance is called a dragonfly appearance. So that's the body of the dragonfly, and those are its wings. So this dragonfly appearance on coronal imaging is very typical of pontocerebellar hyperplasia type 2. And it can be caused by variants in these genes, TSCN54, 2, 34, and 15. But the vast majority of patients with PCH2 will have biallelic variants in TSCN54. So again, this is something that you can just recognize of neuroradiology. And then you can just ask your molecular genetics colleagues to look specifically at the TSCN genes. And hopefully you should get a diagnosis. So I want to move on now to a neuroimaging phenotype that is caused by changes in only 2 genes. And that is horizontal gaze palsy with progressive scoliosis. So these children present with a horizontal gaze palsy. They find it difficult to move their eyes from side to side. And they get very early onset progressive scoliosis. So it's exactly what it says in the title. And this is an autosomal recessive disorder. And type 1 is caused by variants in ROBO3. And type 2 is caused by variants in DCC. And what do you see here? If you look at the T2 weighted axial image here, you see this is the pons, but at the back of the pons, you see this deep cleft. And you can see that the eyes are looking towards each other, indicating perhaps that there is a horizontal gaze palsy. You can see similar findings on this T2-weighted axial images here. So again, the pons is here, and you can see there's a deep cleft, a deep tegmental cleft extending halfway into the pons. And the reason for this cleft is that the commissural fibers that go from side to side are not actually crossing over. And that is the problem that you get if you have biallelic ROBO3 or biallelic DCC variants. If you go slightly lower on the T2-weighted axial images, now you are at the level of medulla oblongata. You can see here that there's a cleft posteriorly and there's a cleft anteriorly. And this appearance is just like the wings of a butterfly. So this is a butterfly wing appearance, very typical of horizontal gaze palsy with progressive scoliosis. But again, you only have to focus on 2 genes. So then this is an entity called Poretti-Bolshauser syndrome, which is an autosomal recessive condition. It's caused by variants in just one gene called LAMA1. And the clinical features are developmental delay, intellectual disability, ataxia, oculomotor apraxia, and retinal dystrophy. And what are the findings? On these axial T2-weighted images, you see that the appearance of the cerebellum is very abnormal. The folia are oriented in a very unusual manner. This is cerebellar dysplasia. If you look at a slightly higher cut, you can see the cerebellar vermis here, and it's got these few cysts inside it. And here you're seeing some early signs of a molar tooth anomaly. Here on the coronal images as well, you're seeing the long, thick superior cerebellar peduncles, again, just like molar tooth anomaly. And then on this T2-weighted mid-sagittal image, you can see that the cerebellar vermis is very, very unusual looking. You can't see a superior and an inferior cerebellar vermis, and you can see all these cystic structures here. So these are all key findings of Poretti-Bolshauser syndrome. If you see this, you can just ask your molecular genetics colleague to just look at LAMA1. That's going to be the diagnosis. So now we move on to another entity where if you can look and recognize this phenotype on an MRI brain scan, then you can not just predict which gene you're going to look at, but you can predict where the variant is going to lie. And that entity is called hypomyelination of early myelinating structures, or HEMS. So for this, you have to go back to the first slide of normal myelination. So what were the early myelinating structures? It was the brainstem, the lateral thalamus, the cerebellum, the posterior limb of the internal capsule, the optic radiations, and the periventricular white matter. So those are the earlier myelinating structures, and then everything else is myelinated later on. But in this condition, what happens is that those entities that should have been myelinated early don't myelinate or myelinate late compared to the ones that myelinate late normally. So these are all images taken in a child that was over 2 years old. So we would expect full myelination across the whole of the brain. But if you look at this T2-weighted axial images here, you can see that there is hypomyelination here of the white matter, which is appearing hyperintense. The subcortical U fibers are also hypomyelinated. If you look at the posterior limbs of the internal capsule, you get this 3-stripe appearance, a white stripe indicating non-myelination on the inside, a black stripe indicating myelination on the inside, and then a 3rd stripe, so here, here, and here. So it gives you this pipe-like appearance. And if you look at the appearance of the thalamus is not myelinated except for this little area here, which is what you would see in a neonate. And here on lower cuts, you can see that the brainstem isn't myelinated and the hilus of the dentate nucleus also isn't myelinated. And on the T1-weighted axial images, what you can see is that this region here, this is all myelinated. It's all white. But the optic radiation here is isoindense. So you can see that this should have got myelinated and should have been absolutely white quite early on, and at 2 years it still isn't. So that's an early myelinating structure that is hypomyelinated. So HEMS is an X-linked recessive disorder. It only affects boys. It is caused by variants in the same gene that gives you Pelizaeus-Merzbacher syndrome, which is also an X-linked disorder. So the gene is PLP1. But this is a very interesting gene. So this gene has got 7 exons here. And it's got the way that it produces 2 isoforms. So the long isoform is called PLP1, and it includes all of these exons here. And DM20, its shorter isoform is called DM20, which doesn't include this bit of exon 3. And all of the variants that cause HEMS sit either in this part of exon 3B or in this intron here. And it basically interferes with the way that this exon is spliced, and it changes the ratio of PLP1 to DM20, giving you an altered ratio. And that is why you get this very unusual type of hypermyelination of early myelinating structures. So if you can make this diagnosis on MRI, then you can tell your colleagues in the lab that this is where they should be looking at for variants. So it's really very helpful. It's very different clinically from Pelizaeus-Merzbacher syndrome. So these kids do have motor delay, but they have normal speech, normal cognition. And then as they get older, you can start to see some cerebellar signs, nystagmus, cerebellar ataxia, and you can also see some mild spasticity emerging. Now, this is an entity which doesn't have a name, but it's caused by a very specific missense variant, ARG37-HIS in SMARCB1. And if you have loss of function variants in SMARCB1, then you get rhabdoid tumor predisposition syndrome. And if you have missense variants in SMARCB1, then you get a type of Coffin-Cyrus syndrome. But this variant is different, and it's got a different episignature as well compared to variants, missense variants that cause Coffin-Cyrus syndrome in this gene. And this is the phenotype. So profound ID, hydrocephalus, feeding difficulties, congenital anomalies across many organ systems, obstructive sleep apnea, and anemia. But the signature finding of this condition is hydrocephalus. And the hydrocephalus can be actually quite difficult to treat. And the reason for that is that if you look at these T2 weighted images here, you see that the choroid plexus is very large. And that is because of choroid plexus hyperplasia. You can see it here as well on the T1 weighted coronal images there, and here as well. So the choroid plexus hyperplasia means that you're producing a lot of CSF, and that is the reason for the hydrocephalus. So once you see this picture on neuroimaging, you know exactly what variant you're looking at and what gene you're looking at. And then lastly, Abhijit has already told you about pontine tegmental cap dysplasia. So you can see here the pontine tegmental cap in all these patients here. But just to say that you can also get cross-fused brachium pontus here. And on the CT bone windows, you can see that the internal auditory meatus is absent on one side because of aplasia of the vestibulocochlear nerve. So I just want to finish by saying that brain dysmorphology is as important as facial dysmorphology for genetic diagnosis. Recognition of neuroimaging phenotypes can help with selection of gene testing panels and analysis of results, and can also help you to pin down not just a gene, but the region of the gene or a specific variant. But more importantly, as Abhijit said, if you see pontine tegmental cap dysplasia on neuroimaging, you don't need to do any genetic testing because you're not going to find anything. So it's just a clinical diagnosis. Thank you.
Thank you, Dr. Suri. It was a very wonderful presentation. First of all, I'd like to thank the organizers, Dr. Ashok Gupta sir, for inviting me for this wonderful conference. And we welcome all the delegates who have come all the way abroad to this beautiful pink city. And till now, we were just thinking neuroimaging for the convulsions and seizures, but you have enlightened us with your very wonderful talk that it can be used in the alignment for the genetic disease also. Thank you. Any questions? Yes, please. Can we have a mic, please? Yes. Thank you. Yes, you can take.
It's working. No.
Your voice is loud, sir.
Now it's working. Yes. Yes, lovely talk. I was wondering, so because, of course, I like your phenotype, genotype, the right direction. I fully agree with this. I was wondering, so these are very specific, and you make this link to facial dysmorphology or other dysmorphology. Do you think, I want to have your opinion on this, would it be possible, because now some of those images for neurodevelopmental disorders, you get these MRI images and they are said to be normal. So you get them back as normal. If you compare this with the situation in the face, then lots of dysmorphic features could be considered, if you're not trained, normal as well. So do you think it might be very reasonable to envision that if you collect enough MRI images for specific syndromes, that you can actually do your dysmorphology on the brain and that is very subtle. So I wonder what your thoughts about this.
Yeah, I totally agree. So, you know, why confine dysmorphology just to face? You can have dysmorphology of the brain. If you've seen enough of, you know, if you see a lot of MRI scans, if you participate in a lot of neuroradiology MDTs, then you have the expertise to know when the brain looks different. And for example, Abhijit is our sort of local expert on tubulinopathies. He's seen so many of them. And so he works with our pediatric neuroradiologists. They sit down together and they read the MRI scans together. And they are able to just look at the MRI scan and say, yeah, this is tub 1A1. They can just tell you, just like that. So it's a skill, but like all skills, it has to be acquired. It takes time, and you need to read lots of MRI scans. But you know, everybody starts somewhere.
So that can be trained.
Yes.
In AI.
Yes. Yes.
Algorithm as well.
And the same for skeletal dysplasias. I mean, just like you can do MRI dysmorphology, brain dysmorphology, you can do skeletal dysmorphology as well. It's exactly the same.
Okay, thank you.
Sir, can we have one more question?
Sure.
I'm thankful to Dr. Ashok for organizing this wonderful conference. And sir, I need to know that in Indian scenario also here, we are having lots and lots of migration defects. Agyria, pachygyria, hemimegalencephaly, and we are having lots and lots of patients of FCDs which are coming up.
Focal cortical dysplasias, FCDs.
Yes, sir, focal cortical dysplasias. And what we are going through is that we have kids coming to us with some slight dysmorphism and seizures which are basically beyond control sort of thing. So you are using 2 to 3, 4 AEDs sometimes to control their seizure, and still we are not able to get them across. So we do have a little bit lack in genetic analysis definitely in our area. Things are picking up, no doubt. But do you recommend that if a person having seizures and we require more than 2 AEDs, so we should definitely go ahead with one MRI and some genetic analysis if we are able to, because sometimes MRI is also not able to pick up the small FCDs.
So that's an interesting question. So I know that you have a 3 Tesla machine here, don't you? You've got a
Definitely.
1.5 and a 3 Tesla machine here. So the 3 Tesla should pick up FCDs. I wouldn't do any genetic testing until you've done your MRI scan. The reason for that is that if your MRI scan picks up FCDs, there are very few patients with FCDs in whom you will find a germline variant that you will pick up on a blood sample. You will find variants, but in the area that is affected by the focal cortical dysplasia. In other words, if you do epilepsy surgery on that patient and you get some tissue from surgery, if you then do genomic testing on that tissue, that is where you will find the variant. So you just need to, first I would say just do your MRI scans. If there's a child who has intractable epilepsy and requires a lot of anti-epileptic medications, I think that's enough justification to do an MRI, certainly. And if you're suspecting FCD, just do it with a with a higher strength machine, do it on your 3 Tesla. So in Nottingham, we have a 7 Tesla machine, but we use it primarily for research. But if I ask our professor of neuroradiology and tell him that I've got a patient who might have FCD, and I want to look specifically for a small focus somewhere, he will put that patient through the 7 Tesla machine. So we can get it done. So Nottingham is where MRI started. So Peter Mansfield, he got the Nobel Prize for that, and he's from Nottingham. And our neuroradiology center is actually called the Peter Mansfield Neuroradiology Center. So.
Thank you. Thank you, sir.
Thank you, Dr. Suri. Dr. Arpan Bhatt, the next and perhaps the youngest speaker of our conference, is the head and consultant of the Genomics and Genetics Division at Sterling Accurus Labs, Ahmedabad. He had made significant contributions to implementing specialized genetic techniques like next-generation sequencing and optical genome mapping at various private laboratories in India. We are delighted to have Dr. Arpan Bhatt with us today, and we look forward to the insights he will share on the topic, Advancement in Genetic Diagnosis of Rare Diseases, optical genomic mapping. Dr. Bhatt.
Can we have the... thank you, Aditi, for the modest introduction. I'm taking this privilege and using this stage to convey some of the new technology, and one of them is OGM, optical genome mapping, which I have worked with more than 100 OGMs myself in the laboratory, and then I'm taking this stage to convey some of the message which OGM can convey, which NGS cannot. So actually I thought of putting this message for the OGM, but when I heard Bert's lecture, I can convey the same to the AI tool which he has worked on. So there are some basic stats which everyone knows now, because maybe we are on the last day of the session, and many of the previously session, in many of the previously session this has been conveyed, and still I'll be going quick. We know that there are more than 72 million cases registered in India for the rare diseases, and we know that more than near about 80% of the cases have the genetic origin. And currently we are standing on the diagnostic yield of up to 60%, even if we consider the best state of art, the laboratory. So still we have gap to address. So this was one of the study Dr. Dipanjana quoted in her lecture. So this was one of the Ahmedabad's very old laboratory running by Dr. Jayesh Sheth and Franny Sheth. They published this paper recently, few months back, and they compiled 22 years of the tertiary care center experience, and they found the diagnostic yield improvement. So if we see that in this era, NGS was introduced. In India, around 2011-12, the panel was introduced, and in 2014, whole exome sequencing was introduced. And in their clinic, the major group was enzymatic and basically we can say neurodevelopment disorders. And they found the drastic change or drastic increase in the diagnostic yield from 30 to almost 50%. So there is a 20% improvement when new technology is added. Now, recently in last 2 years, OGM has come up with the structural variation detection capacity. So it's been 10 years, we can say now after 10 years, the new technology has been added, and we might see the spike in the diagnostic yield. We can say after 10 years someone is presenting, we can see the again 10% spike in the diagnostic yield, 10 to 20%. So what are the routine challenges we face in the genomics setup? The first one is interpretation, that has been widely discussed in this conference, that VUS. Where we get the VUS, it is difficult to interpret and difficult to convey the particular message as what will be the next step. And there are many ifs and buts, do the functional studies or do the RNA-seq to confirm if the particular variant is affecting at the translational level or not. So, but what my focus is today is the detection. So, majority of the time when we say structural variation is involved, we might see one of the variant is picked up by the NGS, but when we see in the autosomal recessive disorder specifically, the other variant is missed, and then we end up with the heterozygous autosomal recessive variant in the whole exome sequencing report, but we might not know what can be the other variant, or we might end up having, okay, there is a heterozygous variant running in the family might be, but patient have only heterozygous, but it is somewhat matching with the phenotype, but we don't know what is the other way, what can be the next step. So there the long read sequencing plays a crucial role in identifying that can be a structural variation above 50 kb, and that there is a major limitation of the short-read genome sequencing where it cannot be used to detect structural variation, and the accuracy is not that high. Or maybe other challenge which we face is variants are basically masked due to biases which we find during the alignment. Okay. So here I'm just comparing briefly some of the routine cytogenetics and next generation sequencing technology. So if we know karyotyping is gold standard till now, I'm not ruling out the karyotyping, but we know the resolution limit even with the high resolution karyotype, it is 5 MB. And because it depends on the cell culture, there is a chance of a specific cell selection we might miss out. Fish, basically we know that is a targeted technology, it doesn't cover the whole genome, and they're difficult to maintain probe libraries, and if you maintain the whole library, there is a huge cost involved. And microarray has also its own limitation, it cannot detect the balance translocation and inversion that we are aware, and also in some of the low mosaic cases microarray fails to imply when we cutoff is the 20%. And coming to the short-read NGS, now the short-read NGS has been a boon since 2014 adding the diagnostic yield up. Still there are some false positives, and also when it comes to structural variation in the repetitive regions or low complexity region, it fails to identify. And also there are some repeat expansion disorders which short-read NGS as of now it fails to do so accurately. And when we say long-read NGS, like PacBio, HiFi and all, there is a huge cost involved with the, even if we consider one case just for the confirmation, there is a huge cost involved, but it is working very well with the structural variation. So just as we know, I'm going to skip this slide, what is structural variation, which everyone knows. And right now in the last few years, various studies identify that there are, if you run the OGM or any other long-read sequencing, we might get more than 20K structural variants in the human genome, which cannot be identified by the short-read NGS. So there is a thing that OGM can be next generation cytogenomics. Can it replace fish or karyotype? So that is a debate, because karyotyping has a 5 MB resolution where it can reach up to 500 base pair, we can say 0.5 kb, much higher than the microarray. So what is optical genome mapping? Briefly, which we can say that optical genome mapping is a technique which can identify SVs that are undetectable. But what it does, it utilizes the high molecular weight DNA, and it is labeled by the enzyme which basically it is a method called DLS, and it is labeled across the genome. And that's why we get the whole genome coverage, and it is loaded into the scanner which is provided by the OGM. It linearizes the DNA, so because it's a ultra high molecular weight DNA, it has to be linearized by the current, and when it moves through the anode to the cathode, the linearized DNA images are captured live, and these are aligned to the reference images which are basically created by the more than 350 genomes by the OGM softwares. Okay, previously they already have a 350 plus genome software, and these live images are aligned to those softwares, and in such manner we will be able to identify deletions and duplications. So if you see here, so these are the reference, this is the reference map, and this is the one of the deletion map, where if there is a couple of labels, these are optical labels, which has basically the spaced roughly as average size of the 5 kb. The average labeling density map is 15 kb per 100 kb, 15 labels per 100 kb. So we get good resolution when the labels are very nearby, and if those 3 labels are deleted, it will not be mapped, and we can see that there is a gap here, so there is a deletion. Such way in duplication that will be added. In inversion, we can see the label orientation is inverted. We can see the new labels are inserted in the particular position. We can see the labels are translocated from one chromosome to the another. Such way we can also measure that repeat expansion that I'm going to discuss for the FSHD cases. So OGM, so this was the recent study published in last few months that OGM has identified structural variant which was hidden by the short-read NGS in the neurodevelopmental disorder. So they used they had a pool of 47 unsolved cases, okay, and they identified 7 rare variants out of those families, and 5 was basically known to have a pathogenicity. So we can say it could improve the diagnostic yield in such cases by 10% at least, we can say. So this was one of the rare variant they picked up. They identified 19.5 kb intragenic hemizygous duplication. That here we can see these levels are matching this region, and then this we can say tandem duplication. This followed by this one. So this is 19. The size is 19.5 kb. Now question comes, why micro? Why not micro array? We know the micro resolution with the 750K array or 1 million array, it is going to be not less than 400 kb. So there the optical genome mapping plays a crucial role. Now coming to the other case, here they found 2.4 kb deletion. That is very small to be captured by the microarray, and here that's why they found some of the diagnostic value. Now this is also a very rare thing. This cannot be picked up by any NGS, I can say. And paracentric inversion, the size was used because we can say paracentric, the 27 MB, and particularly it was mosaic, not the. This was also one of the interesting case study published for the ATRT, the tumors, in which they did the sequential assays in the family. I'm going to take you the pedigree. So two siblings, they had the ATRT tumor identified in early stage, neonatal stage only. For the first case, they did certain assay which cannot be, which basically did not yield any diagnostic value. So for the second pregnancy, when it occurred, it was the repetitive case, then they opted for the OGM. But why before opting OGM, they did first of all IHC, immunohistochemistry, and SMRC B1 staining was absent in the tumor cells. Then they did the SNP array just to check the LOH, and both the tumors showed the heterozygosity, loss of heterozygosity in the Q arm of the chromosome 22, but breakpoints is a bit different in both the cases. And to check what is actually happening at the transcript level, they took the RNA, did the sequencing at the cDNA level, and they found there is a low level exon 2 skipping is happening, because they found in some of the reads after exon 1 that directly exon 3 boundary is starting. So we can identify that this is actually a low level mosaic exon 2 skipping. Now because it was suspected to have predisposition, they identified something is there in that particular region, so they used the long read PCR, but somehow they were not able to amplify because of the predicted to have a repetitive region in that particular thing. So this was the map of the short read sequencing. We can say this is the patient where the reads are heterogeneically mapped. It is not accurately mapped. So suspecting it is not mapping with the the coding region where what we know, and these are the parents. So here there are some reads in the maternal side that they suspected to have a maternal origin. But when they did the OGM, they found there is a almost 2.8 kb insertion in the intron 2. That is basically confirmed by the PacBio sequencing that it is a sign element, repetitive element, and we can see there is a couple of reads supporting this insertion by the PacBio. So OGM have the capacity to identify repeat expansion. This is one of the unpublished data, C9 ORF 72, where the mosaic repeat expansion was captured. That is basically difficult to identify by any NGS method, because here we can have the leverage to check each red separately. We can identify it's a mosaic or non-mosaic case. But here they identified a variety of we can say insertions in the repeat region. Now, while looking at the facioscapular humeral dystrophy 1, in such cases we have a huge repeat contraction in the 4QA allele in the pathogenic cases. If you see, it has an evident structural map for the 4QA and 4QB, where they measure the flanking labels, the distance between the two flanking labels around the D4Z4 repeat, and such way they identify it is a and they count if that is a less than 10 D4Z4 repeat, it is reported as a pathogenic. And in laboratory we reported more than 50 cases with OGM for FSHD. So how it looks like for the routine, this was the animated view and how it looks like. So there are, with the variety of haplotypes we find, there are 4 haplotypes for the FSHD, 4QA, 4QB, 10QA, 10QB. So I'm putting just images for the example how we can capture the mosaic of FSHD as well. In such cases, if you see, there are 1 repeat unit with the coverage of 37 and 8 repeat unit with the coverage of 90 for the 4QA pathogenic allele, and there are 12 repeat units for the coverage of 41. That's how they identified there is a mosaic. Even in the pathogenic allele count, there is a mosaic reads which cause the FSHD. And this was the map where 4QA and 4Q. This is the routine map we see when both the 4QA is contracted from 6 and 9. For the average Indian, I will say for the Indian genome, the repeat size is more than 30. For the it can also identify the camouflage region. If that we know that CR1 and such genes where there is an external binding domain, it cannot be checked by NGS. But if there is any variation in certain region, it can be checked by the we can say OGM. We can say it can also detect the mosaic deletion up to, there is an example of CDKL5, it was in X-link case, they found 90 kb mosaic deletion. So the question comes, does OGM is sufficient to identify majority of the variant? The answer is definitely no. We have to do the NGS along with the OGM to get the holistic view of the genome and identify if there is any variant, if missed variant picked up or not. So there is a resolution map beautifully designed by the OGM. So here we can see long read sequencing, it basically going up to 40-50 kb in considering PacBio. But OGM has basically coverage till the we can say it is one longest read we identify up to 5 MB in the OGM. So there are scope to map the long reads beautifully with the OGM, and I can say another upcoming technologies. So what NGS and OGM combinedly, what both the techniques are complementary to each other in certain cases. If we do combined study, we can address the most of the cases where repeat expansion, repeat contraction, inversions, and and translocation which is not picked up by the NGS. So there was one example, autosomal recessive leukodystrophy syndrome, where there was a 17.9 kb deletion in one of the allele, and other allele had a point mutation which was captured by the NGS. So here we can see the combinatorial technique was very well used, and it was published in 2023. Now the question comes, is there any better technology than OGM in the structural variation detection line? Yeah, we can say yes. Recently NBCS has come up with the electronic genome mapping. The concept is almost same. It labels the DNA which is same as labeled by the OGM, but the detection where in OGM it was happen optically. We can say there was a laser in the OGM which when there is a fluorescence it was captured by the optical genome mapping machine. But here when the label DNA passes through the particular chip, there is a voltage change which is captured by this machine, and the capex cost of this machine is very low in compared to the OGM, and that's why they are putting the, that's why I have kept cost comparison of the we can say IGM and OGM. So we can say that they are claiming EGM to be the lowest cost for the structural variation detection. So in conclusion, the addition of the new technologies, efficient technologies in diagnostic setup greatly reduces the diagnostic workup timeline, where we see with unsolved cases, patient goes undiagnosed till the decade. But when we add such new technologies in the diagnostic setup, we can improve the diagnostic yield and reduces the diagnostic workup timeline for such patients. And definitely it is going to help clinician to understand the unsolved cases, and they can plan the disease management. So that's all from my side. Thank you for taking up your lunch time.
Okay, Dr. Arpan, we have a small question from you.
Yes.
Thing is that pediatric endocrinologist and genetics, these people only come together when there is something fishy about some patient.
Yes.
So when we have a non-classical CH,
yes.
So in non-classical the presentation is definitely late, and we pick them up with definitely with when the child grows up. So in this scenario, since the gene size is big, so you recommend that OGM is helpful in going through this thing, or should we have a long sequence NGS for this particular gene?
So first of all, OGM, so we can say long read sequencing when there is a mutation is involved, but in cases where there is a large insertion or in the repetitive region, so where OGM plays a good role rather than PEG bio, because PEG bio is going to be too costly, and OGM has come up in the Indian setup as well around $300 to $400. So the cost of the test is not that high as compared to the PEG bio. So first of all, we should rule out with OGM, and then I think we can go for, if something is not fruitful, we can go ahead with the RNA-seq or some expression things that actually it is affecting at the transcript level or not, but not directly the long read sequencing.
Actually, we get only one shot from the patient for genetic analysis.
Yeah.
Definitely the cost is involved, and it is not in the government sector, so we need to be very sure that what we are recommending. So generally MedGenome and other companies, since they are the private players,
yes,
we do get reports, but in this particular aspect, they also refuse to do it because sometimes they're not able to get through. So I think if the OGM is the breakthrough, so we can definitely recommend OGM for the patient.
So see, in the first slide I mentioned when NGS was introduced, it was like it increased the diagnostic yield from up to 20-30% since 2014. Now the genome mapping techniques has been introduced. So the detection issues which were facing for the structural variation, the large variation in CNVs, that might go, can be addressed. And the Indian setups, it is not very common. Only some of the lab has basically OGM technology, and now the upcoming technology EGM. Now I think that can be installed in coming years, and the combinatorial approach can be, if we are having one shot, we can have both shorted and OGM or a EGM that can address this issue.
Thank you, Dr. Bhatt. I think we are close to lunch.
Thank you.
So we'll stop taking further questions and head on back.
Thank you.
Thank you, Dr. Arpan. With this, we come to the end of the session. To felicitate our guest speakers and also our chairpersons, I would like to invite Dr. Anju Kumar, who is the consultant, Obs and Gynae, Cardiff and Wales University Health Board, University Hospital of Wales, UK, and is also the director of the Genomic Medicine Foundation, UK, and also the proud wife of Dr. Devendra Kumar. Thank you so much, ma'am. Can I now invite the chairpersons, Dr. Somshekhar Nimbalkar, Dr. Rajpreet Soni, Dr. Anurag Tomar, Dr. Atul Gupta, and Dr. Prashant Mithalwal. Can I now request the guest speakers, Professor Bet Fries, to please come on the stage, and Dr. Arpan Bhatt. Dr. Arpan Bhatt. In order to do the felicitation for the recent poster and paper presentation, I would like to invite Dr. Priya Marva to please take the mic.
Thank you, Dr. Aditi. Good afternoon, everyone. We are just going to take a short detour from our academics to felicitate the prize winners and the organizing committee. So as we gradually move to the final lap of the journey, one thing is crystal clear. The so-called birth defects or the rare diseases are not so rare after all. What is rare about them is the number of doctors interested in learning about the birth defects. So on behalf of the organizing committee, I extend my sincere thanks to all the wonderful speakers and the delegates for making it a beautiful feast of information, recent advances, and future prospects. I now request the organizing committee members, the chairpersons, Dr. Devendra Kumar, Dr. Ashok Gupta sir, and the organizing secretary, Dr. Aditi, to please take their place on the dais. Dr. Devendra Kumar sir, Dr. Ashok Gupta sir, and Dr. Aditi to please take their place on the dais. And I know the audience is quite sparse, but hope to hear a loud round of applause for the chairpersons, please. I request Dr. Anurag Tomar to felicitate Dr. Devendra Kumar, the organizing chairperson. I request Dr. Helen to please come up on the stage and felicitate Dr. Ashok Gupta, sir. Thank you, Dr. Helen. Thank you, Dr. Anurag. I request Dr. Dravendra Kumar to present a memento to Dr. Aditi Singh, the organizing secretary. I request the respected chairpersons to please stay back and honor the organizing committee members. Special thanks to Dr. Vaibhav Upadhyay and Dr. Tushita, the joint secretaries for this conference, for their unstinting support in organizing the finer details. Dr. Vaibhav Upadhyay and Dr. Tushita, please. This smooth journey would not have been possible without the support of my lovely assistant professors who helped us sail through the conference effortlessly. So let's hear it for them. Please give them a huge round of applause. And they are also the organizing committee members, Dr. Gunjan Agarwal, Dr. Nikita Pal, Dr. Trapta Goyal, I call upon the other organizing committee members, Dr. Shipra Majumdar and Mr. Kedar Negi. Thank you, respected chairperson, sirs. We received a large number of posters and papers for the academic competitions. So I now request Dr. Reena Das to please do the honors of felicitating the winners.
Yeah, just before that, we have one felicitation for you. Priya has been working very hard, and she's been very, very perfect and immaculate. So, sir.
Thank you so much, sir.
I just wanted to make another big announcement about this conference. This conference has been given 18 hours of credit point from the Royal College of Physicians of UK. So it's a very big achievement, and Professor Devendra's ability and his recognition brings us this laurel. So a big round of applause for Professor Devendra Kumar. and a matter of great pride for our institute that our meeting is credited from UK too. Thank you.
Thank you and congratulations, sir. At the outset, I extend my heartfelt thanks to the jury of the poster competition, Dr. Abhishek Sharma, Dr. Gaurav Agarwal, and Dr. Abhishek Saini. I now request Dr. Reena Das to please honor the winners. The first prize for the poster competition goes to Dr. Anil Kumar. Dr. Nishtha Gupta is the first runner-up. We had a lot of interesting papers for the paper presentations, and the jury for the paper presentation competition were Dr. Jitendra Gupta, Dr. Rajveer Singh Yadav, and myself, Dr. Priya Marwa. I request Dr. Reena Das to please continue with the proceedings, and the winner of the paper presentation competition is Pramiti Parikh. Let us hear a huge round of applause for this young lady. She is the final year MBBS student, and she deserves a huge round of applause, please. Let's hear it for her. We have two runners-up for this, Dr. Ankush Khanna and Dr. Avani Verma. Can I have Dr. Shipra Majumdar on the stage? She was one of the joint secretaries, and I think I missed out in announcing that. Dr. Shipra, let's hear it for us, please. So we now break for lunch and hope to be back in 40 minutes, 30 minutes for the next session. Thank you so much.
I need to do. And for Helen?
Okay, thank you. Don't worry about it. Just delete it. Many thanks. Don't worry.
We are placing the boxes for the mementos. If you need, you can keep your mementos in these boxes. Thank you.
plastic वाली
يصير فيما يصير لازم يغيب العقل روح شوية زين حوايج يولي يموت ويفنى عليها روح شوية مع الأخرى
done. I got it.
मेरे को ये देखना है कि चेयरपर्सन किसको बनाना है। आ तो जाए लोग थोड़े से।
जो आ जाए उनको बिठा दो वहीं तो फैकल्टी में।
डॉक्टर कनुप्रिया को बिठा दो।
कनुप्रिया को बिठा दो और उधर से
वीरेंद्र गुप्ता आ रहा है क्या?
अपने नाटा साहब को, नाटा साहब तो बोलने वाले हैं, नाटा साहब तो स्पीकर देयर करते हैं और आने वाले हैं। मेरा जल्दी करा दो बिकॉज आई हैव टू लीव टुमारो टू सिडनी।
तो बता दिया ना मुझे। 5 का आया। जब आप खुद 5 मिनट
तो उसको बोलना पड़ेगा फिर मेरे को।
म्यूजिक बंद कर दीजिए प्लीज. So we are ready to begin with the post-lunch session. The chairpersons for the first two talks are Dr. Ashutosh Chaturvedi, Dr. Abhishek Sharma, Dr. S.P. Sethi, Dr. Virendra Gupta, Dr. Kanupriya Chaturvedi, and Dr. Mamta Meena. So whosoever is present in the audience, please, I request them to take their place on the dais. Our first speaker is Dr. Sunil Kaushal, Director and Chief Cardiac Surgeon, Mahatma Gandhi Hospital, Jaipur.
We'll stop. Such a poor show. You ever seen a validatory function being done halfway through the conference? Myself never seen in last 30 years. Sunil Kaushal. Respected Chairperson, dear colleagues, thank you very much, organizers, for the opportunity, if you call it opportunity. I will be presenting rare tumors of the cardiopulmonary origin, basically covering 3 lesions, bronchogenic cyst in neonates, rhabdomyoma of the right ventricle, and Comerel's diverticulum. Neonatal bronchogenic cyst presented 28 days old male baby born at 34 weeks. So presented with a severe respiratory distress, and he was shifted to NICU, and he was worked up there and shifted to RICU. And after CT, it was diagnosed to have a query forward duplication cyst or a bronchogenic cyst. Incidence is very rare, approximately 1 in 50,000 birth defects. Only 10% complicated symptomatic patients require treatment. Mostly asymptomatic till late stage. This was his X-ray suggesting a big mass-like lesion in X-ray. And you can see by arrow suggesting a bronchogenic cyst, mass in mediastinum in the pulmonary in between the cardiopulmonary area. So this was what I showed on, but echo showed only PFO. So approach through the lateral posterolateral surgical approach was lateral thoracotomy, posterolateral. This is heart. As you can see, first we have to divide the PDA. This is PDA to access the cystic lesion there. Then around aorta we mobilize. This is retroaortic area. You can see the cyst here. This is the cyst after division of PDA. You can see the cyst. Then we mobilize. This is ascending aorta, esophagus. It was compressing on the esophagus. That's why baby was irritable, not able to take feed. It was pressing over the bronchus, which you still can't see here. We have to further mobilize it. That area you can see, this is the bronchus, left bronchus. This is the cystic mass. This is the cyst filled with fluid. To mobilize all around, this is that left bronchus. This is aorta. This is P posteriorly, it's esophagus. This is for clamping the cyst and excising it. You can see the whitish fluid came out. This is after the excision, the bronchus, this is aorta, posteriorly the esophagus, this is left bronchus, this is that excite mediastinal tissue. The baby was extubated on 3rd post-op day and went well. Histopathology confirmed it's a no malignancy, it's only bronchogenic cyst. So early diagnosis and treatment is of paramount importance, and in differential diagnosis, you have to always keep this, though it is rare in neonates presenting with persistent respiratory distress cyanosis. So it's another case of rare birth defect, cardiac rhabdomyoma in a neonate. It's very, very rare, 0.0 to 0.08%, but most of the babies, 70 to 90% have underlying tuberous sclerosis, TSC complex, so we have to investigate them for that part as well. So diagnosis was made on the basis of echo and CT angio. Usually it is treated conservatively if it is smaller, but herein because of the huge size of the RV tumor, it was compressed, it was obstructing both inflow and outflow of the right ventricle. So baby was approximately 20 days old and 2.6 kg and came to our ICU, severe respiratory distress, walked up and shifted to our ICU. So usually they are treated by mTOR inhibitors, the sirolimus and all, but because of the huge size of the tumor, it was obstructing both inflow and outflow of the right ventricle. This is the pre-op echo. You can see it was filling up the whole right ventricle, squashing the left ventricle as well. This is the left ventricle. You can see pushing the septum into the LV, the huge size of the tumor. We went through the midline sternotomy. You can see the RV is full, distended, mild dysfunction as well. You can see the both right ventricle outflow, the MPA and aorta both were clamped and gave cardioplegia, so that while taking the cardiac tumor in piecemeal, it should not go into the lungs. This is how we are opening the RA. This is, you can see the right tumor was popping through the tricuspid valve after opening the RA. Tumor is being excised. You can see the MP and aorta both are clamped. It is being excised out in piecemeal. You can see the sucker is in between the tumor and the right ventricle free wall. This is free wall. It was very adherent to the myocardium. See, this portion is coming out. You check the papillary muscle was inserting into the tumor mass. You can see this tumor mass, island of the tumor was taken along with the papillary muscle. This is anterior papillary muscle, this is anterior tricuspid leaflet. So after checking the competence here, we realized it's coming out. We were quite aware of it because we excised the part of tumor along with the papillary muscle. This is that area. This is anterior tricuspid leaflet. This is papillary muscle along with the chordae. That's why there is a severe TR here. This is your leaflet. This is the base of the pericardium, papillary muscle along with the part of the tumor, which is being transfixed onto the interventricular septum, this papillary muscle. This is being transplanted into the interventricular septum now. This is, you can see, is tied. Now checking the tricuspid valve, just compare that previous TR and now we have to do some tricuspid endoplasty as well. So there is hardly any TR now. Mild TR. This is the post-operative echo. It's a mild TR. We have to leave a decompressive ESD also to compensate the RV dysfunction. You can see the RV is dysfunctional, but there is no tumor mass there now. This is post-operative RV, still distended, dysfunctional because of the lot of excision. Postoperative chest was kept open for a few days, and after that chest was closed and baby was weaned off. But there was persistent RV dysfunction for many days with some arrhythmias. So baby was kept on Codron. This is postoperative echo. Is RV fully cleared of cleared of tumor. Biopsy showed rhabdomyoma. Right now, patient came for follow-up after 3 months. Is doing fine. RV is much better now, and TR is much lesser now. Same proper prompt recognition, decision making, early detection is necessary for the early better outcome. So one more case, Comeral's diverticulum. It's a diverticulum of the base of the subclavian artery and descending aorta, usually associated with right aortic arch and aberrant subclavian artery. Most of the time it is left aortic arch with aberrant right subclavian artery, or sometimes it is right aortic arch with aberrant subclavian artery, which is much rarer. So only 50 cases has been reported in the literature so far. This is the schematic diagram suggesting, you can see the aberrant right subclavian. This is aberrant left subclavian. The two types of right aortic arch. Usually the symptoms of compression are dysphagia, dyspnea, coughing, pneumonia. Mostly patients are asymptomatic if they are not aware. Otherwise, there is a risk of sudden rupture of the aneurysm. As you can see here, it is aneurysm is here. It is compressing the esophagus. This is that you can see diverticula. This is that red star is Comeral's diverticula. It is pressing over the, along with the aberrant subclavian artery, pressing over the esophagus and trachea, bronchus. So another CT suggesting the same thing, Comeral's diverticula, aneurysmal dilatation, compressing over the bronchus. We did through the left posterolateral thoracotomy. The Comeral's diverticula is excised, that bulbous thing is excised. I lost that video. It is being clamped, and after excision it's being, aorta is being repaired. As you can see, it's a clamp here and aorta is being repaired. This is after the subclavian was taken off the descending aorta. This area was, then it was anastomosed to the left common carotid artery. This is the left common carotid artery. This is left subclavian artery. This is that clamp. This is after the, this is being repaired, the final stitches. Now clamp is coming off in this picture. Clamp is off. You can see this is left subclavian, anastomosed to the left carotid artery. So it's basically tumorous diverticula is repaired and left subclavian is anastomosed to the left carotid artery. This is that after the excision, this is descending aorta, this is esophagus, this is the excised PDA. This is that repaired left subclavian to the left carotid artery. Below is the Comeral's diverticula. So it's excised and repaired through the posterior thoracotomy successfully with the repair of aberrant subclavian artery. Thank you very much.
Sir, I wanted to ask a question. In case of rhabdomyosarcoma of heart, how we manage the patient medically before the surgical procedure can be done? Because there is a LV or whatever the dysfunction was there, you have shown the images like there is a dysfunction of cardiac. So the surgical procedure, it will take some time, and how will we manage the medically that patient?
No, if it is patient is symptomatic, means it's obstructing somewhere at the inflow or outflow and causing dysfunction, because with adherence to the myocardium, it can cause arrhythmia as well. So baby will be hunger, so there will be a hunger kind of symptoms. So So in that situation, there is no other way out except we have to refer the patient to further surgery, whatever be the stage or age of the baby. So if it is much smaller than that, like if you for if you just for eyeball purposes, the small size is smaller or 1/3 of it is which you saw on echo. So it can be managed by those conservative medicines. If the size is half of that tumor, then you can hold on for a few months. So, but patient has to be free of obstruction, inflow or outflow obstruction. Then only you can manage conservatively. But most of the rhabdomyomas are managed conservatively, but they are not that big. So, like in 27 years, I have encountered first this size RV tumor. So, mostly the cardiologists manage on their own.
Okay, thank you.
Thank you. Thanks.
Thank you, Dr. Kaushal. May I now request Dr. Dharvendra Kumar to please felicitate our speaker and the chairpersons of the session. Thank you, sir. Thank you, chairpersons. For the next session, the chairpersons are Dr. Somshekhar Nimbalkar, Dr. Meena Nayak, Dr. J.K. Mittal, Dr. Siddharth Rathore. Anyone here? I request Dr. Aditi and Dr. Arjun Verma to please chair this session. And I now request Dr. Vijay Nahata, Director, Gynecological Endoscopy Unit, Mahatma Gandhi Hospital, to present his case. Thank you.
No, Vijay Nahata. So, good afternoon, everyone. So, me with my two colleagues, we have come across a case which is one of the rarest of rare case of Mullerian and this thing. Miss X, 14-year-old, resident of Jaipur Rural, came to us around 2 years back. She was having dribbling of urine since birth, then cyclical pain abdomen for last 1 year, episode of spotting per vagina 1 year back. Then presently she is using colostomy bag. Past history was birth history, preterm vaginal delivery at 8 months gestation. Then surgical history when she was at 1 month of age, colostomy was done for anorectal malformations. Then in 2008, 2 vaginal opening, 1 common, and there was some common channel mobilization was done. Then trans-abdominal rectal pull-through approach through catheterized bladder was done. And in February too, because of some previous problem in the previous colostomy, they did again a repair of colostomy and again one cecostomy was done. And in July 22, again she went for the vaginoscopy because of this cyclical pain. Then when she came to us, the uterus was palpable. Local examination was showing continuous urinary dribbling since birth, and there was absence of external urinary orifice, and evidence of anal atresia was there. The anus was not found. Vagina was only tip of finger, and investigation showed ultrasound was showing uterine didelphys with the cervical atresia, hematometra. Then MRI was showing a high variant of anorectal malformation with the lower anorectal agenesis. Then rectovesical fistula, uterine didelphys, duplex vagina, didelphys, again same thing. Then kidneys were normal. These are some MRI pictures which is showing this hematometra and that dormant uterine horn. The same thing in the steer image, again some hematometra and that dormant utricle and this duplex vagina, and this again this is showing kidneys were normal, but bladder was having some air inside, so that was showing that there is some fistula is there. Then CECT was almost similar finding. There was congenital pouch of colon with cecostomy at left upper arm. Urinary bladder is minimally filled with interluminal air, so that was showing that some fistula is there, and Mullerian duct anomalies as was in MRI. So management in the last 2 years, what we have done is, first of all, when she came, we thought of removing the uterus for alleviation of her cyclical pain, and we discussed with the GI surgery because of the previous cecostomy, but their suggestion was that this is unoperable. So then we approached interventional radiologists. They did a bilateral uterine artery embolization that worked for just for 2 months, in 1 month, but practically it was not very effective. Then he did a USG guided aspiration of hematometra and keeping a pigtail catheter, introducing the endometrial cavity, but a very little amount drained. And because it was not working, then we kept her on medical management to stop her menstrual cycle. We gave GnRH analogues. Then again she had some severe pain. Then again USG guided aspiration was done, which only we could retrieve only 70 cc of pus. Again we have kept her on different hormones, letrozole, then GnRH, then Dynogest, which is a very effective drug for stopping the menstrual cycle. But this young girl, we cannot keep on very longer hormones because of the other side effects of hormone like osteoporosis and others. So now the key challenges in this case are the reproductive system, the uterus with the hematometra, urinary tract, the continuous dribbling of unidentified level, a urinary tract anomaly, and GI system, anal atresia, short gut syndrome, and cecostomy twice. So prognosis and long-term plan in this case depends upon if we can get some daring surgeon who can associate with us to remove this hematometra or that horn, which is the active horn, and close monitoring because she is very prone for urinary infections, and regular gynecological and urological gastrointestinal assessment. When we had a talk with this patient, they are very desperate because of they are facing for last 14 years. They are ready even that for DOT, that means death on table, but let's see. today in the lunch time, I was discussing with the Dr. Nitin Khuteta. So he has shown some courage that he will take this case and help us, this suffering girl and the parents, which is a very, very real problem. So, and definitely psychological support we are giving, but it's not how this can be useful. So now in the heavy post-lunch audience, I will like the opinions of all these very learned audience that what else we can do in this case. Sir.
Okay. Yes, a very good case from the malformation from syndrome point of view. Will describe as a Merck's association. If you look at literature, find Merck's, it's a sequence of anomalies, Mullerian agenesis, and then lower colorectal, urinary, all those things. Plus, they also got the lower coccyx and lower spine, sacrococcygeal abnormalities. In terms of syndrome, there's a syndrome called Kaufman-McKusick syndrome. But they have, in addition to these anomalies, they have polydactyly, they have a congenital heart disease, and some other brain abnormalities as well. We have got quite a significant number of genes for that rare condition. And so that's also recessive and seen in Turkish families. I had one family from northwest Pakistan living in UK now, and they had 3 babies born, and 2 females, 1 male. They've got a lot of severe hypospadia, so severe abnormal male genitalia. I think what your plan is absolutely correct, because I think either giving that surgical operations plus this thing, and I think you have to manage as you're managing. I'm not in favor of surgical intervention. I think it will add to the discomfort, and she's losing years of learning education. The more she'll go for surgery, she'll not go to school. She'll not learn the skills. So I would focus more on that kind of support, so that she becomes independent, And as far as I think.
How to healing from that cyclical pain?
Well, that I think I mean my.
Let me try to say, I don't think so. I've come across that severe kind of one. I've come across Mullerian agenesis with diadelphus, with cervical agenesis. But I was able to dilate through, create an artificial, because there was access to vagina, was able to drain it through the vaginally, the hematometra, and dilated it quite regularly and gave regular estrogen, as well as put coil in to be able to get that passage open. But I think my patient didn't have as much. I'm not sure. Originally, there was a fistula. There's no access at all. So I think the only other things you probably need to end up doing hysterectomy, really. But how you're going to do it, that's a difficult one because of previous surgery.
We have found a very daring surgeon.
Daring surgeon. Maybe he will do it.
Thank you.
Thank you so much, sir. I request Dr. Anju. Sir, ma'am is also a gynecologist, to please honor Dr. Vijay Nahata, sir. Ma'am, I request you to please felicitate our chairperson, Dr. Arjun Verma. Ma'am, this is a special request from the House that we want Dr. Anju ma'am to chair the next session. So I request you to please take your place, and I request Dr. Reena Das to please come up on the stage and chair this session. Dr. Sumit Patodia. So the next speaker is Dr. Manju Bhaskar. She's a professor and head, Department of Psychiatry.
Presenter's view. So I am going to present a case of 19-year-old male studied up to 11th class. He belonged to Kota, Rajasthan, and he was brought by his father and elder brother to psychiatry OPD with chief complaints of disturbed sleep, aggressive behavior, increased appetite, talkativeness, increased libido. Total duration of illness was 10 days and symptoms were abrupt in onset without any precipitating factor. Now, history of presenting illness. So, progression of symptoms, day 1 to 2, he had a disturbed sleep. The informant reported difficulty in falling asleep and waking up frequently. Despite reduced sleep, the patient showed no signs of fatigue. Family members noticed increased energy levels which were out of proportion to his usual behavior. Day 3 to 5, he had talkativeness. The patient exhibited excessive and pressured speech, often initiating long and animated conversation with those around him. His speech was rapid, difficult to interrupt, and often disconnected or tangential. He became very irritable and confrontational, particularly when his idea or behavior were questioned. Family described him as out of character during these interactions. Patient displayed a marked increase in appetite, demanding food frequently and eating significantly large portions than usual. Increased libido, he made inappropriate sexual remarks and exhibited behavior suggestive of hypersexuality which were unusual for him. Day 6 to 10, the patient expressed exaggerated and unrealistic belief about his abilities, claiming he was extraordinarily talented and destined for greatness. Patient reported hearing of voices of God in which the God told him to do something great in life. Patient refused to acknowledge any abnormality in his perception or behavior, lacking insight into his condition. Past history, there was a history of epilepsy at the age of 3 years, for which treatment was taken for 2 to 3 years and then discontinued by family members without medical advice. Family history of psychiatric illness was present in father, who was a known case of bipolar mood disorder, and elder sister, she was diagnosed to have a psychosis NOS. Personal history. Birth history. He was the youngest child in the family. He did not cry immediately after birth, admitted in the NICU for 3 to 5 days, query due to fever as reported by the informant because details were not available. Developmental milestones. He had delayed walking around 20 months of age, pincer grasp 14 months, bisyllable words 14 months. Held during childhood. Frequent behavioral challenges such as temper tantrum, bedwetting, and thumb sucking was present. Patient was immunized according to government policies, and history of epilepsy at the age of 3 years. There was no other history of any chronic medical illness. Temperament of the child. He was excessively attached to his mother during early childhood, introverted and struggled with adaptability, easily influenced by peers, leading to occasional inappropriate behavior. adaptive functioning, patient he was unable to dress himself properly until 5 to 6 years of age and frequently wearing shoes incorrectly. Excessively attached to his mother during early childhood reflects difficulties in emotional regulation and social independence. Personal history, schooling and education, academic performance and behavior at school, socially withdrawn with poor adaptability in group setting, required constant support and supervision from teachers. He struggled significantly with overall academic subjects, difficulty in following instructions and completing the task independently. Extracurricular activities, he enjoyed singing and showed a keen interest in music, though participation was limited. In general examination, he was tall and thin with long limbs. Height was 185 centimeters, weight was 60 kg and BMI was 17.54 kilogram per meter square. Facial features, he had long and narrow face, prominent nasal bridge with a high arched nose, high arched palate, large protruding ears. Hands and feet, he had long slender fingers, arachnodactyly was present, hyperextensible joints. Vital signs were within normal limit. In his skin and hair, there was no unusual pigmentation or abnormalities observed during examination. In systemic examination, there was, in CNS examination, there was no focal neurological deficits were present. Cardiovascular, respiratory and gastrointestinal system was within normal limit. But in musculoskeletal system, patient has long, thin limbs with hyperextensibility of joint. There was no deformities or tenderness in joint. Gait was mildly unsteady. Mental status examination, general appearance, patient appeared disheveled, wearing bright mismatched clothing. He was alert, overly energetic and restless with exaggerated gestures. Behavior, he was hyperactive, unable to sit still, pacing in the room. He demonstrated inappropriate laughter and intrusive behavior. Attitude towards the examiner, he was overconfident, demanding and occasionally dismissive of the examiner. He was cooperative initially but he became argumentative when challenged. Speech was, he had a pressured speech, loud and rapid, hypernasal speech was present. Frequent interruptions and difficulties staying on topic. He was jumping from one topic to another topic, that is called flight of ideas. Mood was euphoric, overly cheerful and elated. Affect was highly labile and exaggerated, inappropriately elevated even during serious discussions. Thought content, he had delusion of grandiosity. Patient insists he has special powers and is the chosen one destined for greatness. He claims that he is the best artist in the world without any evidence. Perception, auditory hallucination. Patient also reported hearing voices of God telling him to do something great in life. Cognition, he was alert and oriented to time, place and person, but he was distractible during examination. Judgment was grossly impaired as evidenced by unrealistic plan and impulsive behavior, such as spending money excessively to prove his worth. Insight was absent. Insight was severely impaired. The patient denies any mental illness, attributing concern to others. He was telling that it's not my fault, I don't have any problem, but my father and all, they have brought me to hospital, so they may be having some problem. Investigation, biochemical investigations were done, hemoglobin, WBC, peripheral smear, RBS, LFT, RFT, thyroid function test, serum vitamin B12, parathyroid hormone, they were within normal limits. Investigation, 2D echo was done in view of some ECG abnormalities. There was trivial TR was there, but otherwise normal LV function. MRI brain and EEG was done because there was a history of epilepsy in childhood, but it came out to be normal. Ophthalmology reference was taken to rule out any ocular abnormalities, but that was also within normal limits. So based on the history and mental status examination, psychiatric differential diagnosis was mania first episode versus acute and transient psychotic disorder. Because patient had mainly mood symptoms, elevated mood, increased energy level, talkativeness, increased sexual energy, disturbed sleep, aggressive behavior, and that lasted more than 7 days. So the diagnosis was more in favor of mania first episode, and ATPD was ruled out based on psychopathology. Second was, along with psychiatric disorder, patient had marfanoid features, intellectual disability, and psychiatric symptoms. So we suspected there could be some genetic syndrome. So first was Lausanne-Franz syndrome. In this syndrome, there are presenting features are mild to moderate intellectual disability, mania with psychotic syndrome, long cylinder fingers, arachnodactyly, hyperextensible joints, long and narrow face, prominent nasal bridge with high arched nose and tall stature. Exclusion, we could not exclude this diagnosis because features align with the case, like psychiatric symptoms, arachnodactyly, facial and joint findings match the diagnosis. Second possibility was Fragile X syndrome. It was, but in Fragile X syndrome, there are moderate to severe intellectual disability, long narrow face, but in Fragile X syndrome, mostly they have macroorchidism, but in our case, there was no history of any macroorchidism, and psychiatric features like mania, they are rare in Fragile X syndrome. Then third differential diagnosis was Marfan syndrome. In Marfan syndrome, there are long cylinder fingers, joint hypermobility, tall stature, cardiovascular issues, ocular findings, normal or near normal intelligence. It was excluded because there was no cardiovascular abnormalities or lens dislocation. Psychiatric symptoms are atypical in this condition. Homocystinuria. In homocystinuria, there are intellectual disability like psychiatric symptoms, long cylinder fingers, joint hypermobility. But in our case, there was no thromboembolism or lens dislocation as ophthalmic consultation was taken and that was ruled out. And in biochemical investigation, serum homocysteine level was within normal limits, so this condition was ruled out. Last was Ehlers-Danlos syndrome. In this condition, there are hyperextensible joints, skin hyperelasticity and fragility, easy bruising, poor wound healing, and normal intelligence. It was excluded because there was no skin hyperelasticity and there is presence of intellectual disability. In conclusion, the clinical and psychiatric presentation was consistent with Lausanne-Franz syndrome. Management. Primary goal of management was to stabilize the mood, reduce psychotic symptoms, and address the cognitive deficit. Secondary goal was prevent relapse and ensure functional improvement. On the day of admission, patient was aggressive and violent. The patient was admitted in male psychiatry ward and the family members were psychoeducated about the patient's condition. On day 1, to assess the severity of mania, YMRS scale was administered and score came out to be 32, which indicates severe mania. On the day 1, pharmacology acute phase, patient presented with behavioral disturbances, lack of cooperation and absence of insights. For rapid tranquilization, injectable antipsychotics were given. On subsequent management, post-sedation, the patient was managed on injectable for 2 days. After that, he was treated with the following oral medication: tablet sodium valproate, which is mood stabilizer, tablet olanzapine, which is atypical antipsychotic, and tablet lorazepam, benzodiazepine. Clinical monitoring and assessment. On day 3, 5, and 7, YMRS score was done. On day 3, it came out to be 28, day 5, 22, and day 7, it came out 18. Progress during hospital stay. Initially, the patient was uncooperative with no insight. However, gradual improvement was observed with treatment. By day 7, the patient became cooperative with grade 2 insight. Outcome and discharge. Patient showed significant improvement and was discharged on day 7 with the same medication regime. Follow-up in psychiatry OPD department was advised after 15 days. On follow-up details, on day 15, patient came to OPD where further reassessment was done. Reassessment in OPD, patient reported 50 to 60% improvement in psychiatric symptoms. Medications were continued without any change. Additional observation, father reported poor academic performance. So psychological evaluation was done. because it was not done during hospitalization because he had active psychopathology. So after 3 weeks when patient became stable, then we sent the patient to psychologist for IQ assessment. It came out of 58, which indicates mild intellectual disability. Interventions initiated on follow-up, psychoeducated, conducted for both the patient and family, focusing on understanding the condition and coping strategies. Therapy initiated, CBT, cognitive behavior therapy, to address the emotional regulation and adaptive behavior. Physical observations, features of high arch palate, arachnodactyly, tall stature, and hyperextensible joints were noted, suggesting a possible genetic syndrome. So patient had the psychiatric symptoms, in mostly predominantly mood symptoms. So psychiatric diagnosis was mania first episode. IQ assessment was done, which indicated mild intellectual disability. On physical examination, he had long slender fingers, arachnodactyly, hyperextensible joint, long narrow face, and tall stature. So this triad was there. So we took pediatrician's reference, and pediatrician, they advised urine panel for inborn error of metabolism, which came out to be normal. They advised genetic testing, but due to financial constraint, family members denied. On second follow-up, after 30 days, we advised them to continue CBT sessions. Ongoing medication was continued, and patient reported 75 to 80% improvement in psychiatric symptoms. Medication were tapered down. Therapy session continued. We advised them to come after 30 days for further assessment. Discussion. Luzan-Franz syndrome, also known as X-linked mental retardation with Marfanoid habitus syndrome, is a rare X-linked genetic disorder caused by mutation in the MED12 gene, particularly then PN1007S missense mutation, which disrupts the MED12 protein, a key regulator in gene transcription and development. Diagnosis can be made based on clinical features when genetic testing is unavailable. The syndrome is characterized by distinct craniofacial features, including a prominent forehead, long narrow face, maxillary hypoplasia, small mandible, long nose with a high and narrow nasal bridge, short deep philtrum, thin upper lip, highly arched palate, receding chin, and low set retroverted ears. Neurological and developmental features include agenesis or dysgenesis of the corpus callosum, hypotonia, developmental delays, mild to moderate intellectual disability, and hypernasal speech. Marfanoid features such as tall stature with a disproportionate arm span become more pronounced after puberty, reflecting the syndrome's progressive nature. Behavioral disturbances may also occur. Developmental delay and hypotonia are more evident during early childhood, while Marfanoid features emerge in adolescence. The syndrome exemplifies a complex interplay of physical, neurological, and developmental abnormalities. In this case, patient was advised for genetic testing but was denied by family due to financial constraint. However, Luzan-Franz syndrome is a clinically diagnosed condition characterized by a unique combination of craniofacial dysmorphism, Marfanoid habitus, neurological features, and intellectual disability. While genetic testing can confirm the diagnosis, it is not always necessary when clinical features are evident. Thank you.
Any questions from floor? So I was just going to ask, you haven't had genetic testing, and I wondered, do you have some support for these patients to offer them genetic testing, or do you have to be, they have to be self-funded always?
Actually, ma'am, when this patient first presented to us, they were more worried about psychiatric symptoms, about mania, that first you treat the psychiatric symptom, then we will think about genetic condition, because they were not bothered about genetic condition. But when we counseled them, they belong to lower socioeconomic status, and it cost around 18 to 20,000, so they were not affordable. But next time whenever they will come, we will take support from our management, and if we can do it for free of cost, then we can publish this case report and we can confirm our diagnosis also.
Okay, thank you.
Thank you, ma'am.
I request Dr. Sumit Patodia to please felicitate Dr. Manju Bhaskar. I request the chairpersons to please stay back through the whole session. We just have 2-3 more speakers. Our next speaker is Dr. Nitin Khoteta, Professor and Head, Gastrosurgery, Mahatma Gandhi Hospital.
Right? Sure? No, I think it's fine. Robotic liquor. No. Unit. Okay. 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 So one and then second I'll present. So good afternoon everybody. So I'm a surgical oncologist here. I'm not a gastrosurgeon for correction. And I'm going to present 2 cases here, rare cases to be presented. So this patient who presented to us has a large cystic swelling in the upper neck, and it was diagnosed on evaluation imaging as well as on FNAC as a lymphangioma, which is very rare. So we report in a case of adult lymphangioma localized in the neck, and so, this is a congenital benign pathology, the lymphangioma in young kids, which is 1.2 to 4 per 1,000 newborns. And most commonly, it occurs only in children, mainly in head and neck area and oral cavity. Rarely, the presentation is in adulthood. So fewer than 150 cases has been reported in the world literature for adult lymphangiomas. It arises from an embryological defect that consists of an abnormal connection from the jugular sacs, and the diagnosis is done by imaging technique, that is ultrasound and CT scan or MRI scan. The treatment of choice for these cases are complete excision. So this male, which is 57-year-old gentleman, presented for a swelling to us with the swelling in the neck in last 1 year, and last 6 months there is a substantial increase in the size, with no other associated signs and symptoms to this patient. No comorbid conditions. On evaluation, he was found to have a 58 into 32 millimeter sized cystic swelling in the upper neck, and FNAC was done, as we oncosurgeons do FNAC in these cases to diagnose what these swellings are. It appeared on FNAC as a benign cyst in favor of lymphangioma. This is the imaging which shows very clearly, this is the photograph. You can see here, this is the cystic swelling in the upper neck here. And this is the part of the mandible that is seen, maxilla, and this is the part of the swelling which is seen very clearly adjacent to the carotid vessels and the IV, internal jugular vein. The treatment of choice for these patients with adult lymphangioma is to do a complete surgical excision. Though the structures nearby are like common carotid artery, tail of parotid gland, and internal jugular, big veins and arteries are there, but a careful dissection has to be done in these cases to give them cure of this disease, because there is a chance of recurrence if you leave the part of cystic cavity there. So this is the surgical photograph which shows this 8 centimeter cystic swelling in the upper neck, and the dissection has been completely done, and a complete removal of the cyst was done in this case surgery. The histopathology proved to be a lymphangioma composed of large irregular lymphatic channels lined with bland endothelial lining filled with eosinophilic proteinaceous fluid, that is lymph. So the incidence of lymphangioma in newborns is 1.2 to 2.8 per 1,000 newborns. There is no gender predilection, and 60% are present at birth, and up to 90% are detected at the age of 2 years. More than 90% are congenital. But adult lymphangioma is very rare, and till now only 150 cases has been reported in the world literature. Theories are given for the lymphangioma to be formed: blockage or arrest of normal growth of primitive lymph channel during embryogenesis, Primitive lymph sac does not reach the venous system, so the lymphatics dilate up and kids present with the lymphangioma. During embryogenesis, lymphatic tissues lay down in wrong area and that proliferates in the neck and that leads to lymphangioma. But in adults, these are all the theories for the kids, not for the adults. So the pathophysiology of adult lymphangioma is not clearly understood till now. And these patients only present with the swelling in the neck, no other associated signs and symptoms because these are cystic swellings, they are not masses, solid masses, and these are diagnosed by ultrasound and CT scan or MRI scan. The treatment of choice for these patients adult lymphangioma is surgical resection. The complication during these surgeries are there because these swellings are near and entangling the surrounding structures like common carotid artery, the fork of carotid artery, internal jugular vein. So the complications during surgery can be of bleeding and hematoma formation later on. And since it is in the upper neck, the facial nerve damage can be there during surgery, which is bigger, it's going in between the nerves like hypoglossal nerve or glossopharyngeal nerve or recurrent laryngeal nerve. So deep nerves may be damaged during the surgical resection. The other treatment options that are present are sclerosing agents and radiotherapy, but these are for very morbid, large lymphangioma which are not excisable or patient cannot, is not operable because of its poor general condition in that case. And so this is all about the lymphatic proliferation malformation that is lymphangioma.
Thank you, Dr. Nitin.
Thank you.
I was just going to ask you, do you discuss these kind of cases like an MDT? I was thinking, this is in the neck, isn't it?
Yeah.
So were you involving the maxillofacial surgeons and ENT surgeons into this?
We do. But see, ma'am, I'm an oncosurgeon. I'm not an ENT surgeon, first thing. So this patient came to us to get this swelling because an adult male coming with the neck swelling, first differential goes to tuberculosis or lymphoma or some primary in oral cavity. In Rajda, the commonest cancer in our part of the world is oral cavity cancer and lung cancer. So we think of metastatic disease in the neck, right? So we also discussed with our ENT surgeon colleagues here also, and everybody thought to go for a surgical resection and do a biopsy because it was a cystic swelling filled with fluid. You don't get a tissue there when you even do a biopsy in these cases. It's not a solid tumor. So that was the plan to go for, complete excision of this tumor.
No. Okay, thank you.
I'm
You
presenting
got
my
another case
yeah,
as well.
Yeah, that's what. I did that. So this second case which I'm presenting is very interesting, how the genetic study changes the surgical plan of the patient. That is the theme. So 53-year-old female presented to us, she's post-menopausal, hypothyroid since last, full screen, it's not, sorry. Is it? Yeah. So she's hypothyroid since last 1 year on thyroxine with no family history of malignancy. OG history is okay, breastfeeding of 16 months of the kid, no history of hormonal therapy. And she had total abdominal hysterectomy with balsasalpine oophorectomy 9 years back for dysfunctional uterine bleeding. We don't have the histopathology report because it was on outside. So she presented to us with a lump in the right breast since last 3 to 4 months, no other associated symptomatology, and no other complaints she had. We investigated the patient and found we do triple test, that is ultrasound of the clinical examination, then ultrasound of the breast and FNAC from the breast lesions. So on ultrasound, the right breast, which was in 23, showed a 28 into 41 millimeter well-defined irregular hypoechoic lesion and at 9 o'clock position of the right breast with speculated margins, which goes more in favor of a malignant lesion or Barrett's 4 as far as ultrasound classification is concerned, and multiple enlarged round to over clustered lymph nodes in the ipsilateral axilla. The opposite breast was normal. So after doing a biopsy, it came out to be invasive ductal carcinoma with triple negative, ER/PR, HER2 positive, negative, all three, T2, N2A, ERPA stage, and she was BRCA positive and stage 3B. So why we do BRCA in this, I'll tell you in the next slide, because she was triple negative breast cancer, and triple negative breast cancer has around 15% chance of BRCA positivity, right? So the plan was, we discussed the case in our multidisciplinary tumor board, where we have a medical oncologist, radiation oncologist, and a team of all oncology experts together with us. And it was planned to go for, since she was having locally advanced breast cancer, she was planned for neoadjuvant chemotherapy 8 cycles, followed by reassessment for surgery and then follow-up. So our plan, we proceed with the same. We gave 8 cycles of chemotherapy, followed by right modified radical mastectomy. Generally, if it is not BRCA positive, we just treat the diseased breast. But since she was BRCA positive, we had to do a left mastectomy because she was BRCA1 positive, where the chance of having breast cancer in opposite sides is up to 70%. So that's how a change of the plan was there from BRCA because she was positive. So the histopathology was, since she was given chemotherapy before surgery, there was no tumor in the breast. It all dissolved, it all melted down because of chemotherapy. We say it a complete response to the chemotherapy. Right? So pathological complete response was there, but there was no viral tumor in the right breast, and the regional lymph nodes which were pre-surgery on investigations were positive on radiology also, were also negative. So conclusion was the patients with triple negative breast cancer have a BRCA mutated probability of 20 to 25%. BRCA1 and BRCA2 gene studies, gene positivity, have likelihood of developing breast cancer, ipsilateral contract up to 60 to 70%, endometrial cancer up to 40%, and in the whole family we talk prostate cancer and pancreatic cancer in the range of 10 to 12%. So that's the importance of genetic study, because now we can recommend the whole family also about this screening test regarding other sites of origin of these diseases, and that's why we had to do a left mastectomy. And because she was previously operated, the total abdominal hysterectomy was done. Otherwise, we would have done salpingo-oophorectomy simultaneously also in this case because she was BRCA positive. So the criteria for BRCA genetic mutations are breast cancer diagnosed before the age of 45 to 50 years, cancer in both breasts and relative having BRCA positive, male breast cancer, triple negative breast cancer, breast ovarian cancer syndrome, and if the family, there is a strong family history of prostate cancer and pancreatic cancer also, we prescribe them to go for a BRCA study to confirm the genetic mutations. So there are a lot of meta-analysis and work has been done. We know everything about the BRCA testing in practice now. So the conclusion is that in triple negative breast cancer, we definitely advise these patients BRCA positivity to do BRCA test to know the BRCA positivity or not, is there or not, so that we can ask them to screen further, them as well as their family, do prophylactic surgeries also if needed. We can recommend them, we can guide them, counsel them. Thank you, ma'am.
Any question you want to ask?
No, just a comment that, this particular entity became very popular after Angelina Jolie, I think.
Yes,
most people
true.
are aware of this. But my query was that you also mentioned about pancreatic cancer, so
Yes.
which means that the patients after surgery also need to be followed up for pancreatic
absolutely.
cancer.
So cancer patients, we call them up till 10 years of follow-up. So our protocol is that first 3 years, every 3 monthly follow-up, next 3 years, every 1 yearly follow-up. 6 monthly and then 1 yearly.
Will it change with particular diseases?
Sorry?
Will it change with particular diseases or the follow-up plan?
No, it remains the same.
Remains
but patients who are positive with BRCA, we have to be more, cautious
Aggressive,
about it.
or
And we have to
you-
counsel them properly.
Yes.
That any symptomatology you develop, please come as early as possible. And they are diagnosed, like we do screening tests like ultrasound, abdomen and all in these patients on follow.
Actually, with a lot of other oncological lesions also, this germ cell mutations are quite not unusual, I will say. They're getting better recognized and their close follow-up of the family members becomes extremely important.
Like MEN syndromes
I
are
know we had a case with RUNX1 mutation in a family with multiple cancers actually, and this patient after chemo also continued to have thrombocytopenia. So then we realized that the mother who was going to be the donor actually, she had RUNX1 mutation.
True.
This kind of thing, people are getting more aware these days.
Like thyroid cancer we are getting, MEN syndromes we are getting, then colorectal FAB syndromes are there.
Yes.
Familial adenomatous polyposis. So a lot of syndromes are coming now, Leaf-Ramney's and all.
Sorry, just wanted to know, what about the family? Since these patients are paying themselves, do they get their family screening as well for BRCA1?
Not all. We counsel some of the patients, they come definitely. We have schemes and health schemes in our state also.
Yeah.
So they also help for that. And in college
So-
also, like our institute does help these families also.
So have there been family members within her family to screen for it?
Yeah, yeah.
Yeah,
I have got a family which they have got 6 patients with prostate cancer at the age of 40 years, and they are BRCA positive.
Good, thank you.
Thank you.
Anything else you want to ask?
Thanks to the epitome surgeons like Dr. Nathan Khoteta sir, people like Nazul Singh Sidhu come on the stage and they say lemon tea cured their wife or so after a successful surgery. Thanks to you, sir.
Thank you, Dr. Nitin Khoteta, Professor and Head, Robotic Onco, Surgical Oncology. I stand corrected. I request Dr. Reena Das to please present a memento to Dr. Nitin Khoteta. Our next speaker is Dr. Saurabh Singh, Associate Professor, Department of Neonatology, Mahatma Gandhi Hospital.
First of all, I would like to thank organizing committee for giving me an opportunity to present before such a distinguished and knowledgeable teachers. So my case is a newborn with hyponatremia. So the baby was a full-term baby, term male child, 3.1 kg, non-consanguineous parents, and uneventful antenatal and postnatal course. The baby was discharged on day 3 of the life. The baby presented to us on day 9 with poor feeding, lethargy. Baby was having severe dehydration with 16% weight loss, and baby was progressing to shock. Baby was having bradycardia, irregular heart rhythm, and the notable absence was of there was no diarrhea or vomiting. So now the differentials which we thought on day 9 if a baby present with shock. So the first thing which comes in everyone's mind is sepsis. But in a full-term baby, sepsis is so rare that we should think twice before diagnosing sepsis in a term baby. Instead, we should think about inborn error of metabolism, congenital adrenal hyperplasia, cardiac causes. So on physical findings, the baby was normal in appearance, no dysmorphic feature or skin abnormalities, normal male phenotype, no evidence of hyperpigmentation. So when we did electrolytes, there was severe hyponatremia, sodium was 110, and hyperkalemia, the potassium was 9.8, with metabolic acidosis, and the renal function was suggestive of pre-renal azotemia, and the blood glucose was normal. Other tests like infection screen, ammonia, they were normal renal ultrasound and sterile urine cultures. So our case is having severe hyponatremia with hyperkalemia. So it means aldosterone must be involved in this. So this was our thought process that either aldosterone deficiency is occurring. So most commonly we think of congenital adrenal hyperplasia or adrenal hypoplasia, or it could be due to resistance. So keeping congenital adrenal hyperplasia in mind, the baby was started on steroid, inotropes, 3% saline. We have to give high doses of 3% saline. 20 to 25 millicurie per kg per day, and potassium binders apart from other hyperkalemia protocol, other medication. And potassium binders were given 6 gram per kg. So the usual dose, as you know, is 1 gram per kg. But to our surprise, 17-hydroxyprogesterone, cortisol, ACTH, they all came normal. So now we thought that if deficiency is not there, are we dealing with the case of pseudo-hypoaldosteronism? So aldosterone levels, they came very high. Aldosterone was more than 1000 nanogram per deciliter, and renin was also markedly elevated. So there was a pseudo-hypoaldosteronism. Aldosterone levels were very high, but the baby was not responding to our treatment. So we tried high dose of fluorocortisone in this baby. The usual dose is 0.1 milligram per kg, but we tried 0.4 milligram per kg, and after that you can see the electrolytes, they have started responding. The sodium became normal and the potassium levels came down. So in the pseudo-hypoaldosteronism, there are different types. Either it can be systemic pseudo-hypoaldosteronism or it can be a renal pseudo-hypoaldosteronism. The systemic pseudo-hypoaldosteronism has got a worse prognosis, and then it can be secondary pseudo-hypoaldosteronism also if there is some kidney abnormality or pyelonephritis, but that we have ruled out by normal renal ultrasound and sterile urine cultures. So then we did exome sequencing in this baby, and SCNN1A gene mutation was found, which is responsible for autosomal recessive type of pseudo-hypoaldosteronism, type 1, and it is a systemic form, multiple organs are involved, and it doesn't improve with age, and it has got a worse prognosis than the renal form. The renal form, it is restricted to kidneys only, and it improves with age. So with the help of this whole exome reporting, we were able to counsel the parents, and we were able to counsel them in their future pregnancies also. So it has got autosomal recessive, the autosomal recessive pseudo-hypoaldosteronism, it affects epithelial sodium channels, and that's why the aldosterone can't act, and that is why we have severe hyponatremia with hyperkalemia. The potassium is also not able to excrete, and that is why we have severe metabolic acidosis. So the baby was discharged. The baby was discharged on high dose of 3% saline per sodium supplementation per day, on oral soda bicarbonate, potassium binders, and fluorocortisone. So the take-home message is the diagnosis of sepsis in the full-term neonates, we should think twice. We should think of inborn error of metabolism, congenital adrenal hyperplasia, that should be high on our cards. Hyponatremic dehydration is not always simple. Sometimes it can be a genetic puzzle. And genetic testing is very important. It can refine our management and counseling of the parents about the prognosis of the baby, and it can help in the future pregnancies also. Thank you.
Thank you, sir, for the wonderful talk. This shows the importance of newborn screening. It should be provided to every mother, every newborn born in the nursery, especially in the tertiary care center, a full panel newborn screening. If we do for 100 newborns, we might get 3 to 4 newborns with some rare diseases at our tertiary center. So I know here in Mahatma Gandhi, it is being offered to every newborn which is born here. So that's a great thing.
Thank you.
Thank you, Dr. Saurabh. I now request Dr. Gaurav Agarwal, Associate Professor, Department of Pediatrics, to present his case.
Thank you, ma'am. Thank you, organizing committee, for providing this opportunity. And good afternoon, respected chairpersons and audience. So here is the case. This was an infant with abdominal distension. So this was the male child who presented at the age of 7 months, born from non-consanguineous marriage, and it was from Rajasthan only. Chief complaint was of abdominal distension since 3 months, not gaining weight and not able to sit with support. Also there was fever since 5 days. Parents were complaining about the child not achieving milestones as per the other previous child. Also history of fever on and off, low grade and relieved on taking medications. Multiple consultations were taken in past 3 months for progressive abdominal distensions in periphery, but there was no significant relief. Child was also treated for fever on and off, history of 2 packed cell transfusion for low hemoglobin at the 4 months of age. Then child came to Mahatma Gandhi Hospital for further management and evaluation. So in antenatal history, there was severe oligohydramnios, gestational hypertension was present, and the child was born preterm with a birth weight of 1.8 kg. However, there was no NICU stay, prolonged NICU stay, and there was no history of any adverse event during NICU stay. Presented to us with the immunization up to date till 7 months of age, and no similar complaints were present in parents and siblings. So the child was exclusively breastfed, and we looked in child for the other negative histories. So there was no history of jaundice, no history of vomiting, constipation, or any clay colored stool. There was no excessive crying, no complaint of seizures, no dribbling of urine or crying during micturition. There was no history of any fractures or bleeding manifestations. Then on examination, child was alert, active, conscious, and recognizing parents, also vitally stable, and there was no pallor icterus cyanosis, lymphadenopathy or clubbing. The only thing is weight was 4.2 kg, expected was 7.2 kg at the age, length was 63 centimeter, expected was 67 centimeter, and the head circumference was 43 centimeter. So child was having failure to thrive. In head to toe examination, eyes appeared to be bulging. There was blue sclera, protruding tongue, and abdomen was distended. Rest all was normal. So then we came to the systemic examination, and in systemic examination, abdomen was distended. Liver was 5 centimeter below the right costal margin, and the span was 8 centimeter. Spleen was 3 centimeter below the left costal margin. Genitalia was normal, and there was no abnormality detected in central nervous system, cardiovascular, and respiratory system. So till now, what we got from the history and clinical examination, it was 7-month-old infant born at 35 weeks with low birth weight, with antenatal history of severe oligohydramnios, gestational hypertension, with complaint of abdominal distension, failure to thrive, and recurrent fever. On examination, there was hepatosplenomegaly, bulging eyes, protruding tongue, blue sclera, and motor developmental delay. History of 2 blood transfusions in the past. So what can be the provisional diagnosis with these findings? What we thought of was it can be hematological, as there was 2 blood transfusions, hemoglobinopathies, or it can be leukemia, lymphoma, malignancy. Since it was preterm with low birth weight and developmental delay, it can be torch infection, HIV, or hepatitis B. Hepatomegaly, hepatosplenomegaly was present. It can be storage disorders or galactosemia. Surgical causes rare, choledochal cyst, hepatic tumors, and polycystic kidney disease. And since blue sclera was present, it also favors towards osteopetrosis, osteogenesis imperfecta, which are also favored by the presence of anemia and hepatosplenomegaly. So we went for the investigations, and we found that hemoglobin was 9 gram per deciliter. Others in CBC was found to be normal. However, in PBF, it was microcytic hypochromic anemia, platelets were adequate in number, and there were no spherocytes and elliptocytes seen. Reticulocyte was only 1.2%, SGOT was raised, it was 1364, that is 1364, and SGPT was 701. In triglycerides, only 181 milligram per deciliter, rest of the investigations were normal. So as per our differential diagnosis, now we went for the specific investigations. MP by CAR test was not detected, urine routine was normal. For galactosemia, urine reducing sugar was negative. HPLC for hemoglobinopathies, no abnormal hemoglobin was detected. Similarly, TORCH, HCV, HBsAg, HIV were found to be non-reactive. USG, no surgical cause was found, only hepatosplenomegaly, and blood and urine culture were also sterile. Now again we came to the same scenario where is the diagnosis. Now if we see for differential diagnosis, we can see that there was no hemoglobinopathy, PBF was normal, no malignancy, TORCH, HIV and hepatitis B non-reactive. Also there was no history of multiple fractures and X-ray was also not supportive of. So this was also ruled out. Then galactosemia, reducing sugar, urine for reducing sugar was negative, and abdominal ultrasound did not reveal anything. So we were left with storage disorders, which can be any of the lysosomal or glycogen storage. So according to that, we went for again ophthalmology detailed examination. So cornea was enlarged, bluish sclera, and no cherry red spot was found. Rest of the examination was normal. So we, in view of the megalocornea and blue sclera, we kept our diagnosis for to be metabolic liver disease. So liver histopathology invasive now test was done. For this liver histopathology, we found that here we can see that the cells in the center are foamy cells, histiocytes. This is not. This is working. So these are the foamy histiocytes, and they are surrounded by the normal hepatocytes. So if we see it in magnification, we see that foamy cells are present and normal hepatocytes are present. Now this is the pass staining. In this we can see that these histiocytes are not taking any pass stains. This means they are pass negative and they are surrounded by normal histiocytes. So we came to one conclusion that it is metabolic liver disease, and since it is pass negative, it favors towards the lysosomal storage diseases. So genetic study was done, and in this we found out that it was SMPD, sphingomyelinase phosphodiesterase gene affected. It was autosomal recessive and found to be Niemann-Pick disease type A or B. So what this is defect in sphingomyelinase phosphodiesterase gene, and it synthesizes acid sphingomyelinase enzyme found on chromosome 11p15.4. So this is sphingomyelin. This substrate is acted upon by acid sphingomyelin in lysosomes to convert it into ceramide and phosphocholine. So now when acid sphingomyelin is absent, as in Niemann-Pick, there is accumulation of sphingomyelin in lysosomes of all the parenchymal cells, and get these cells are stored in spleen, liver, lung parenchyma, bone marrow, neurons and kidney. So all the organs are affected. Now if we see, there was Niemann-Pick disease type A and type B and intermediate. So type A is rarer than comparing to A, B and B. So here according to clinical features, we found out that ours was favoring towards type A because there was loss of skills and there was regression of milestones. Hepatosplenomegaly was present by the 3 months. Still we were missing the cherry red spot. So again we called the patient in follow-up, and we saw that now delayed milestones, there were more delayed milestones, regression of milestones was occurring, bilateral cherry red spots were present, abdominal girth was increased, and now liver span became 14.2 centimeter, spleen of 10 centimeter below the costal margin. So finally we concluded that case belongs to Niemann-Pick disease type A, but still enzyme test was pending. We will be doing that. So birth prevalence of Niemann-Pick disease type A is found to be 0.4 to 0.6 per 1 lakh of the population, and combined frequency of A and B is 1 per 2 lakh 48,000. So now specifically test for acid sphingomyelinase was done. It was 1.49, whereas normal should be more than 3. So this deficiency was favoring towards Niemann-Pick disease. Now, for management part, what to do? So this is the olipudase alpha. This is recombinant human acid sphingomyelinase enzyme. This is exogenous source of acid sphingomyelin. It was approved by US Food and Drug Administration in August 2022. Drugs Controller General of India, this is still pending. So when we came across this case, we tried to find out whether it has been reported in Rajasthan or not. We found out that it was the first case of Rajasthan of Niemann-Pick disease type A, which was genetically proved and enzymatically proved. So we mailed to the DGCI and approval is still pending. So this is the literature we came across, that it was approved by August 31 in 2022. Now the thing is, this drug needs first loading dose, and after that it needs to be given IV in every 15 days. So this happens to be costly drug. We are still awaiting for the government to give approval for it. And there is one portal by the name of Raj Sambal, that is rare disease crowdfunding for Rajasthan. We have empaneled the patient in that, and we are waiting for the betterment.
Actually, whenever you get splenomegaly, which is like undiagnosed, I think the suspicion should be very high, and a bone marrow examination is a very easy way of getting to the diagnosis, because the liver biopsy and all you need, especially when the liver enzymes are so increased, so somebody agreeing to do a liver biopsy also will be difficult, but bone marrow is easy. So our pediatricians always ask for a bone marrow whenever they find any differential diagnosis like that. It is of course very rare and difficult to manage, but the diagnostic part, easy test would be the bone marrow.
Yes, you are. This is very correct. But in that case, still we are in dalmia whether we are undergoing any, because of hepatosplenomegaly, we are undergoing any malignancy. So to rule out that, liver biopsy is still required.
Bone marrow is enough.
Yes.
Thank you, Dr. Gaurav. Such an interesting case and very well worked out here in Mahatma Gandhi. Thank you.
Thank you, Dr. Gaurav. I request Dr. Dhavendra sir to please come up and do the honors and felicitate our speakers and the chairpersons.
It is an honor to introduce someone who truly needs no introduction in the world of genetics and genomics. A globally renowned clinician, educator, and researcher. He has made landmark contributions in clinical genetics, genomic medicine, and application of genomic principles to precision healthcare. His special interests span a wide range of fields, including inherited diseases of children, cardiovascular genomics, dysmorphology, and evolving landscape of multi-omic medicine. I'm sure by now you all must have guessed whom I'm talking about. Yes, it is none other than Professor Dr. Dhavendra Kumar, Honorary Clinical Professor at the William Harry Research Institution, Queen Mary Institute of London, and a Senior Consultant Advisor at the Polo Genomic Institution, India. Sir is also the founder and medical director of the Genomic Medicine Foundation. Professor Kumar, we are truly grateful for your dedication and hard work in organizing this international conference. Your efforts have not only brought together some of the brightest minds in the field, but also provided us with a valuable platform to interact, exchange ideas, and collaborate on groundbreaking research. This conference stands as a testament to your commitment to advancing knowledge in genetics and genomics, and we are deeply thankful for the opportunity. It is with great honor that I invite you to the valedictory lecture at the conclusion of this prestigious conference.
Thank you, Aditi. It's been real. You have worked so hard for the last few months. I'm really grateful. Again, great thanks to MGU, MST, and all senior and many other colleagues who worked very hard. I think I wanted to give you a message because the theme of this conference, when we decided, we thought about beyond genomics. The beyond genomics, the buzzword is called multi-omics. And I do have a small presentation, but then because of time, I will not. I think I'll just quickly go through. Because Aditi wanted me to say as a farewell lecture or valedictory lecture. So I've got a few things just to convey some message. I don't know whether, is it functioning? Or something else. This is somebody else. No, I think it's not mine. It must be on the list. I'll be very brief. Yeah, this is not somebody else. इसमें लिस्ट में आएगा ना ये पिक्चर पुराना एक सेकेंड I think the next thing now is to really how to integrate all this knowledge into mainstream medicine. You have heard many cases, and because of limitation, the case diagnosis could not be made, or case management could not be planned. Extreme measures of surgery and everything was taken, and many investigations were already taken. So the message now is to next step, that's the integration of multi-omics medicine. So you can see how we all know about, so gene and genome, we talk about a great deal. Essentially, Om is a word which we have got in Sanskrit, Om, and also in Greek language called Omega, Om. Meaning is same, means knowledge. In fact, our word goes beyond knowledge, means welfare. So Sanskrit says Om means, actually Om has got many meaning in terms of expression. So there are many aspects of genome. We talk about genes, we talk about some sequences, but the limit is endless. And when we complete our genome sequencing, we know great deal more about genome. So the word genomics is basically the science of genome is genomics. Now the thing is that now after Francis Crick, who discovered the double helix with Jim Watson, after 3-4 years of later on, he was just talking to friends in a bar. He mentioned DNA just the beginning. And he said, after DNA, we got to think about RNA. So the code word, what you call the central dogma of life is DNA to RNA, RNA to protein. I think very 8th class teaching, I would say biology teaching. If my grandchildren would say, okay, DNA is beginning, RNA is the second word, you can say DRP. Remember the DRP. So center, in fact, many people don't know that. So so RNA stands for transcriptomics, as we know, basic biology. After transcriptomics, it's translation that makes protein. That's where the genetic code of Khorana's code came along. Put together in the cell, we got proteins called proteome, and they make the metabolic environment. That's metabolome. So omics is all about that. And best, you got environment. So we have got diet, we got climate, we got infection, we got all endemic like COVID we had. So our body is reacting in the background of genomic signatures, RNA information, and the protein makeup. So that's our background, which is essentially for all biological creatures, mammals, small bacteria, fungi, small worms, you name it. That's a very basic thing. So omics is an umbrella term which is given to many branches of science. Transcriptomics I mentioned, proteomics I mentioned, epigenomics. Phenomics was mentioned by many speakers. Essentially, phenomics is more important. You heard in his presentation, they were all describing clinical features. Some were very good features. So there is a clinical picture called phenotype. The science of phenotype is phenomics. A clinical person, if he or she does not examine the patient, does not collect clinical features, I would say, sorry, I'm not very happy that you are a doctor, to be bluntly speaking. We are trained as a doctor, our job is to examine a patient, collect information, what we call the deep phenotyping. You also heard the word from the speakers, human phenotype and ontology. Human phenotype ontology. Ontology, nobody knew what's the meaning. Ontology means the science of existence. So something exists on your patient. You have to identify and you have to describe. That is phenotype. So that's the starting point. Microbiomics, as we understand, all microbes around us, inside our body, outside our body, inside our body, all over our body, the science is called metagenomics. And glycomics, as the word indicates, the science of sugars. So one end of glycomics, we know about diabetes. There are many other aspects of the carbohydrate, metabolism. So there are many omics now, many, about 35, 40, something like that. So the core omics stand for, as you can see, genome, transcriptome, proteome, metabolome, and then overall mix makes cellome, plus from outside we got microbiome and epigenetics like toxins and pollutions, all those. In fact, we have no idea how many are there. So these all impact on disease morbid factors, as you can see from this slide, and you can apply to both common diseases and rare diseases. We have many rare diseases, but we should not forget common disease. Professor Dina Das covered common disease, thalassemia, sickle cell. It's one end of the spectrum. If you take the hypercholesterolemia, 1 in 300 people, maybe 1 in 200 people, I mean, they got hypercholesterolemia in the developed world, including India, in fact, has got quite more. So, but common genetic factors are there, or genomic factors there. In fact, omic factors are there in all cases. So this is the model which came out very early on after we started human genome sequencing. Human genome sequence was completed as the Human Genome Project. So this is the sort of thing we do every day in our practice. As you know, many labs are offering all these services. We got genetic testing available in the background of conventional testing. The question comes, do you want to go conventional testing in all cases? For example, I give you an example. A baby born, floppy baby born. I mean, the old books, when I did my MD pediatrics, the old books had 20 different tests. You start from one end to the other end. But if you did genetic testing, you know where to go, what to test. You not go for unnecessary thing. You not go for unnecessary MRI, like Dr. Suri mentioned, showed very MRI pictures of brain. Very complicated. Many MRI diagnostic radiologists, they do not know. I'm sorry to say that. They don't know how to read pediatric MRI. But genetic background will help them. So the multi-omic medicine is here with us. It is the future. The best application of multi-omic medicine is in cancer, oncology, and they are using it, as you know, you might have heard the word called tumor board assessment. So in America and other places like in Tata Cancer Hospital, so every single case is analyzed, investigated, and then discussed before they start treatment. And now those days have gone when you had vincristine or chlorambucil, all those chemotherapeutic agents, you're just hoping it will work, No, it's too late. You have to identify the genetic receptor, gene change receptor, target, and plan accordingly. There are endless of now agents for cancer treatment. So message is that one size fits all, forget it. Go for very predictive target-based therapy. So I will close on this point. So the present-day medicine has to be personalized, has to be precise, has to be predictive, has to be preventive, and we have to act fast before disease goes out of control, preemptive, and allow families and patients to participate. That is the message. So I think with this, I will stop here. And one more, slide I can just show that this thing. Now this is a workflow in a modern lab in USA, in our place. Here also, I think Genome has got, there was a poster in the stand today in the stall. They are offering multi-omic analysis now. And then this is a workflow. But if you look at what is important, very important thing is that examine the patient, collect information, phenomics. So I think that is, there are many things to discuss about that, but I will leave the message here. You also heard the word AI, because data will be generated. The more you sequence, the more you have data. You have no clue. You need a very powerful system to analyze. That's where AI will come, as Dr. Bert de Vries from Holland mentioned today, and also optical genome technique also. So there are many papers on AI available now. If you just go and read on the newspaper. So this is, of course, this requires research. That's another model for research. And I know CSIR, ICMR, they have got no such priority for multi-omic research. That's my observation. So this is the landscape as we talk about. And so this is, we have to always keep in mind the human variation. That's what Professor Osler in Oxford said way back in 1892. So I think I will leave the message here. Again, once again, thank you very much for hosting this conference. And always remember, when you see a patient, I know it is very expensive, availability, cost. That's why I think in the beginning we talked about the Center for Excellence, where the government has already allowed 50 lakh rupees per patient. So we have to harness that. I mean, it is not fair that 12 centers only in a large country of 1.4 billion, 1.45 billion people. I mean, when you've got 36 states, you know, I said to governor, and as I was telling governor what to do, but I mean, I hope one day you'll have more centers of excellence, more access. Thank you very much. We'll leave this talk on the system so that it will go on alongside the conference proceedings, so that anybody can go and look at, you know, because if you're planning research, you need all the information and references. I mean, the research is the key, definitely. You need to have research in all areas, whether it is oncology or neurology, even gynecology, endocrinology, you name any field. So that's it's a large, the research opportunities here are great, really great. Thank you. Okay, Aditi.
Thank you so much, sir. As a gesture of gratitude, if I can invite all from the audience to please come on the stage and give a small token of Jaipur and ICBD to Professor Dhavendra Kumar. So, please. As the organizing secretary of this conference, it is both an honor and a privilege to express my heartfelt gratitude to all those who have made this event a success. Firstly, I would like to thank Dr. Achal Gulati, Dr. Ashok Gupta, and Dr. Hemant Malhotra for trusting in me with the role of secretary for this important conference. Only if I can thank Dr. Dhavendra Kumar and Dr. Anju Kumar for placing their faith in me and supporting my contributions to this conference. Your encouragement has been a constant source of motivation for me. Sir, gratitude is all I have for the two of you. I would also like to extend my sincere thanks to Dr. Priya Marwal and her dedicated team, Dr. Gunjan Agarwal, Dr. Nikita Pal, and Dr. Trapta Goyal, for their exceptional efforts in organizing the scientific sessions. Your attention to detail and hard work has truly made this conference a memorable experience. To all the speakers, delegates, faculty members, students who have contributed their time, expertise, and insight, thank you for enriching our sessions and making this conference a truly impactful one. A special mention to our international delegates for traveling to Jaipur for their invaluable participation. I'm deeply grateful to my new friends at the institution, Dr. Vaibhav Upadhyaya, Dr. Tushita, and Dr. Kedar Negi for their constant support and assistance in every aspect of the conference. Your help has been indispensable in ensuring everything ran smoothly. Our sincere thanks also go to Mahatma Gandhi Hospital for providing the venue and allowing us to host this conference at such prestigious location. Finally, a big thank you to the sponsors, event management team, transport team, and audiovisual team for their professionalism and tireless efforts in ensuring a smooth flow of our conference. Your hard work behind the scenes have not gone unnoticed. Thank you to each one of you for your time, efforts, and dedication in making this conference a success. I look forward to continued collaboration and learning from all of you. I would like to end this conference by saying, Alvida nahi, bas fir milenge kisi aur mode par. Meaning, not a goodbye, just see you again at some turn of the world. Thank you, ladies and gentlemen. I would request everyone to please rise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय जय जय